குழந்தைகள் நலப்பிரிவின் சார்பாக இங்கு கூடியிருக்கக்கூடிய மாணவ மணிகளையும் மருத்துவ நிபுணர்களையும் வருக வருக என அன்போடு வரவேற்கிறோம்.
It is with great pride and immense joy that I welcome you all to the Pediatric Pearls 2025, our much anticipated continuing medical education program hosted with a dual purpose: to enrich ourselves academically and, most importantly, to honor the extraordinary career of a legendary pediatrician, Dr. P. Kumaran sir, our respected Deputy Superintendent. Today's CME is not just a scientific session, it is a celebration of a legacy. Dr. Kumaran sir has been more than a pediatrician. He has been a teacher, mentor, administrator, and above all, a compassionate healer. His journey has touched countless lives, from infants in need of care to students in pursuit of knowledge and colleagues seeking guidance. I would also like to extend a warm welcome to all our senior pediatricians, distinguished family members, postgraduate and undergraduate students. Your presence enriches this occasion. A special note of gratitude and welcome to all our invited speakers and expert pediatricians who have joined us today to share their knowledge and pearls of wisdom. Once again, I welcome you all and thank you for being a part of this very special day. Now I request our HOD sir, Dr. Arunachalam, to give a welcome speech.
Plan to start the program by it's half an hour late. It gives me immense pleasure to welcome you all to Pediatric Pearls 2025, a continuing medical education program proudly hosted by the Department of Pediatrics, Government Thuthukudi Medical College. The CME is not just an academic gathering, but a celebration of science, service, and leadership. At the heart of today's event is a humble and heartfelt tribute to a person who has inspired generations of pediatricians, Dr. Kumaran Annan, a name synonymous with excellence in clinical practice, academic mentorship, and visionary administration. His multifaceted contribution to our department, from strengthening the clinical infrastructure and modernizing teaching methodologies and building a cohesive pediatric team, continues to serve as a benchmark for all of us. We are fortunate today to be joined by eminent speakers, passionate educators, and dedicated clinicians who will be sharing knowledge of some of the most relevant and evolving topics in the child health. Each session has been thoughtfully curated to bring practical insights, reasoned evidence, and innovative approaches to everyday pediatric practice. I would like to take a moment to acknowledge our organizing team, resource persons, and supporters whose combined efforts have made this day a possibility. To all our delegates, thank you for your presence and enthusiasm. Your engagement is what transforms a program into a meaningful learning experience. Once again, on behalf of the entire department, I warmly welcome you to Pediatric Pearls 2025. May this be a day of learning, reflection, and celebration. Thank you.
Thank you, sir. We'll now start our first scientific session on the topic of type 1 diabetes mellitus basics and beyond by Dr. V. Kumaravel sir, pediatric endocrinologist. Sir is the director in the Department of Endocrinology at Alpha Hospital and Research Center. Sir has done many publications like role of serum thyroglobulin levels in differentiating hyperthyroidism and thyrotoxic phases of thyroiditis. And he also done a publication on association between ACE gene insertion deletion polymorphism with the diabetic peripheral neuropathy and its importance as a genetic biomarker. We welcome you, sir. And this session will be chaired by Dr. Vellaipandiyan sir, Senior Pediatrician and retired HOD of Pediatrics, Thuthukudi Medical College, Dr. Padmanabhan sir, Senior Pediatrician, Medical Superintendent, Thuthukudi Medical College, Dr. Arul Prakash sir, Senior Physician, Endocrinologist, Indira Diabetes Center. We now request our speaker and chairpersons to occupy the dais.
Good morning to one and all present here. On behalf of the chairpersons, I thank the organizing team for giving us the opportunity to sit in front of you. So this topic is really an interesting topic. In 80s, usually it is an uncommon topic. Nowadays it is not uncommon. So you must be very aware of this problem, because most of the time this type 1 diabetes will present as ketoacidosis. So unless you have think of that problem, we may have to lose the child. So it is very important, and the recently evolving new topic as far as pediatric is concerned. With this, over to the speaker.
Good morning, respected chairperson, organizers, Dr. Kumaran sir, my friend Dr. Marimuthu, and my dear friends. I think the topic which I am going to discuss today is type 1 diabetes, basics and beyond. I understand we have started half an hour late. I will try to finish in half an hour so that you can save some time for the future speakers also. So this is going to be the overview of my talk. I am going to discuss regarding the basics of type 1 diabetes, how do you define diabetes, and what is the pathogenesis of type 1 diabetes, symptoms and signs, diagnosis, and the treatment of type 1 diabetes. This is something basic which all of us has been doing regularly, and to go beyond the basics, there had been recent understanding in our pathogenesis of diabetes which really paves the way in prevention of diabetes, and monitoring strategies have changed and treatment modalities are evolving. I will try to touch upon the newer treatments which are available for us, and I would also try to touch upon the future which is very promising with us. So we all know we have diabetes, we have various types of diabetes, type 1, type 2, gestational diabetes, and other forms of diabetes. So the classic teaching is that type 1 diabetes occurs in children, and usually they are lean, and most of the patients present with diabetic ketoacidosis. But now with the advent of various screening tools and awareness, we see most of the children, even they have type 2 diabetes also, but type 1 diabetes is basically caused by an absolute lack of insulin. The peak incidence is somewhere between 10 to 14 years. And type 1 diabetes again is subclassified into 1A and 1B. 1A where you have autoimmune type of type 1, and 1B we really don't know what is the reason, which you call as idiopathic cause. So the clinical presentation and treatment is more or less the same. The only difference is that in 1A you have antibody markers which is positive, 1B the antibody markers which are negative. So as I said, the most important factor which differentiates between type 1A and 1B diabetes is the presence of islet autoantibodies. So whenever you say type 1A or 1, it is more or less synonymous. It is the usually well-known type with a relatively rapid onset, and the autoimmune process can be suspected even at preclinical stage. So this is the very important period where you can intervene, where prevention strategies could be applied. And there is something called latent autoimmune diabetes in adults, which occurs in adults, which presents like type 2 diabetes, but basically it is a type 1 diabetes, a slow onset type 1 diabetes, what we call it as LADA. And type 1 diabetes may be non-insulin dependent in some stages. For example, you diagnose a patient with diabetic ketoacidosis, treat them with insulin. After discharge, sometimes you are able to reduce the dose of insulin, you may be even able to stop insulin. So this is called honeymoon period in a patients with type 1 diabetes, and especially in pre-diabetic stages of type 1 diabetes, they may not require insulin. As I said, slow onset type 1 diabetes or LADA, initial stages they may not require insulin. So this is in crux about how your type 1 diabetes behaves. Pathogenesis of type 1 diabetes, for type 2 we know insulin resistance is the key event, then you have beta cell dysfunction. On contrary, the pathogenesis of development of type 1 diabetes, you have various stages. You have a genetic susceptibility, which on top of environmental trigger, which causes islet autoimmunity, which in turn causes islet cell destruction, where you have loss of insulin secretion and overt diabetes. The reason why I have given some gap here is that at the onset of autoimmunity to loss of insulin secretion, you have various other stages. So this is a very, very crucial period where you can intervene to prevent even type 1 diabetes. And the symptoms of type 1 diabetes, commonly what you call this as polyphagia. Human short acting insulin is the regular insulin what is available. Human long or basal insulin we call it NPH insulin or lenti insulin. Analog insulin we have ultra short acting or a prandial insulin we have aspart, lispro and glulysin. And analog long or basal insulin we have glargine, detimer, we have degludac. Of course we can give this short acting and long acting mixture separately, and sometimes they are available as pre-mixed insulin. We have pre-mixed human insulin, pre-mixed analog insulin. The pre-mixed insulin comes with a fixed combination of short acting and long acting. We have 30/70, which means 30 is going to be a short acting component, 70 is going to be a long acting component. We have 50/50, where 50 is going to be a short acting and another 50 is going to be a long acting. Once I decide what insulin has to be used, next thing is how is that I am going to space for my patients. So what are the insulin regimens which is available? So the best regimen which could be available is that you give 3 short acting insulin for your food. So you have a prandial insulin cover 3 and you have a basal insulin which covers the overnight. So this is called basal bolus regimen, and this is the gold standard which is very easy to titrate. But the problem with type 1 diabetes is that many of the children would be going to school, taking insulin for 4 times may not be practically feasible. So they would always want the another alternate regimen to be given for the patient. So where we give 2 short acting insulin, or a long acting component, which could be a pre-mixed, or you can mix a short acting and long acting, so which becomes 3 injections. Another commonly which is used is you give 2 pre-mixed insulin, one for the breakfast and one for the dinner, or you can give a short acting and long acting in the morning, short acting and long acting in the night. If necessary, you can have a short acting in the afternoon or evening if the patient is going for the school. So these are titrated as per the patient needs, convenience and the glycemic profile. But the best thing would be the basal bolus regimen, where they have a mealtime flexibility. But whatever regimen you use, higher the prick, the control is better. Lesser the number of pricks, the compliance is better. So we should know the what prick or what regimen would suit for our patient. Ultimately, the target which has to be maintained for most of our patients would be before meals or before bedtime, it should be roughly between 100 to 180. That is what is the target which is required. And postprandial, they don't have a targets basically because children it is very difficult to titrate the diet. So any blood sugar you see should be less than 200 in a child, and your HbA1c should be less than 8. And the HbA1c cutoff keeps on changing for your adults based on the age group. So for a toddlers and school going children, your bedtime insulin and a before meal should be less than 180, and your HbA1c should be less than 8 without the risk of hypoglycemia. So this is the basics of type 1 diabetes. We have defined type 1 diabetes. We have seen the basic pathogenesis. We have seen how do you diagnose it. We have seen what are the insulins which are available and how we are going to do it. Now moving beyond basics. So basically what happens, we discuss type 1 of insulin producing beta cells of the islets of pancreas. Not everyone's beta cell gets affected by your type 1 diabetes. Though everyone is exposed to the same environmental insult, everyone are living in the same environmental area, not everyone develops type 1 diabetes. So that's a strong genetic component. So approximately 50% of the risk of disease arises from the genetic component. When I say genetic component, it could be a HLA or non-HLA mediated. So you have various HLA genes like DR3 and DR4 genotype, they confer a higher risk for type 1 diabetes. Non-HLA genes like insulin genes, CTLA4, PTPN22, and you have various named genes which basically act on your DNA regulatory sequences of the immune cell, and they again play an important role in how we react to an environmental insult. So this two things forms a basic genetics. So we have various genetic markers to see who are the patients who would be predisposed to type 1 diabetes. So environmental triggers, commonly we have seen there are certain harmful triggers, there are certain protective triggers also. So probably harmful triggers, we have seen enterovirus infection and even obesity, high birth weight, all rotavirus and various glutens, and COVID-19. After this COVID-19, we had a sudden spike in type 1 diabetes. So basically what happens, there is something called molecular mimicry, where your cell membrane protein of certain viruses resemble your islet cell protein. So whenever you start developing antibodies against the cell membrane protein, they cross react or they can destroy your beta cell. So this is molecular mimicry concept, how your viruses can cause type 1 diabetes, or your viruses can directly destroy your beta cells. Even these things are also possible. So one, direct destruction by the viruses, or your immune reactions which destroy your beta cell, where your viruses could be just the innocent bystander. The unlikely causes, which even your influenza or childhood vaccination, your formula feeds, usually they do not cause type 1 diabetes. The possible protective effects, breast milk, probiotics, vitamin D, omega-3 fatty acid and gut microbiota. Basically they form a very positive role in protecting a patients from type 1 diabetes. So this data was basically generated from a baby diet study, which is a very interesting study where they noted the children who got more than 3.7 infection within 100 days. The probability of them developing type 1 diabetes was much higher. So when you are exposed to multiple viral or bacterial infection, the chances of them cross-reacting with your beta cell or the immune destruction is very highly possible. So the next thing, once when you have a environmental insult, you have a immune mediated destruction, what you call as isletitis. So we have various proteins or various antibodies. The newer antibody what has been seen is a zinc transporter 8 antibody, which is supposed to be very specific, or at least 80% of those patients with new onset type 1 diabetes have a zinc transporter protein antibody defect. Initially we were doing only GAD. If the GAD antibody is negative, we say it is type 1B. But basically GAD antibody could be negative, but other autoimmune markers could be positive for them. So that is one reason where we are trying to look at various antibody panels which could be helpful. You might be asking me, why is that you need 5 antibodies? If one antibody is positive, you are going to call it type 1 diabetes or autoimmune destruction. And what is the role of so many antibodies to be tested? I'll just tell you in my forthcoming slides. So based on that, you can stage type 1 diabetes. You have a genetic risk, you have a immune activation, you have an immune response, and once after the immune response, you have various stages where you have a normal blood sugar, abnormal blood sugar, then you have a clinical diagnosis and long-lasting diabetes. So from immune response to stage 1, you have various preventive strategies which are available. So if you are able to catch them much earlier, you will be able to prevent type 1 diabetes. You have oral insulin which has been tried, which is something like a vaccination concept which has been tried. You have immune effects of oral insulin. You have drugs like abatacept, you have teplizumab, and you have various other battery of drugs which has been tried, and even rituximab has been even approved for prevention of type 1 diabetes. So who are the patients whom you can use for this prevention? You can tell me. In our practice, we cannot do a genetic study. So what else could be done? So if a patient is diagnosed with type 1 diabetes, siblings, or whenever you think a patient is high risk for type 1 diabetes, you look at various antibodies. If they have more than 3 antibodies positive, the probability of them developing type 1 diabetes is roughly around 80 to 90%. So they should definitely be intervened. If there is only 1 antibody positive, the probability is roughly around 20 to 30%. 2 antibody positive, the probability is around 40 to 50%. So these antibodies in a sibling of a patient with type 1 diabetes, or in a family member of patients who is at high risk for type 1 diabetes, you can see them and early intervention could be done. So this is something beyond what we have understood, beyond our basics. The next thing in type 1 diabetes, we know we have discussed about insulin regimen, but basically what guides your insulin dose is your glucometer blood sugar. It's very difficult for a child to have a regular venous plasma sample every time. So venous plasma sample is generally done, we do it once a month. Once in 3 months we do a glucometer, we do a HbA1c, and sometimes we do fructosamine once in 2 weeks. But routinely they are monitored with glucometer. The ideal recommendation is at least 4 times a day. So depending on the patient's convenience and the practicality, they do it regularly. So now what happens, this glucometer, the difficulty is that you have to prick it very frequently. So to counteract that, now we have a continuous glucose monitors. So this continuous glucose monitor is nothing but like a, which is patch. You can see the red arrow. It is a size of a 1 rupee coin. We can put it here. You can have a reader, or nowadays most of these patches comes with a Bluetooth connectivity with your mobile phone. So you can just scan it with your mobile phone, Android phone or app phone. That will give you a reading continuously for 24 hours, and this one patch could be used for 14 days. So which means for 14 days only 1 prick is enough. They can take bath with it, they can play with it, usually sweating, nothing happens to them. And most of my type 1 diabetes has been using this thing, provided financially it is feasible for them. And this continuous glucose monitoring costs roughly around 5,500 rupees for 14 days. It is definitely feasible for many of the patients when they have very high blood sugar. So now I will show you one patient. So this patient is on Humalog insulin, which is nothing but a Lispro insulin, 10 units which is short acting in the morning, 6 units in the afternoon, and night the patient is on Humalog mixed insulin, which is a pre-mixed insulin of short and long acting, 14 units. Now this patient you see put on continuous glucose monitoring, he has a nocturnal hypoglycemia. Suppose I check with the glucometer, I might miss most of this nocturnal hypoglycemias. So whenever I check the blood sugar in the morning, it's roughly around 200 to 300. So I presume this patient's blood sugar is still in the higher side. So I am tempted to increase the dose of insulin. So now what happens when you see the continuous glucose monitor, it is hypoglycemia. The clue for this is that whenever I check the HbA1c for this patient, it is normal. Because hemoglobin A1c is the average of your blood sugar. So whenever you have a high fluctuation in blood sugar, your HbA1c is going to be normal. So whenever you see a patient with disproportionate hemoglobin A1c and the sugars what you have seen, definitely continuous glucose monitoring has to be considered. So based on this, what we did is, I didn't change the morning dose of insulin. I just reduced the night dose of insulin from 14 to 10. You can see the nocturnal hypoglycemia happens at least 6 hours after taking the premixed dose, which means the long-acting component is acting more. So I want to reduce the long-acting component. What I did is just reduce the human insulin 25/75 to 50/50, which means 50% becomes a short-acting, 50% becomes a long-acting. So after that, you can see your pattern totally changes. So this continuous glucose monitoring gives you an immense clue for you to decide what exactly could be suitable for our patient, and based on that, it also gives you a mean average blood sugar. You can have an estimated average blood sugar also could be seen. So as I said, this is a typical regimen which is used for most of our patients based on your continuous glucose monitoring. But frequent pricks could be difficult for our patient. So one, you have a eye port where you have a patch like kind of thing, so you can keep on injecting insulin in this thing. So this eye, but the problem with eye port is the probability of getting infection is very high with this eye port. But some patient it could be selectively used. So the next advancement in type 1 diabetes is the insulin pump. I would say this is the gold standard for management of type 1 diabetes. You have a pager-like device. So this is the pager-like device which has the insulin, and you can see the picture there. You have a tubing where you have a needle, and this insulin pump delivers the insulin continuously. And this set has to be changed once in 3 days. Again, the prick is going to be just 10 pricks in a month, not more than that. So the advantage of insulin pump is that your basal insulin you can keep on changing. For example, when I give a long-acting insulin twice a day, I am going to give 10 units in the morning, 10 units at night. For every hour, this is going to be act the same. Suppose I want the long-acting insulin component to stop in between. I need a long-acting component to be increased a dose. This is possible with the insulin pump. You can see the basal insulin, I can keep for 0.4 units per hour. I can keep for 1.5 units per hour. I can even suspend the thing. And you have bolus component separate where I can take it. Whenever I take breakfast, I can take a bolus. And whenever I take a lunch, I can take it. Whenever I take a dinner. So the flexibility is very high. And you get a best of the best control with the insulin pump. Now the latest with insulin pump is that we have a sensor augmented insulin pump, where you have a CGM sensor which I showed you before, and you have a pump. So whenever you have a hypoglycemia, the pump gets suspended. So you need not be worried about hypoglycemia, and pump gives an alarm whenever the blood sugar is high. So you are able to control the best in blood sugar control with this insulin pump, which is very easily available, and these things are very much available within our scope, and we have been using this for most of our patients. But whatever insulin pump we use, whatever best insulin we use, insulin is not going to be a cure for diabetes, because you are just replacing insulin which is there. So beyond type 1 diabetes, whenever you are trying to look at cure for diabetes, even in 1922, when in Banting's lecture he said, insulin is not a cure for diabetes, just a treatment for diabetes. So we are always looking at a cure for diabetes, and even the gold standard DCCT study which suggests tight glycemic control prevents the diabetic complications, but however it does not replace the pancreatic beta cell function. Now how do you replace the pancreatic beta cell function? One, I can give various immunotherapies whereby my pancreas becomes resistant to destruction. So I can protect my pancreas, or I can replace my pancreas. Now what are the immunotherapies which is available? You have various immunotherapies where you have islet peptides which has been used, which basically tries to suppress your immune mediated mechanism. It tries to recruit more and more of protective genes, protective immunomodulators. So all these things makes our type 1 diabetes patients, or makes our patient more resistant to immune mediated destruction. The second thing which has been commonly used, though it's off label, is a BCG vaccination. Probably when you try to compare the Western standards, type 1 diabetes in India is much less. So one reason has been postulated is because of the high incidence of tuberculosis, and there are some data which suggest BCG vaccination could be protective in terms of your beta cell, and even in patients with type 1 diabetes, insulin requirement has been coming down. So when immune therapy does not work, you are going towards a beta cell replacement. Now how do you replace the beta cell replacement? You can have a pancreas replacement, islet cell transplant, beta cell regeneration, or you can go with xenotransplantation where you take beta cells from some other organ. So the islet cell transplantation, the concept is very simple. You have a pancreas which has both endocrine and exocrine cells. You take the pancreas, you isolate your islet cell, which is basically an endocrine cell, and it is infused in a blood bag kind of thing into the portal vein. So this islet cell gets dislodged into your hepatic sinusoids and it starts secreting insulin. And you have very strong data pre-transplant, post-transplant, blood glucose control is good. Even after 5 to 15 years of follow-up of islet cell transplantation, insulin independence has been achieved. There is reduced fear of hypoglycemia with islet cell transplantation, and diabetic complications have come down with the islet cell transplantation. Your nephroprotection and your retinopathy protection has been seen with islet cell transplant. But the problem with islet cell transplant is the supply of islets. For example, for a patient to have one islet cell transplant, you need at least 3 pancreas, and it is very difficult. So people have started looking at xenotransplantation, where they have looked at pig transplant from pig pancreas. The advantage is that it's unlimited supply, it's very easy to breed, and the physiology of organs is more or less similar. For some reason, pigs and humans are more closely related in medical field. You had pig valves which has been used initially, and initial insulin we had from pigs, and we have pig omentum which is used for burns dressing and so many things. And there have been lots of genetic resemblance between your pigs and humans, so most of the things would really work. And another thing is that once when you transplant islets, you should make the islets survive. So like rejection, so you improve oxygenation for the islets, where you have a transplanted islets in a pouch, and you have a microanastomosis which increases the vascularity of the islets. Another way to increase the vascularity of islets is that with the islets, you co-culture islets with the plant algae. So basically your plant takes the carbon dioxide and releases oxygen. So when you co-culture it, so this oxygen which is released by your algae makes your pancreatic islets survive, so there is not much of hypoxia. And when you go beyond, you can also do immunoisolation of the islets, where you take your beta cell, expose them to various toxins. You put them on streptozotocin, you put them on naloxone, you put them on cytokines, most of them will die. 2 or 3 islets will be resistant. You take the resistant islets, do a mass protection, and then you transplant it. And another dream in a beta cell replacement is that your stem cell, you have adult stem cell and you have embryonic stem cells, and there have been some data of stem cells which has been tried in both type 1 and type 2 diabetes. Basically this stem cells can trans-differentiate to either your beta cell. Your alpha cell can trans-differentiate to a beta cell, your acina cell could trans-differentiate to a beta cells. Similarly, your stem cells could differentiate to endothelial cells, and it could send signals to protect your beta cells. All those things are possible. So I think I will not go beyond this, and I will stop my lecture with this. The final message is that type 1 diabetes is never a dreaded disease. So all these celebrities are type 1 diabetes. You have a type 1 diabetes patient who is a triathlon champion. You have a Mr. Universe who is type 1 diabetes. You have Miss America with type 1 diabetes. You have so many living examples with type 1 diabetes. So I think the people need not be bothered because they have a type 1 diabetes. I know it's a disease, but it could be easily controlled. They can definitely have a normal quality of life, provided they are motivated, and it is our responsibility to motivate our patient. And thank you so much for the opportunity.
Thank you, sir. Your lecture was very lucid, and you have been being an opening batsman. You stayed in the crease for a shorter period and delivered a maximum score. And we really appreciate the type 1 diabetes basics and beyond. And we learned a lot of things from you.
I hand over mic to the Arun Prasad sir.
So, is there any question and answer session now? So, any questions from the postgraduates? Yeah. Okay. Before everybody, tries to think about some questions, I can just add few things. I really sincerely appreciate Dr. Kumaravil for really justified his role from basics and beyond. Of course, it's a vast area to explore. And to add a bit, there are two things I would like to emphasize. So he talked about, now the people are talking about AI in every area of medicine, including this topic. And FDA has approved this Medtronic insulin pump without doctor's intervention to you do not set the insulin dosages. And you can just load the basal and bolus or whatever insulin rate. You need not set that. The insulin adjustment will be done by the machine itself. So there is no need for doctor intervention. You just put in that machine and it will take all over. It has been FDA approved. It has been validated. But now, and the second important thing, the prevention aspect, he talked about that. And again, then artificial intelligence coming down. So he said that during the pathogenesis, there are genetically prone people with HLA, non-HLA, certain type of genetic background, and the viral infections and antibodies, subsequent antibodies, islet cell antibodies, or insulinomod-like antibodies. So people have found that the registries in Teddy's study, I'm just quoting a study because the postgraduates may be interested to know that. So from the infant, with this particular background of genetics, they were taken samples at the age of 3 months, 6 months of the babies. They were not diabetic, yet to become a diabetic, of around 800 people. And at least 15% of the people became type 1 diabetic eventually. And they, before knowing that, they took samples from the blood, they did some metabolic biomarkers, immunology, and etc. And 14% of the people changed to become type 2 diabetic. And then you have a preventive scope. So the best decision was made at the age of 9 months. We can predict which baby will develop type 1 at the age of 6 years. You can predict at 9 months of a baby. And you have a large window to intervene with your immunomodulators or whatever. So A is coming in a big way to help us, because we, as human, we can have only 6 parameters to comprehend. And if you have any more than 6 or 7 parameters to work with, we get fumbled. But the AI does a great lot of things. So, but it needs to be validated just for information.
Sir, if after managing acute management of DKA crisis, we will be switching IV to insulin to subcutaneous insulin thrice a day, then how should we change it to split mix regimen, sir? How long we can take, whether we have to achieve full blood glucose control, or how should we switch over to split mix, sir?
Yeah, madam, basically how it holds good is, once when the patient is stabilized with IV insulin, we calculate the total daily dose of IV insulin. So based on that, you put them on your short acting and long acting insulin. Suppose a patient IV insulin, the requirement is roughly around 30 units per day. So which means the normal dictum is that 50% is going to be short acting and 50% is going long acting. So which means 15 units is going to be a basal insulin. Another 15 units is going to be a prandial insulin. So if you are taking 3 times, it will be 3 prandial. So I would put the patient on 5 units of short acting insulin 3 times and 15 units of basal insulin. So this would be the requirement. If suppose I am going to give 3 times a day, so which means that 15 units of long acting insulin I may give 7 in the morning, 8 in the night, and the short acting would be the same 5. So where the common practice in GH or government hospital is that you give a short acting, long acting mixture in the morning, short acting, long acting mixture in the night, and a short acting in the afternoon. So that's how human insulin are 5, and human insulin N would be roughly around 8 in the morning and 7 in the night. So this would be just a starting dose. The same thing will not hold good for every patient. Then depending on the glycemic profile, you increase or decrease the dose. The final requirement could vary for each patient. But the thumb rule is that you calculate the total daily dose and then split 50% into short acting and 50% into long acting. 50% short acting should be divided 3 times. So all short acting analogs are more or less same, sir. For example, whether you take Aspart or whether you take Lispro, it is more or less the same. So now you had Glulysin and Fias. The advantage they claim is that they are much faster in action and the duration of action is very short. For example, you want to take your breakfast and take your insulin, your ultra short acting would be useful. As far as the long acting analogs, Lantus and Detimer was there. Now they claim Tresiba has a more or less as steady state. So they claim slightly edge for Tresiba insulin compared to your Lantus insulin. And I am sure next we are going to have Icodec insulin, which is a once weekly basal insulin. So that will be launched within 2-3 months. So which means basal insulin will be only once a week. Prandial insulin you can take depending on the food what you take. But more or less each analog is more or less similar. It depends on your comfort and your experience.
So you'll be starting at 1 units per kg per day of regular insulin. How can we titrate and how will we knowing the requirement for that child? As you have mentioned, when we calculate 30 units, it's half for a short and long acting. My question is, within a span of 2 days, how will you come to a conclusion that the child's requirement is only so and so, whatever may be, when we start at about 1 units per kg per day of regular insulin?
Yeah, so if the patient is already admitted with DKA, so you have put the patient on IV insulin, so 2-3 days you would have been monitored, so roughly you know per 24 hours how much they would require. But the challenge happens is when the patient is not in DKA, presenting with you just weight loss and polyphagia and you see the blood sugar of 500. So in such scenario, probably you can use it 1 unit per kilogram body weight. And generally when you feel the child is thin built, you can start with 50% of the dose and then gradually uptitrate. Because the uptitrating and downtitrated insulin can be done once in 2 days or even you can do it daily. You have a glucometer profile and you can uptitrate and downtitrate. Because the initial aim is to prevent ketosis. Second is to bring down hyperglycemia, but without hypoglycemia. So whenever you are in doubt, you can start with 50% of the dose and then gradually uptitrate. So within 2-3 days, nothing is going to happen.
My question is, how will you come to a conclusion about the dosage for that child?
So for example, you have a child of 10 kgs.
Yes,
so this child would require 10 units per day. So which means 5 units would be the basal and 5 units would be the prandial. So I might give, say, if you want to give twice daily insulin, I may give say 6 units of premixed insulin in the morning, 4 units in the night. This is going to be just the starting dose, first dose. Then based on the glucometer value, I might increase the dose for breakfast or lunch or dinner. Does this answer your question? No.
Thank you, sir.
Thank you, sir. Thank you, sir. Diabetes is a BB topic for all the practicing pediatricians out there. It is a bread and butter topic for all. Sir has escalated this to next level of BB through explaining it from basics and beyond, clarifying it big and better. It was a ticking diabetes session of this special occasion of celebrating our pediatrics BB, big boss of our pediatrics department, Dr. Kumaran sir. Thank you for this astonishing first sixer session of the day, sir.
Now, it's time to honor our wonderful speaker, pediatric endocrinologist, Dr. V. Kumaravel sir. I request Senior Pediatrician, retired HOD Department of Pediatrics, Dr. Vellai Pandian sir, to honor our speaker. I now request our speaker, sir, to honor our respected chairperson, senior pediatrician, Dr. Vellai Pandian, sir. I now request our speaker, Dr. Kumaravel, sir, to honor our senior pediatrician, Dr. Vellai Pandian, sir, with a memento. Now I request our medical superintendent, senior pediatrician, Dr. Padmanabhan, sir, to honor senior physician endocrinologist, Dr. Arul Prakash, sir, with a memento. I request endocrinologist Dr. Arul Prakash, sir, to honor our respected MS, sir, Dr. Padmanabhan, sir, with a memento. Thank you, sir.
Next, we move on to the second session. Nephrotic syndrome, newer insights. This topic is to be delivered by Dr. Susan Udup ma'am, who is a pediatric nephrologist working as a professor and head in pediatric nephrology department, SAT Hospital, GMC, Trivandrum, Kerala. She is having 27 years of PG teaching, and ma'am had published 12 international journals and 17 national journals. We welcome you, ma'am. This session will be chaired by Dr. Ramasamy sir, who is a senior urologist, the Professor Dr. Rajan sir, retired HOD, Department of Medicine, Thuthukudi Medical College, Dr. Pavalan sir, HOD, Department of Orthopedics, Thuthukudi Medical College. We invite all the chairpersons to the dais. Over to the speaker, ma'am.
Welcome, madam. As you know well, nephrotic syndrome is not that much uncommon, little common also. The incidence is at 2 to 7 per 1,000 lakh populations. Unless we address it properly, they landed with the problem. It is more common in children and in adult also. It has to be differentiated from acute glomerulonephritis. Nephrotic syndrome is characteristic of massive proteinuria, hypertriglyceridemia, hyperalbuminemia, a lot of complications. That has to be, I think it has to be well taken by ma'am. You are most welcome, madam.
Thank you for that introduction. Respected chairpersons, senior faculty members, colleagues and friends. I bring greetings from Kerala, and today I will be talking on nephrotic syndrome, some recent insights that has happened in the last few years. So in the next 30 to 40 minutes, we will be dealing with nephrotic syndrome based on some cases. So as the chairperson has already said the definition and how much is the incidence and what is the characteristic features, I will not be going in detail. So nephrotic syndrome in children can be primary or idiopathic, that is the cause is not known in 90% of the times, and it is secondary in the rest of it. And primary or idiopathic nephrotic syndrome, 80 to 90% of it is minimal change disease, and rest 10% will be FSGS, mesangial-proliferative GN and all. The problem with nephrotic syndrome is, it is not a disease that comes once and then it is gone. That happens only in a very few percentage. That is a non-relapsing cause. Most often it is frequently relapsing or steroid dependent, and less often it is infrequently relapsing. And luckily, only 10 to 15% of children will be having steroid resistant nephrotic syndrome. And so minimal change nephrotic syndrome, the response is good, the treatment response is good, and the prognosis is good. Whereas focal segmental glomerulosclerosis, they can have a more difficult course with steroid dependence, steroid resistance, and if they are resistant to the treatment, there is risk of end-stage kidney disease. And again, it is like malignancy. It can recur after transplant even. And in between is the spectrum of diffuse mesangial hypercellularity, where 50% response to steroids will be there. A 3-year-old boy presented with swelling of eyelids more often in the morning, which was there for a week, and subsequently it progressed. So it was insidious onset and slow progression. His urine was reducing in amount, and he was passing frothy or foamy urine, and he was gaining weight. And there was no history of any fever or sore throat, and on evaluation he was normotensive, had bilateral pitting pedal edema, there was ascites and genital edema. Other system examinations were non-contributory. So this is the common presentation, that is a progressively increasing edema leading to generalized edema with effusions in 2 cavities when you call it as anasarca. Sometimes there can be genital edema. There can be a preceding history of minor infection, reduced urine output of frothy urine. Gross hematuria and hypertension are uncommon, but uncommon means it can be there in some cases, and rarely peritonitis can be the initial presentation. So with the clinical presentation of generalized edema and frothy urine, that is very classic, that frothy urine, that will help you to actually tell the mother to look for the urine, whether it is frothy at home rather than again sending it for testing each time when you are following up. And the lipiduria is classic, that is the oval fat bodies that may be seen in the urine, and this is how usually the diagnosis will be suspected. But we have to take a detailed history, that is whether the age of onset, if it is less than 3 months, it is congenital, between 3 and 1 year, it is infantile, and usual age is 2 to 6 years, and consanguinity may be there. A family history is always very important, and low birth weight, that is also important, because a LBW baby with less number of nephrons is having the higher chance of a difficult course of nephrotic syndrome with dependence, frequent relapses or resistance. So oliguria, hematuria, dysuria and all we have to ask. Contact with tuberculosis is important because we will be giving a long-term steroid treatment, and similar complaints in the past. Sometimes it may be unnoticed. This may not be the first episode. And systemic symptoms are very important because secondary nephrotic syndrome due to lupus and other vasculitis and Hinoch-Schönlein vasculitis, IgA nephropathies. Sometimes you may be IgA vasculitis, you may be having rash, joint pains, hematuria. In Alport syndrome, there can be hearing abnormalities. And growth failure also is important, whether the child is growing like peer group. And that is important because there can be underlying chronic kidney disease. And then this history suggestive of complications is very important. That is whether the child is having abdominal pain, hematuria, infections, that is spontaneous bacterial peritonitis, renal vein thrombosis. And the progression of edema has to be also talked about, and growth and development is important, and the immunization status is important. As the chairperson was alluding to, the nephrotic syndrome, distinguishing between nephrotic syndrome and acute glomerulonephritis is very important, because these are the 2 common conditions that present in the pediatric age group with edema and decreased urine output. Nephrotic syndrome, as I have already told you, it is insidious onset edema and slowly progressing to anasarca. Oliguria will be noticed later, and they will be having more ascites, then cavity effusions will be there. Whereas acute glomerulonephritis, the onset is acute, and hematuria is most often a presenting symptom. And oliguria will be there initially, and there will be facial puffiness that is more commonly seen, and the edema is a hard pitting edema in acute glomerulonephritis, whereas it is a soft pitting edema in nephrotic syndrome. And acute glomerulonephritis more often is associated with a lot of volume overload because there is salt and water retention, whereas in nephrotic syndrome it is the reduced oncotic pressure that is responsible for the interstitial edema. So let us go to the index child. His urine analysis showed 4+ protein, microscopy was normal, 24-hour urine protein was 1000 milligram, and blood chemistry, albumin was very low and cholesterol was high. And now with this background, the diagnosis of nephrotic syndrome is confirmed. And dipstick is actually helping us a lot these days, and we should be knowing how to read dipstick. The trace, the negative, the color, as well as the trace, the green color is going up and up. The trace negative is 0 to 15, trace is 15 to 30 milligram per dl, 1+ is 30 to 100, 2+ is 100 to 300, and 3+ is 300 to 1000, and 4+ is more than 1000 milligram per dl. And also to ensure that this test is actually very, very sensitive to albumin and less sensitive to mucoproteins, globulins and Bernstein's proteins, and it is actually less sensitive than sulfosalicylic acid test at lower grades of proteinuria. So with this background, with the baseline investigation, now we have realized that this child is having nephrotic syndrome. So investigations that are required is actually essential investigations which include urinalysis, a complete blood count, blood urea, RFT, electrolytes and total protein albumin and cholesterol, and a tuberculin test because in India tuberculosis is quite rampant, and additional evaluation at onset as well as in relapse is a chest X-ray. Chest X-ray is actually not mandatory at the initial episode if the child is not having a positive tuberculin test or a history of contact is not there or a suspected lower respiratory tract infection is not there. Otherwise, if these are there, we have to take an X-ray. An ultrasound kidney we most often will be doing because we have to know whether the kidneys are normally placed and normal or whether there is an anomaly that is there. But it is an additional evaluation when there is a gross hematuria, suspected renal vein thrombosis, or we are planning for kidney biopsy. And repeat counts is indicated when there is a suspected systemic infection or hypovolemia. And then this baseline investigation that we are doing, we can repeat it later depending on whether the child is becoming more and more edematous or you are suspecting hypovolemia or you are suspecting an AKI, you are giving lot of diuretic and you suspect that electrolyte imbalance like hypokalemia and hyponatremia may come up. And only when there is an associated systemic features are there, complement evaluation, serologies, and then this SLE workup and all will be required. And hepatitis B surface antigen, hepatitis C and transaminases if there is history of jaundice or liver disease. And urine culture is usually not indicated unless there is lot of more than 5 pus per hypor field. So this child was started on daily prednisolone and parents were apprehensive about the use and long duration of treatment with steroids. So how to start treatment and plan follow-up and what is the current guideline? Of course, in the first episode of nephrotic syndrome, starting steroid is never an emergency, that we have to understand. If there is an infection that is there, treat the infection, and at that point of time, you need not start steroid. You can start steroid once the infection is getting controlled. At that point, you have to start, and then you have to monitor the urine daily, and BP and urine output to be monitored daily. Usually, the remission will be achieved by 2 weeks, but sometimes the remission will be by 4 weeks. So the new guideline that has evolved in 2021 and 2022 is the ISPN guideline, which is now endorsing that we have to give 60 milligram per meter square of prednisolone or 2 milligram per kilogram daily, maximum 60 milligram, that is given for a period of 6 weeks. And I would like to endorse that. Don't give divided dose steroid for the 6 weeks. You will make the child really Cushingoid. So you have to give it as a single daily dose in the morning and after food and by 8 a.m. preferably, before 8 o'clock. And then once you complete the 6 weeks, then you have to give 40 milligram per meter square or 1.5 milligram per kg alternate day for the next 6 weeks. The dosage is as milligram per meter square is preferred if the child is less than 4 years of age, because that you can understand when you do the milligram per kilogram and milligram per meter square, actually at young ages the difference will be almost 10 milligram. So you have to give the milligram per meter square if the child is less than 4 years. And also the KDIGO practice guideline is now recommending less than 4 years you can give a tapering dose of steroid for another 6 weeks. That is, total duration of treatment will be around 4 to 6 months then. So this is the current guideline on the management of the first episode of nephrotic syndrome. Then of course the children with nephrotic syndrome should be advised diet and fluid restriction and supportive care. So balanced diet is important, which is high quality protein, high biological value protein. You should not restrict protein. You should not be giving high protein, higher protein than required because of hyperfiltration injury. Calories will have to be normal recommended allowance, and complex carbohydrates should be advised rather than the simple carbohydrates. And the fat should not be more than 30% of the calories, and you will be preferring unsaturated fat. And salt restriction 1 to 2 gram per day. That means 1 to 2 gram per day when you advise, it is actually no added salt to diet. Judicious restriction of fluid. If the child is not edematous, you can give the fluid that is balancing the previous day's output. Whereas if the child is really edematous and the output is very low, you need supplement only the insensible loss, and the rest of the urine output will become a bonus so that you can reduce the weight daily. And more important than fluid restriction is the salt restriction. And no restriction of fruits once the renal function is normal. Usually when you are using diuretic, they will be hypokalemic, so encourage them to take fruits, but fruit with a cover. That is, you are not, don't give fruits that are raw and kept open. And vitamin and calcium supplements and vitamin D and B complex vitamins should be given. So the diet already we have dealt with, and this child, the index child, achieved remission by 3 weeks, and then 6 weeks of daily, 6 weeks of alternate daily, and after completing the 3 months of treatment, steroid was stopped. He came back after 1 month with edema. And so what will you do? You have to rule out associated infection. And remember, one more thing is, when the child is coming for the first time, always tell the parent that this is a disease of relapses and remissions. Otherwise, he will go to the next pediatrician, because you treated, he became good, but the disease recurred. So tell this at the first visit itself. Start full dose steroid if no infection, antibiotics and stress dose of steroid in case of infection. And so again, if the child is relapsing, once you are tapering the steroid, then second time you call it a steroid dependent nephrotic syndrome. This child at the second admission was having massive edema and ascites and oliguria, and what are the management options available for edema, and when will you give diuretics and albumin. So edema in nephrotic syndrome, salt restriction is the first and foremost point, and no added salt to diet in severe edema. Fluid should be restricted, as I have already told you, and prednisolone itself has got some diuretic property and will produce diuresis in 5 to 10 days. And you have to use diuretics. The term is judicious use of diuretic. So the weight gain of around 7 to 10% if it is there, then more than 7% edema, it is an indication for starting, weight gain is an indication for starting furosemide. Persistent edema, then ascites, scrotal edema, genital edema. And contraindication for diuretic is diarrhea, vomiting, and if you feel the child is having hypovolemia. So you always examine for hypovolemia. And it is a paradox, that is, the child is grossly edematous and you are telling that there is dehydration. So how both will be together? So that is, you have to assess for hypovolemia by looking at the blood pressure, the pulse rate, presence of tachycardia, poor capillary refill, a cold extremity, and a big child, it is a postural hypotension. All these are indicative of hypovolemia. So if hypovolemia is not there, you give diuretic, and if hypovolemia is there at that point of time, then you have to give actually fill up. You have to give fluid or you have to give albumin. So there was no hypovolemia, you gave diuretics, but there was no response, no weight loss or diuresis, and so there can be furosemide resistance. What is the reason? The furosemide resistance can be because if you are giving oral furosemide, there can be impaired absorption and impaired this less bioavailability, and the drug has to bind to albumin. Albumin is the vehicle in the blood that takes the furosemide to the kidney. So there is no albumin. So that is why furosemide resistance can be there. You can give double dose of furosemide orally, or you can give IV furosemide until diuresis, or a maximum dose of 4 to 6 milligram per kg per day is the total ceiling dose that you can give for a day. That is 2 milligram per kilogram per dose, 8 hourly. You have to monitor the blood pressure, watch for hypovolemia, and check for electrolytes. Injudicious use of diuretic can actually precipitate acute kidney injury, thrombosis, and shock. So we have to be really careful. So sequential diuretic therapy is also advocated if there is no response to diuretic and the child is not having hypovolemia. You can add on hydrochlorothiazide, you can add spironolactone, and finally you can give metolazone, which will be acting all over the tubules. And if there is no response for the oral, you switch to the IV. And furosemide continuous infusion 0.1 to 1 milligram per kilogram per hour is having greater potency than the same total dose that is given intermittently. And maximum loop diuretics is given, and that fail to induce diuresis, then you call it as refractory edema. So the guideline is now recommending all these points that I have already told you. If you have not given diuretic and fractional excretion of sodium is checked and it is less than 0.5%, you know that there is underfill. So there is edema can be, the two hypotheses is there that I am not going to in depth. One is the underfill hypothesis, which is common in usual MCDs, whereas overfill hypothesis, that is the intravascular volume is already high. And so you have to differentiate between the two, because one, the treatment is actually underfilling, you have to give fluid, you have to give albumin, whereas overfilling you have to give diuretic, and albumin may be detrimental, you may push the patient into pulmonary edema. So differentiating these two is clinical plus some investigation. So clinical, I have already told you, tachycardia, low BP, postal BP fall and all, prolonged capillary refill, a cold shake hand, and biochemical indices also will be helpful. That is, there is the hemoconcentration, elevated hematocrit is there, and the urea is disproportionately high compared to creatinine, and fractional excretion of sodium is less than 0.5%, and urinary potassium index also is helpful, that is urinary potassium divided by urinary sodium plus potassium. If the ratio is more than 0.6, that indicates that there is underfilling of the vascular tree, but the caveat is if you have given already diuretic, the sphena and the urinary potassium index cannot be used. And now the gadget is already there with us. We have become more powerful in assessing hypovolemia, that is by using an ultrasound. You can assess the IVC status, these collapsibility index, that is very, very beneficial in assessing the fluid status of the child. And so this is the recent guideline, the approach to hypovolemia and edema. I am not going into the depth, I will just tell you when to give IV albumin in refractory edema that we are going to deal now. So this article, that is recent guideline, the 2020 guideline on management of steroid sensitive nephrotic syndrome as well as steroid resistant nephrotic syndrome is published in Indian Pediatrics. Please, all the postgraduate students, that is a very good manuscript that will be giving you everything about the nephrotic syndrome. So please read it and mug it up, if I will say, that will help you to know everything in the management as well as assessment theory, everything is there. So albumin in resistant edema, so 20% albumin 1 gram per kg IV followed by IV furosemide 1 to 2 milligram per kg. It is actually at the start, mid and post. If you give Lasix furosemide, that is more beneficial because the car is ready, the albumin is ready to take the furosemide to kidney. So give it together, that will be more beneficial in giving together rather than at the end alone. So give it at the beginning 1 milligram per kg when you have already started albumin and it is on flow, and mid Lasix and post Lasix will be good. So then this is reserved for most severe and symptomatic edema. Hypovolemia, of course, if a child is presenting in shock in the casualty and the child is grossly edematous, you will be giving saline bolus. You will be forgetting that the child is nephrotic syndrome, you will be giving normal saline bolus. Meanwhile, you will ask for albumin infusion, and usually what happens is giving albumin is only going to correct the hypovolemia in these cases, because whatever normal saline you give, it is going to seep into the interstitium further and is not going to remain in the intravascular compartment. So hypovolemia, hypovolemic shock, diarrhea with severe tachycardia and hypovolemia, all this albumin is the treatment that we have to give. Presence of genital edema, prerenal AKI, abdominal pain, that is patient is complaining of severe abdominal pain, whatever you do it is not improving, give one albumin, everything is settled. This is mesenteric ischemia. And then presence of thrombosis. Thrombosis, if it is already diagnosed, you have to give daily or even alternate daily albumin. Disadvantages of albumin I have already told you. If it is an overfill child, albumin is going to be detrimental. It can cause pulmonary edema. There are incidences of children going on to ventilator after giving IV albumin when the child is already in AKI or child is already overfilled. And so this albumin is expensive, duration of action is short, and there can be hyperfiltration injury to the nephron and more nephronal damage, especially in children with resistant nephrotic syndrome. So contraindication, of course, already dealt with, established AKI with fluid overload, risk of pulmonary edema. Some children will develop few relapses, but many of them may have multiple relapses. How to classify nephrotic syndrome with relapse? These definitions are very, very important. You have to learn it from that article I have already told you. What is nephrotic range proteinuria? What is remission? When will you say the steroid sensitivity? What is a stable remission? What is a relapse? Then frequent relapse, when will you say? Dependence, steroid resistant nephrotic syndrome, And these are already there from the beginning, and little more change that has happened is in frequent relapses the time line is little change, that is relapses more than or equal to 2 in the first 6 months of the disease, or more than or equal to 3 in any 6 months, or more than or equal to 4 in 1 year. So this is one change that has come in the recent guideline. Then rest of it, then complicated relapse definition has come in the recent guideline, that is relapse with life-threatening complication is hypovolemia requiring admission, severe infection which can be peritonitis, cellulitis, meningitis or thrombosis. So a complicated relapse, one episode of complicated relapse also is an indication to refer to the higher center or to the specialist. And then another definition has come is difficult to treat nephrotic syndrome. So if the child is having frequent relapses, either frequent relapses are there, or with infrequent relapse if steroid toxicity is there, and such a child, if you have given second line agent and failure of more than 2 steroid sparing drugs. So if all these are qualified, then it is a difficult to treat nephrotic syndrome, and that also should go to the specialist. And another point that is in the recent guideline is significant steroid toxicity, that is hyperglycemia. The HbA1c cutoff is 5.5, and fasting blood sugar is more than 100, and postprandial blood sugar more than 140. Obesity, short stature with low growth velocity, raised intraocular pressure, cataract, osteonecrosis, myopathy or psychosis if it is there. These are all indications of significant steroid toxicity, and child should be taken to the next level. So in the hospital, child developed seizures on 3rd day after admission, and right-sided weakness was noticed. Neuroimaging revealed a superior sagittal sinus thrombosis. CT scan brain will show the empty delta sign. You can see that in this picture, and not empty delta sign, you can see the thrombus there. And also this MR angiogram will be telling you the blocked sagittal sinuses. So various complications can occur in nephrotic syndrome. That is important. Nephrotic syndrome, even though it starts as a simple edema and little bit of facial puffiness, if it is neglected, lot of complications, sometimes it can be life-threatening complications that can be there in some of these kids. So we have to be knowing the complications, we should be picking up the complications in time and treating the complication. So the child became better and was discharged, and prompt pediatric nephrology referral was given to the child in view of thrombotic complication and early relapse after the first episode, which indicate a possibility of FRNS or SDNS. So the indication for referral is onset below 1 year, family history of nephrotic syndrome with hypertension, gross or persistent microhematuria, impaired renal function, or extrarenal features at the onset which tells you that it is not idiopathic nephrotic syndrome, and complications and steroid resistance and frequently relapsing or steroid dependent nephrotic syndrome. So this is a child who presented with steroid dependent nephrotic syndrome with abdominal pain, redness and tenderness, and so you can see the redness over the anterior abdominal wall. So what is the diagnosis? Spontaneous bacterial peritonitis, and so in such situation you have to correct hypovolemia with normal saline bolus because he was hypotensive, and then albumin, avoid diuretics, and 3rd generation cephalosporin is the antibiotic of choice. No role for metronidazole, and at this point you will be coming down on steroids to stress dose. And so various infections, peritonitis, pneumonia, cellulitis and fungal infections can occur, and varicella infection is at another menace that can come, and you have to treat with IV acyclovir, and varicella zoster immunoglobulin is not available, and so you may be giving IVIG, and if a family member is having varicella infection, you have to give prophylactic acyclovir. So long-term complications, steroid toxicity, very, very important. We have already told about that, and if steroid toxicity is there, we have to think of second line agent. And then this I have already told you, entire daily dose is a single dose in the morning before 8 AM, and then you have to monitor for steroid side effects throughout, and if you are giving long-term steroids, you have to supplement vitamin D and calcium also. And then you have to also check blood sugar and serum electrolytes. These are some things that have come up in the recent guideline, that more monitoring for Cushingoid features and better caring for the sugar levels in the child to assess for whether child is developing steroid induced diabetes or hyperglycemia. Then DEXA scan to assess for osteopenia. And so avascular necrosis, myopathy, pseudotumor cerebri, all this we have to be carefully watching in a child with nephrotic syndrome. And so then another point is infection-induced relapses. So ISPN has actually advocated short-term dose of daily maintenance dosing of steroid during the time of infection to prevent a relapse or to sustain remission in FRNS and SDNS, but limited evidence is available on that, and Prednos 2 trial also has shown that it is not very much beneficial. So in the West, this protocol is not followed, whereas in India we are following this protocol, and stress dose steroids is actually 0.5 milligram per kilogram daily as a dose for prednisolone, or if the child is sick and coming, then depending on the procedural risk as well as the stress that is there, you can give a hydrocortisone IV followed by maintenance doses of hydrocortisone 8 hours for a 1 day, and then switch to oral steroid. So vaccination is important. I am actually not going into detail. I will just tell you that right now the protocol has changed. Previously we used to say that you can give vaccines only after stopping steroid. Now it is said that if the child is on alternate day steroid, you can give killed vaccines straight away, and the live vaccines should be given only after stopping steroid 2 to 4 weeks. And also nowadays we are using other drugs like mycophenolate mofetil, cyclosporin, tacrolimus, rituximab. So those drugs, the protocol is a little different. 3 months is the duration that we will be giving as a gap free of those drugs, that is cyclosporin, tacrolimus, then mycophenolate and cyclophosphamide, whereas 9 months is the gap for rituximab. And so second line agents I will brush through fast. The indication is difficult to treat nephrotic syndrome, steroid side effects and resistance. So this difficult to treat nephrotic syndrome defined already, frequent relapsing or high dose steroid dependence with lot of steroid side effects. There is a nice algorithm that is there. If the steroid threshold is more than 1 milligram per kg on alternate days, or more than 1 complicated relapse and significant steroid toxicity in a child with SDNS or FRNS, if these are not there, you go for levamisole or mycophenolate, and if these are there and frequent relapses are there, mycophenolate or cyclophosphamide. And with these 2 drugs, if it is not getting controlled, then you can do a biopsy straight away and do for CNI, that is cyclosporin tacrolimus. If they don't work, or more than 2 years, 2 to 3 years you have given this and still things are not under control, you can think of rituximab. Rituximab has actually come in a big way these days, and right now rituximab is becoming an answer for high dose steroid dependent nephrotic syndrome. But the problem is it is a double-edged sword. It can cause severe depression of immunoglobulin. There will be persistent hypogammaglobulinemia, and child will be subjected to, will be at risk of repeated infection. So you have to choose the patient judiciously for rituximab. So abatacept is also coming up, and so the guidelines have been now laid for steroid resistant nephrotic syndrome also. 2 things are defined. One is initial resistance, that is resistance in the first episode itself, where the problem may be immunological or genetic. You will be doing genetic study in these patients, whereas if the patient was initially responder but later became resistant, it is called late or secondary steroid resistance, and then in that case you have to rule out non-compliance, underdosing, infections, hypovolemia, AKI or thrombosis, and that is called pseudo resistance. Late steroid resistance is a real problem, especially in the adolescent time. These children can become late steroid, late SRNS, and then you do the biopsy, you give CNI. If they respond good, if they not respond, you will give a trial of rituximab. Remember, rituximab is a drug that is good for SDNS and FRNS and less for SRNS. Steroid resistant nephrotic syndrome response to rituximab is only 30%. So we'll be dealing a little bit with the site protection, renoprotective strategies with ACE and ARB or ARB and lipid lowering drugs. The indications are already laid down in the manuscript. You can go for that. And genetics in nephrotic syndrome, it's only for the initial resistance you will be doing the genetic study, not for late resistance. And more than 70 genes are identified. And why you should diagnose genetic nephrotic syndrome? You have to diagnose because that will help to stop all the immunosuppressants. You are actually saving the child from the steroid and other cytotoxic drug side effects. And you will be telling the family that this child is going to progress, will reach ESKD. We will be giving renoprotective strategies only. and once they reach ESKD, a transplant is done and there won't be recurrence after transplant. So these are the points. And one more point I have to tell you, which I actually forgot to tell you, in the current definition of nephrotic syndrome, dyslipidemia is completely taken off. Previously, we used to say that cholesterol more than 200 milligram per deciliter is to be included for defining a child with nephrotic syndrome. Now that is not there. Only nephrotic range proteinuria, edema, and serum albumin levels also. Previously it was 2.5. Now it is less than 3 gram per dl. So these are the few changes that have come up, new insights that have occurred in the nephrotic syndrome guidelines as well as approach. And overall, the disease is old from the Hippocratic era, and the real answers are yet to come. Research is going on, and we hope that we will be having better answers in future. Thank you.
Thank you for your excellent presentation, madam. We make it very nutshell within a stipulated time to cover all. Still a lot of problem with nephrotic syndrome. Whether these, who are all the children need actually biopsy for the kidney to confirm or to further workup?
So steroid sensitive nephrotic syndrome kidney biopsy is not at all required because it is a clinical plus biochemical diagnosis that is there, and if they respond to steroids, biopsy is not required. But if the child is an initial steroid non-responder or a late steroid non-responder, so initial SRNS or a late SRNS, steroid resistance is the most important single in this indication to do biopsy, I will say. Other indications that are already laid down is if the child is already having at the presentation, there is arthritis, there is a skin rash, you are suspecting not nephrotic syndrome but a vasculitis. So lupus, this IgA vasculitis or Hinoch-Schönlein vasculitis. In such situations, if extrarenal features are there, you will be doing biopsy at the onset, otherwise no. And then again is before you give calcineurin inhibitors, that is cyclosporin and tacrolimus, the dictum now is to do a biopsy prior to starting because these drugs can actually produce nephrotoxicity and interstitial fibrosis, striped interstitial fibrosis. So to document that the kidney disease is what and there is already fibrosis, we used to do now, but the guidelines are actually changing, and maybe after another 5 years, people will say that there is no need to do biopsy before starting CNI. But as of now, we are doing for that. Then acute kidney injury occurring during the course of the illness. You don't know what is the cause. You initially thought it is perennial, it is hypovolemia, you corrected that. Then the child is remaining in AKI for a long while, not recovering. So you don't know whether it is an acute tubular necrosis or whether it is an acute interstitial nephritis. So in such situations, there is a need for biopsy. So the biopsy indications are actually very, very limited in nephrotic syndrome. To make a diagnosis, it is not required.
What about the end-stage renal disease the children are having in the later stages, madam? How much of percentage?
So, see, we would like to prevent them from going into ESKD, but those with multi-drug resistant nephrotic syndrome as well as genetic nephrotic syndrome, we can't actually prevent them from reaching ESKD, but we can delay the progression by giving certain drugs to reduce the proteinuria, control the blood pressure, avoid acute insults and infections, that we can do. But these kids who are having a multi-drug resistant nephrotic syndrome, so that is also a new terminology that had come up. We used to say that steroid resistance we define after 6 weeks. We have given calcineurin inhibitor, cyclosporin or tacrolimus. With that also, if the patient is not responding, then we will be telling it is steroid resistant plus CNI resistant nephrotic syndrome. Then another drug you have used, which is mechanistically in its mechanism of action is different from steroid or CNI. For example, you have given rituximab. The child didn't respond, so you know this is a multi-drug resistant nephrotic syndrome. At that point, we withdraw all the immunosuppressants, and we institute we institute the renoprotective strategies with AC, ARB and cholesterol lowering drugs, and tell the parent that see, this patient is going to reach ESKD and we can't prevent it, we can only delay it. Also is genetic nephrotic syndrome, and they do reach ESKD. Around 5 to 10% of children may reach ESKD in a time is 3 to 5 years. If they reach ESKD in 3 years, we call it as, especially the biopsy is focal segmental glomerulosclerosis, we say that it is a malignant FSGS, and the risk of recurrence after transplant is very high in such cases. And right now, even if it recurs after transplant, that is not the end of the story. Nowadays, we can do plasma exchange, as well as we can give rituximab, and we have kids who are actually recurred after transplant but controlled and going on with a normal kidney.
I am Dr. A.S. Babu Kandakumar from Tirunelveli Medical College, Madam. What is the treatment suggested for a late responder? Some other patient may respond at a later time by around 6 weeks. What is the treatment suggested, and how to split the duration into a daily therapy and continuous therapy?
Okay, so the late response, the definition in the recent guideline is, if a child is in partial remission at 4 weeks and you are continuing for another 2 weeks and the child has responded by 6 weeks, you call it as a late steroid response.
Yes,
and remember one thing, if the response is early, the course is going to be more peaceful. If the response is late, most often the child in the future course may become high dose steroid dependent or a frequent relapser, will be requiring other drugs also, second line agents also, and the course is going to be difficult. And such children, when they are going on with the disease for some time, then they can become late steroid non-responders also. So the prognosis is actually little guarded for them. You cannot say that they are as bad as steroid resistance, but they are in between. They may become late SRNS, late multi-drug resistant and can progress, or they remain frequent relapsing or steroid dependent, requiring second line agents, and if they maintain remission with that, good, or if they may require rituximab to maintain remission, and such children are actually at risk of drug toxicity more than the disease problems.
And one more. Therapy to longer periods rather than to first 3 months. And what is your advice and what is your opinion regarding the duration of extension of treatment to 6 months rather than the initial 3 months itself?
Very, very nice question, pertinent one. The ISPN has actually advocated to stop steroid abruptly at 6 plus 6 weeks, that is 3 months. But we actually don't stop it like that. We actually continue tapering slowly, and we may give for 6 months. But if head-to-head trials have not been done, and you cannot really say that whether we are able to avoid the frequent relapsing course by extending the dose, or whether we are giving more steroid toxicity, we are not sure. The KDIGO actually 2021 guideline is recommending less than 4 years is the onset of nephrotic syndrome. They advocate tapering doses of steroid, reducing it to from 1.5 to 1 milligram per kilogram alternate day for 2 weeks, then 0.75 milligram per kilogram alternate day for the next 2 weeks, and 0.5 milligram per kilogram alternate day for the next 2 weeks. So, and 6 weeks continuation has been advocated in the KDIGO 2021 guideline.
Thank you, Madam.
Very good presentation, madam. We urologists are involved only at the stage when the patient is referred to us for transplant. Very unfortunate situation. Though the 5% only go for ESRD, it is very, very difficult to prepare a patient for transplant. The vessels will be small, the donors will be difficult to get. AV fistula is also a difficult problem. Normal dialysis may not work, they have to be on plasmapheresis and other thing. If you give albumin, they go for edema. If you do withdraw albumin, they go for hypovolemia. All sorts of complications are there. So the pediatric nephrologist also will be taxed. Very unfortunate children, but still very few survive. And also they need lifelong support. Unlike other indications for transplant, this sort of people have a continuous process. They must be on not only on cyclosporine, not steroid, and so many other drugs also they need. Very unfortunate children. Thank you.
Ma'am, if a child presents with the signs and symptoms of necrotic syndrome, whether we have to wait till the CBNAT report to start the steroids, or we can start the steroid and alter the treatment after the CBNAT report?
See, you have to definitely wait for the reports. I have already told you, starting steroid is not an emergency. Starting steroid can wait. If the child is coming with an infection, you have to treat the infection and then start. See, the steroid, high dose you are going to give. So we have to actually prepare the child for that. So it is not an emergency, and your diagnosis has to be certain. You don't know whether you are dealing with urine analysis may show some RBCs, plenty of RBCs. Child may be hypertensive. You may be dealing with nephritis. So you have to know the serum albumin levels. You have to know whether the child is already in acute kidney injury. So to define your situation, you need biochemistry. And nephrology is one specialty, which is clinical plus investigation. And it is actually derived from, it is called a physiological chemistry. Nephrology is physiological chemistry. So clinical plus lab.
Ma'am, if we receive a child with hypotension in case of nephrotic syndrome, ma'am, you taught that we can give albumin as a bolus. So how can we give them? Any dose, particular dosage? 1
gram per kilogram is the dose of albumin. But before you give IV albumin, you have to be sure that there is hypovolemia and there is no established acute kidney injury. The creatinine should not be 3.
Yes, ma'am.
And the volume status assessment should be proper.
Okay.
Otherwise, you may push that, because the pipe is, if it is closed, the GFR is going down. At that point, giving albumin may be. So, albumin is actually, you have to use it very carefully and given over a little long time. What we usually do is, in the ER, we will be giving saline bolus, just like any other. But we see that 1 bolus, 2 bolus, the BP will not come up unless it is corrected with albumin.
Thank you, ma'am.
Due to time concern, I request our chairpersons to conclude this session with a final note.
We can move another, presentation, please.
Okay, it's time to honor our wonderful speaker, pediatric nephrologist, Dr. Susan Uthup ma'am. I request Dr. Rajan, retired HOD Department of Medicine, GTKMC, to honor our speaker. With a memento. Now it's time to honor our chairpersons. I request our speaker, Dr. Susan Uthup ma'am, to honor Dr. Rajan sir with a memento. Now I request HOD Department of Orthopedics, Dr. Pavalan sir, to honor urologist Dr. Ramaswamy sir with a memento. Now I request Dr. Ramaswamy sir to honor Dr. Pavalan sir with a memento. Thank you sir and ma'am for a wonderful session. Let us move on to the next session.
Now moving on to the most significant and ceremonial part of today's program, the official inauguration of Pediatric Pulse. This day marks a dual celebration, the pursuit of pediatric knowledge and the honoring of distinguished figure in our medical fraternity, Dr. Kumaran sir. I take great pride in inviting our esteemed dignitaries to the stage. This day marks a dual celebration, the pursuit of pediatric knowledge and the honoring of distinguished figure in our medical fraternity, Dr. Kumaran sir. I take great pride in inviting our esteemed dignitaries to the stage. Our chief guest, Dean Dr. Sivakumar sir, Government Thoothukudi Medical College, Vice Principal Ma'am, Dr. Kalaivani Ma'am, Medical Superintendent, Dr. Padmanabhan Sir, the man we are honoring today, Deputy Superintendent, Dr. P. Kumaran Sir, our RMO, Dr. Silas Sir. We welcome you all. Dr. Vellaipandiyan sir, retired HOD of Department of Pediatrics, Thoothukudi Medical College, to the dais. Dr. Pondravi ma'am, DD Family Welfare, to the dais. Dr. Dhanalakshmi ma'am and Dr. Naren Kumaran sir, to the dais. Our respectable HOD sir, Dr. Arunachalam sir, to the dais. To commence this grand occasion, let us begin by invoking the blessings of our mother tongue and culture. I request everyone to please rise for the rendition of Tamil Thai Vazhku, a symbol of auspicious beginnings. Now I kindly request all the dignitaries on the dais to come forward for the lighting of the traditional lamp, a symbol of wisdom, knowledge and the removal of darkness.
Now I request our respected resident medical officer, Dr. Silas sir, to share a few words about this wonderful vocation, Pediatric Pearls, and to share his experience of working with our legendary pediatrician, Dr. Kumaran sir. We request you, sir, for few words.
அனைவருக்கும் வணக்கம். அதாவது இரண்டாவது முறையாக திரும்பவும் மேடையில் ஏற்றி விட்டிருக்கிறார்கள் சார். குமரன் சாருக்கும் எல்லாருக்குமே நல்ல க்ளோஸ் ரிலேஷன்ஷிப். ஏன்னா சார் வந்து டிஎன்ஜிடியில் இருந்தார், ஐஎம்ஏல இருப்பார், பர்சனலாகவும் எல்லாரோடையும் நல்ல ஒரு கான்டாக்டில் இருப்பார். தூத்துக்குடியில் எல்லா குழந்தைகளையும் அவர்கிட்ட பார்க்காத குழந்தைகளே கிடையாது. அப்படிங்கிற முறையில் எல்லா விதத்துலேயுமே எல்லாருமே சாரோட ஒரு பழக்கப்பட்டிருப்போம். சார் வந்து எல்லா விதத்துலையும் என்னை பொறுத்தவரையிலே எனக்கு நிறைய விஷயங்கள் பர்சனலாகவும் அஃபிஷியலாகவும் சில இதெல்லாம் நான் மாட்டேன்னுட்டு இருப்பேன். சார் வந்து அட்வைஸ் பண்ணி இந்த இதில் நீ இது பண்ணு அப்படின்னு சொல்லி கைட் பண்ணுவார். இன்ன வரைக்கும் நம்மளுடைய மெடிக்கல் காலேஜ் டீன் சாரோடையும் இருந்து திடீர்னு ஒரு இன்ஸ்பெக்ஷனோ ஏதோ வந்தாலும் உடனடியாக எல்லாத்தையும் அரேஞ்ச் பண்ணி கொடுப்பார். அந்த அளவுக்கு அவருக்கு கான்டாக்ட்ஸும் அந்த ஒரு கெப்பாசிட்டியும் உண்டு. சார் வந்து கண்டிப்பாக ரிட்டையர் ஆனாலும் நம்ம கூட தான் இருப்பார். ஏன்னா மெயின் ரோடுக்கு அந்த பக்கம் சார், இந்த பக்கம் நான், அவ்வளோதான். சாருக்கு என்னுடைய வாழ்த்துக்கள். சாருடைய பையனை பார்க்குறேன், ரொம்ப சந்தோஷம். சின்ன பையனாக இருக்கும்போது குமரன் சார் சொல்லுவார், அதையும் சொல்லிடுறேன், எப்பா தயவுசெய்து மெசேஜ் அனுப்பாதப்பா. வந்த உடனே டிங்குன்னு சத்தம் கேட்டோன்னே ஓடி சைலஸ் அங்கிள் அனுப்பியிருக்காரு மெசேஜ்னு தூக்குறான் அப்படின்னு சொல்லுவார். ஞாபகம் வச்சுருக்கீங்களா? அந்த அப்படி சின்ன பையனாக இருந்ததுலேருந்தே நம்ம பார்த்து நம்ம கண் முன்னாடி நல்லா வளர்ந்து இன்றைக்கி ஒரு பெரிய லெவலில் இருக்கார். அவருக்கும் என்னுடைய வாழ்த்துக்கள், மேடத்துக்கும் என்னுடைய வாழ்த்துக்கள். வாய்ப்பளித்ததுக்கு ரொம்ப நன்றி. தேங்க்யூ.
Thank you, sir, for your wonderful words and a great beginning for this inauguration session. Now I request our Professor and HOD, Department of Pediatrics, Dr. Arunachalam sir, to honor our respected RMO sir with a memento. Thank you, sir. Now I request our respected medical superintendent, Dr. Padmanabhan sir, to share a few words about this wonderful vocation and to share his experience of working with our legendary pediatrician, Dr. Kumaran sir. We request you, sir.
Very good morning, one and all. Respected dignitaries in the dais, respected Kumaran sir, my dear professors, elite people in the audience. First of all, I know Kumaran sir for the past 25 years, and he has always touched everybody's life. Students are இருந்தாலும் சரி, இல்லைன்னா நம்ம யார் கேட்டாலும் குமரன் சார் ஹெல்ப் பண்ணாதவங்க இருக்கவே முடியாது. பிகாஸ் he is a crisis manager. Whenever we met in a crisis, we always contact a supreme person like Kumaran sir. நான் அன்றைக்கே சொன்ன மாதிரி குமரன் என்றால் அழகு, அறிவு, அன்பு எல்லாம் சேர்ந்து ஒரே கலவையாக வந்து நம்மளுக்கு அமைஞ்சிருக்கு. இந்த மாதிரி ஒரு பெரிஃபரல் சிட்டியில் குமரன் சார் மாதிரி ஒரு சார் வந்து நம்மளுக்கு கிடைச்சது வந்து ரொம்ப பெரிய விஷயம். இஸ் வெரி மச் டெடிக்கேட்டட் பர்சன். நமக்கு நான் ரொம்ப க்ளோஸாக மூவ் பண்ணது இப்போ ஒரு முன்னாடி பண்ணியிருந்தா கூட சாரோட டைரக்ட் சூப்பர்விஷனில் இருக்கிறது இப்போ தான். ரொம்ப பங்க்சுவல் பர்சன். ஏதாவது எல்லாம் கரெக்டாக பெர்ஃபெக்டாக பண்ணணும்னு நினைப்பார். ஸோ எஸ் அப்ளை லீவ்ஸ், நிறைய லீவ்ஸ் அப்ளை பண்ணிவிட்டு வரும்போது நான் நல்லா தானப்பா வச்சுட்டு போயிருந்தேன், நீ என்னப்பா சொதப்பிட்டிய, என்ன ப்ராப்ளம் ஆகிடுச்சான்னு சொல்லிட்டு யூ வில் சார்ட் இட் அவுட் வித்தின் ஃபியூ செகண்ட்ஸ். அது மாதிரி ஒரு கெப்பாசிட்டி உண்டு. அண்ட் ஆஸ் எவ்ரிபடி ஹஸ் டோல், he is a very leading pediatrician, passionate in pediatrics. He has seen 3 generations of people, and he himself has told he is not only pediatrician, he is a family physician for them also. And ஒரு 1000 ஃபேமிலிக்கு மேலே குமரன்னு பேர் வச்சவங்க இருக்கிறாங்க. பிகாஸ் ஆஃப் த இன்ஸ்பயர்ட் லைஃப்பை பார்த்துட்டு நிறைய ஃபேமிலிஸில் வந்து குமரன் வச்சவங்க நிறைய பேர் இருக்கிறாங்க. தட் ஷோஸ் இஸ் இன்ட்ரெஸ்ட் இன் டெடிகேஷன். இஸ் எ ஹார்ட் ஒர்க்கர். நம்ம பீட் பண்ணவே முடியாது. அந்த அசுர உழைப்புங்கிறோம்ல, அது மாதிரி எங்களுக்கெல்லாம் ரோல் மாடல். அண்ட் he is a man given with golden hand. whatever he touches it become gold. அந்த மாதிரி ஒரு இது. ஸோ என்ன ப்ராஜெக்ட்ஸ் எடுத்தாலும் சன் டிவி முதல்லலாம் சொல்லுவோம், சன் டிவி என்ன ப்ராஜெக்ட் ஆரம்பித்தாலும் சூப்பர் மெகா ஹிட் ஆகும். அதே மாதிரி நம்ம இதில் குமரன் சார் என்ன ப்ராஜெக்ட் எடுத்தாலும் சரி, என்ன லீடராக இருந்தாலும் சரி, he worked in the college for 8 to 10 years. அங்கே போய் டஸ் ரெவல்யூஷனரி சேஞ்சஸ். இங்கே இருக்கும்போது எங்களுக்கு அட்மினிஸ்ட்ரேஷனில் நல்லா ஹெல்ப் பண்ணியிருக்காங்க. ரீசெண்ட்லி ஆல்சோ ஃப்ளட்டுக்கு வந்து இன்ஃபோசிஸ்லேருந்து ஒரு 85 lakhs ஒர்த் ஆஃப் இன்ஸ்ட்ருமெண்ட்ஸ் நாங்கள் எல்லோரும் ட்ரை பண்ணோம். இந்த எப்படி முருகர் வந்து எல்லா இடத்துலையும் போய் மாம்பழம் வாங்குற மாதிரி நாங்கள் எல்லோரும் ஒவ்வொரு கம்பெனியில் போய் சிஎஸ்ஆர் ஆக்டிவிட்டியில் ட்ரை பண்ணோம். ஹீ ஒன்லி கோல்டன் ஹேண்ட் உடனே வாங்கிட்டு வந்து 85 lakhs உட்காந்த இடத்துலேருந்து அவர் ஃபோனில் என்ன மேஜிக் இருக்குன்னே தெரியாது. மொமெண்ட் ஏதாவது ப்ராப்ளம்னா கொஞ்சம் இரு அப்படின்னு சொல்லிட்டு இது பண்ணுவார். உடனே யூ could able to contact the right person the right time and you'll do the righteous thing. So even after retirement also we continue we require your support for the continued development of this college and hospital, and he is a professional ku romba support பண்ணுவாங்க. Thank you sir, thank you Onanda, thank you.
Thank you sir for your wonderful words. Our MS sir never surprised us with his words of wisdom. Now I request our respected RMO sir Dr. Silas sir to honor our MS Dr. Padmanabhan sir with a memento. Thank you sir. Now I request our former HOD Department of Pediatrics Professor Dr. Vellai Pandiyan sir to share his few words and his experience with our Professor Dr. Kumaran sir. We request you sir.
அனைவருக்கும் காலை வணக்கம். இந்த இனிய நாளிலே எனக்கு ஒரு வாய்ப்பு கொடுத்த மிக்க மிக்க நன்றி. குமரனை பற்றி சொல்ல வேண்டுமென்றால் அவருடைய அரசு பணி ஆரம்ப காலத்திலிருந்து எனக்கு நன்றாக தெரியும். கிட்டத்தட்ட நான் எப்போவுமே குமரனையும் அருணாச்சலையும் கொஞ்சம் ஈக்குவலைஸ் பண்ணி பார்ப்பேன். ஏன்னா ரெண்டு பேருமே உள்ளத்தில் நல்லவர்கள். பட் உலகமே அழிஞ்சாலும் பதட்டப்படாமல் இருக்கக்கூடிய ரெண்டு ஆன்மாக்கள் இங்கே தூத்துக்குடியில் உண்டுன்னு அது ரெண்டு பேரும். இப்போ உலகம் இடிஞ்சு உழுவு போகுது, ஹோட்டல் உழுவு போகுதுன்னு சொன்னால் கூட அப்படியா அப்படின்னு எட்டி பார்த்துட்டு அப்படியே உட்காந்துருப்பாங்க. நீங்கள் எல்லாம் எந்திரிச்சு ஓடணும்னு பார்ப்பீங்க, நம்மளையாவது காத்துக்கொள்ளலாம்ண்டு. அப்படிப்பட்ட ஒரு திடமான மனம், பொறுமை, இது ரெண்டையும் உடைய ஒரு நல்ல மனிதர்கள். பட் அவருடைய வளர்ச்சிக்கு பின்புறத்தில் முதல்வாக நான் நினைக்கிறேன் அவருடைய பெற்றோர்கள். ஏன்னா இவருக்கே தெரியாமல் அவரை மானிட்டர் பண்ண நிறைய விஷயங்கள் அவங்க அப்பா பண்ணுவார். ஏன்னா அவங்க அப்பா பற்றி நான் கேள்விப்பட்டிருக்கேன், எனக்கு டைரெக்டாக பழக்கம் கிடையாது. பட் அவருக்கு தெரியாமல் அது வீட்டில் இருந்தாலும் சரி, கிளினிக்காக இருந்தாலும் சரி, மருத்துவமனையாக இருந்தாலும் சரி, ஒரு மானிட்டர் பண்ணி ஒரு பாதுகாப்போடு கொண்டு வரக்கூடிய ஒரு நல்ல பெற்றோர்கள். அதற்கு அடுத்து இன்னொருக்கு தாரை வார்த்து கொடுத்துட்றாங்க. அவங்களுக்கு ஒரு ஹோம் டிபார்ட்மெண்ட் வருது. அந்த அம்மா ரொம்ப செல்லமாக பார்த்துக்கிறாங்க, ஒரு பாசமாக அன்பாக அரவணைப்போட. இப்போ நீங்கள் பார்த்தீங்கன்னா தெரியும். ஆனால் ஒரு குமரன் நல்ல நண்பர், எனக்கு நல்லாவே தெரியும், நல்லா பழகுவார், எல்லாமே செய்வார். ஆனால் ஒரு ரகசியத்தை மட்டும் இன்றைக்கி வரைக்கும் என்கிட்ட சொல்ல மாட்டார். இளமையின் ரகசியம் என்னென்னு கேட்டால் இன்றைக்கி வரைக்கும் சொல்ல மாட்டார். நீங்கள் பாருங்கள், அப்பா இருக்கார், பையன் இருக்கார். ஏதாவது உங்களுக்கு டிஃப்ரென்ஸ் தெரியுதா பார்த்தீங்கன்னா, இது ஒரு கிஃப்ட் ஆஃப் காட். அது ஒரு நல்ல மனம் உள்ள ஒரு மனிதர்களுக்கு தான் கிடைக்குமாங்கிறது தெரியல. பட் நம்மளாம் இப்படி தான் மேக்கப் போடணும்னு நினச்சா கூட அவ்வளோ போட முடியாது. பட் மற்ற எல்லோரும் சொன்னது மாதிரி சர்வீஸை பொறுத்தளவில் ஒரு ஒர்க்கர், அது ஒரு வெல் பிளானர். இன்னொரு பெரிய விஷயம் என்னென்னு கேட்டிங்கன்னா, சில சமயம் நான் எத்தனை தடவை அவர் கூட சத்தம் போட்டிருப்பேன், ஆனால் அதை பற்றி வருத்தமே பட மாட்டார். போட்டு நம்ம போய்ட்டு அடுத்த நிமிஷம் வந்து கை கொடுத்துட்டு சரி சார் அடுத்து என்ன செய்யணும்னு கேட்பார். அந்த மைண்ட் செட் வந்து நிறைய பேருக்கு சர்வீஸில் வராது. இப்போ நான்லாம் அப்படி இல்லை. ஒரு தடவை வாங்கிட்டேன்னா திரும்ப மொத்தம் நேராக பார்க்குறதுக்கே பயப்படுவேன். அந்த மாதிரி மைண்ட் செட் உள்ளவன். பட் அது சர்வீஸில் ரொம்ப முக்கியம்னு நினைக்கிறேன். அது ஒரு காரணம், அவருடைய வளர்ச்சிக்கு அது ஒரு காரணமாக இருந்திருக்கலாம். ஆனால் நீங்கள் இப்போ பார்க்கும்போது தெரியும், சரி அவர் நல்லா நிறைய மேக்கப் போட்டிருக்காரு, அதனால் வயசு தெரியலன்னு நினைக்கலாம். பட் அவர் மேக்கப் போடாமல் இன்னும் ஒரு முக்கியமான ஐட்டம் அவரிடம் உள்ளது. அது என்று நீங்கள் யாரும் கண்டுபிடிக்கிறீங்கன்னா ஒரு பிரத்யேகமான பரிசு கொடுக்க அவங்க தலைவர் ரெடியாக இருக்கார், HOD டாக்டர் அருணாச்சலம். இன்றைக்கி மேக்கப் இல்லாமல் இருக்கிறார் அப்படின்னா அவர்கிட்ட ஒரு விஷயம் உண்டு. என்னென்னு தெரியுமா யாருக்காவது? அவருடைய மனசு தான். உள்ள ஒன்றை வச்சு வெளியே ஒன்றை பேசுகிற பழக்கம் நிறைய கிடையாது. அது மேக்கப் போடவும் முடியாது. அது ஒரு நல்ல மனம் படைத்த மனிதர். எனவே இந்த ஓய்வு பெறும் இந்த மாதத்திலிருந்து அவருடைய வாழ்வில் சில மாற்றங்கள் உண்டாகி அவருடைய உடல் நலமும் ஆரோக்கியமும் குடும்ப நலமும் நன்றாக இருந்து வாழ இறைவனை வேண்டிக் கொண்டு வாய்ப்புக்கு நன்றி கூறி விடைபெறுகிறேன். நன்றி, வணக்கம்.
தேங்க்யூ சார். உங்கள் அனுபவங்களை அருமையான உரையாக எங்களுக்கு அளித்ததோடு மட்டுமல்லாமல் எங்களுடைய துணை கண்காணிப்பாளரின் அழகின் ரகசியத்தை சொல்லியமைக்கு மிக்க நன்றி சார். Now I request our MS Dr. Padmanabhan sir to honor respected former HOD Dr. Vellai Pandiyan sir with a memento. Thank you sir. Now I request Deputy Director Family Welfare Dr. Ponravi sir to share a few words and experience of working with our legendary pediatrician Dr. Kumaran sir. We request you sir.
எல்லாருக்கும் காலை வணக்கம். முதல்ல எனக்கு சான்ஸ் கொடுத்ததுக்கு ரொம்ப நன்றி. குமரன் கிட்டத்தட்ட 1990 நான் ஹவுஸ் சர்ஜன்சி பண்ணும்போது இன்ஸ்டியூட் ஆஃப் சைல்டு ஹெல்த்தில் பிஜி, கிட்டத்தட்ட 35 இயர்ஸ் ஆஃப் ஃப்ரெண்ட்ஷிப். அப்புறம் அங்கே படித்து முடிச்சுட்டு வந்த பிறகு அவர் இங்கே வந்து முடிவேத்தானந்தல் பிஹெச்சியில் ஒர்க் பண்ணார், நான் புதுக்கோட்டை பிஹெச்சியில் ஒர்க் பண்ணேன். மீனாட்சிபுரத்தில் கிளினிக் போட்டார், மீனாட்சிபுரத்தில் எங்கள் வீடு இருந்துச்சு. ஸோ இப்படியே அந்த ஃப்ரெண்ட்ஷிப் வந்து கிட்டத்தட்ட 35 இயர்ஸாக கண்டினியூ ஆகி, அப்புறம் அவங்க வந்து ஹெட் குவார்ட்டர்ஸ், அப்போது தூத்துக்குடி வந்து ஹெட் குவார்ட்டர்ஸாக இருந்துச்சு, ஹெட் குவார்ட்டர்ஸில் பீடியாட்ரிஷனை ஜாயின் பண்ணார். நான் திருச்செந்தூர் ஜிஹெச்சில் ஜாயின் பண்ணேன். ஸோ ரிலேஷன்ஷிப் ஹீஸ் கரெக்டாக நீங்கள் டைட்டில் போட்டிருக்கீங்க, லெஜெண்டரி பீடியாட்ரிஷியன். ஹீ இஸ் அ லெஜெண்ட், நாட் ஓன்லி இன் பீடியாட்ரிக்ஸ், இன் ஆல் ஃபீல்ட்ஸ். ஹீ இஸ் அ மேன் ஆஃப் பப்ளிக் ரிலேஷன்ஸ். எந்த கலெக்டர் வந்தாலும் தெரியும், எந்த எஸ்பி வந்தாலும் தெரியும். நாட் ஓன்லி ஹையர் அஃபீஷியல்ஸ், கீழ் லெவலில் உள்ள எல்லாரையுமே தெரிஞ்சு வச்சுருப்பார். அவருக்கு தெரியாத ஆளே இருக்காது, எல்லா டிபார்ட்மெண்ட்லேயும் ஆளை தெரியும். எந்த டிபார்ட்மெண்ட்டில், நாட் ஓன்லி கவர்மெண்ட், ப்ரைவேட், எங்கே வேணாலும் சரி அவர்கிட்ட போய் ஏதாவது ஒரு காரியம், சார் சொன்ன மாதிரி, எம்எஸ்ஆர் சொன்ன மாதிரி ஒரு காரியம் ஆகணும்னா குமரன் ஃபோன் பண்ணால் போதும், எங்கேயாவது எல்லா இடத்துலையும் ஒரு ஆள் தெரிஞ்சு வச்சுருப்பார். ஸோ ஹீ cannot be replaced by anybody. It's actually, he is retiring from government service தான், not from private service. கிட்டத்தட்ட 35 இயர்ஸ் அங்கே தூத்துக்குடியில் ப்ராக்டிஸ் பண்ணிகிட்டு இருக்காரு. இன்றைக்கி 35 இயர்ஸ் ஆஃப் ஏஜ் குரூப்பில் உள்ள அத்தனை பேரும் இவன்கிட்ட கண்டிப்பாக ட்ரீட்மெண்ட் எடுத்திருப்பாங்க. லெஸ் தேன் 35 இயர்ஸ் ஆஃப் ஏஜில் உள்ளவங்க அத்தனை பேரும் ட்ரீட்மெண்ட் எடுப்பாங்க. லீடிங் பீடியாட்ரிஷியன், கரெக்ட்லி செட், லெஜெண்டரி பீடியாட்ரிஷியன். ஐ விஷ் ஹிம் ஆல் சக்ஸஸ் ஈவன் இன் ஃபியூச்சர், ஹெல்த்தி அண்ட் ஹாப்பி லைஃப். நரேன் பிறந்ததுலேருந்து எனக்கு தெரியும், சின்ன பையனாக இருந்ததுலேருந்து, ஸ்கூல் படித்ததுலேருந்து தெரியும். இஸ் ஆல்சோ குமரனோட சக்ஸஸ்க்கு ஒரு கரெக்டான வாரிசு. ஐ விஷ் நரேன் ஆல் சக்ஸஸ். தேங்க்யூ ஃபார் கிவிங் திஸ் ஆப்பர்ச்சுனிட்டி. தேங்க்யூ.
Thank you, sir, for sharing a words of wisdom and a good experience. More than an experience, it seems between a talk of two departments, a department of family welfare and a department of child welfare. We all are astonished that what is the connection between these two. The connection is friendship. உடுக்கை இழந்தவன் கைப்போலே ஆங்கே இடுக்கண் களைவதாம் நட்பு. நல்லதொரு நட்பின் இலக்கணமாக திகழும் இவர்களுக்கு நம்முடைய வாழ்த்துக்களை தெரிவித்துக் கொள்கிறோம். Now I request our HOD Professor Dr. Arunachalam sir to honor DD Welfare Dr. Pundravi sir with a memento. Now I request Professor HOD Department of Pediatrics, Government Medical College, Dr. Arunachalam sir to share a few words about this wonderful CME and to share a words of wisdom and working experience with legendary pediatrician Dr. Kumaran sir. We request you, sir.
அனைவருக்கும் காலை வணக்கங்கள். இங்கே இந்த சிஎம்இக்கு வந்து கௌரவத்திற்கும் டீன், வைஸ் பிரின்சிபல், ஆர்எம்ஓ, மெடிக்கல் சூப்பரிண்டன்ட் மற்றும் பேராசிரியர்கள் மற்றும் மருத்துவ மாணவ மாணவிகள் மற்றும் நண்பர்கள் அனைவருக்கும் முதற்கண் எனது வணக்கம். ஸோ நான் வந்து குமரன் சார் அப்படின்னு சொல்லி எனக்கு பழக்கம் இல்லை, அண்ணன் சொல்லி தான் பழக்கம். எப்போவுமே அந்த இது வந்துடும். எங்கள் ஒரு ஈவன் ஒரு கவர்மெண்ட் அஃபீஷியல் இதில் போய் பேசினா கூட சொல்லும்போது அண்ணன் அப்படின்னு வந்துடும், குமரன் அண்ணன் அப்படின்னு வந்துடும். அந்த மாதிரி இந்த ஊருக்கு 2002 நான் வந்தப்போ வந்து அதுலேருந்து நமக்கு வந்து அறிமுகமானாங்க துறையில். ரொம்ப அதுலேருந்தே ரொம்ப ஒரு பழக்கம். அது ஒரு என்ன அப்படின்னு சொல்ல முடியாது, ஒரு தனியான ஒரு பாசம். அது வந்து எப்போவுமே என் மேலே ரொம்ப அன்பாக இருப்பாங்க. அதாவது என்ன சொல்லுவாங்க அப்படின்னா வந்து, எனக்கு போட்டியா நீ தாண்டா வருவ அப்படிமா சொல்லும்போது அப்படி தான் சொல்லுவாங்க. சொல்லிவிட்டு வந்து அதுக்கடுத்து என்கரேஜ் பண்ணுவாங்க. ஸோ நான் இந்த ஊருக்கு வரும்போது இப்போ இருக்கிற யங்ஸ்டர்ஸோட மனநிலை தான் ரொம்ப, அதாவது ஹார்ட் ஒர்க் பண்ணுறது அப்படிங்கிறதுலாம் ரொம்ப தெரியாது. போனால் ப்ராக்டிஸ் பண்ணணும், வீட்டுக்கு போகணும், ஜாலியாக இருக்கணும் அப்படிங்கிற மாதிரி ஒரு இப்போ இருக்கிற யங்ஸ்டர்ஸ் வந்து அப்போவே நான் அப்படி தான் வந்து இருந்தேன். திட்டுவார் என்னைய கூப்பிட்டு, ஏன்டா இப்போ வேலை செய்யாமல் எப்படா வேலை செய்ய போகிற, வேலை செய்யடா அப்படின்பார் கஷ்டப்பட்டு. இன்னொரு முக்கியமான விஷயம் சொல்லுவார், கடன் வாங்க அப்படின்பார். எங்கள் அப்பா வந்து என்னை கடனே வாங்கக்கூடாது அப்படின்பார். எங்கள் அப்பாவோட டீச்சிங் வந்து கடனே வாங்கக்கூடாது, நீ கடன் வாங்காட்டதான்டா நீ இருக்க முடியும் அப்படின்ட்டு. அந்த காலகட்டத்தில் அப்போ இருக்கிற சூழ்நிலையில் வந்து கடன் வாங்காமல் இருந்தால் நம்ம தப்பித்தோம். பட் இந்த காலகட்டத்தில் கடன் வாங்கலைன்னா நம்மளால் ஒன்றுமே பண்ண முடியாது. எதுக்காக சார் கடன் வாங்க சொல்கிறீங்க, எதுக்காக கடன் வாங்க சொல்கிறீங்கன்னா, சரி அப்போ தான் உனக்கு ட்ரைவ் இருக்கும் லைஃப்பில், சரி கொஞ்சம் சம்பாதிப்போம், கொஞ்சம் கையில் காசு வரும், ஜாலியாக இருக்கணும்னு நினைப்போம். பட் ஒரு கடனை வாங்கிட்டோம் அப்படின்னா அடுத்து வந்து அந்த கடனை அடைக்கணும் அப்படின்ற ஓடணும் அப்படிங்கிற எண்ணம் வரும். நமக்கு வந்து அந்த ட்ரைவ் வந்து நமக்கு கண்டினியூஸாக இருந்துகிட்டே இருக்கும். அதனால் எப்போவுமே வந்து என்னென்னா வந்து அது ஒரு ட்ரைவை நம்ம வச்சுட்டே இருக்கணும், நம்ம வந்து டு கோ ஃபார்வர்ட் அப்படின்ட்டு. அண்ணன் என்னன்னா இன்னொரு அவங்களுக்கு ஒரு மாமா இருக்கார். அவர் வந்து என்னென்னா வந்து அவரை தான் எக்ஸாம்பிளாக பார்த்துட்டே இருப்பார். அந்த மாமாவுக்கு 85 வயசு இருக்குமா சார்? 85-89 வயசு இருக்கும். அவர் வந்து இப்போ வந்து ரியல் எஸ்டேட் பண்ணிகிட்ருக்கிறாரு, இன்வெஸ்ட் பண்ண கூப்பிட்ருக்காரு அண்ணன் 90 வயசில். அவரே அவ்வளோ ஓடும்போது நமக்கெல்லாம் என்னப்பா 60 தானே அப்படின்ற மாதிரி. ஸோ இந்த மாதிரி அதாவது ஒரே துறை தான், ஒரே துறையில் வந்து ஒரு நட்பாக இருக்கிறது அப்படிங்கிறது வந்து ரொம்ப ரொம்ப கடினம். ஏன்னா போட்டி, நம்ம சும்மா இருந்தால் கூட பேஷண்ட்ஸ் வந்து எதாவது போய் போட்டு கொடுப்பாங்க கரெக்டாக, இங்கேருந்து அங்கே போய் போட்டு கொடுப்பான். ஸோ அதெல்லாம் வந்து மீறி நல்லா ஒரு அண்டர்ஸ்டாண்டிங்கோட பழகணும். அதோட ஒரு சீனியராக இருந்து ஒரு ஜூனியர்ஸை வந்து என்கரேஜ் பண்ணி கொண்டு வர அந்த ஒரு பெரிய குவாலிட்டிஸ் எல்லாம் வந்து நம்ம பார்க்க முடியும். நிறையா ஆசைகள் அப்படிலாம் கிடையாது, எல்லாமே அனுபவிச்சிட்டாங்க. ஆனால் சில ஆசைகள் உண்டு, நிறைவேறாத ஆசைகள் கொஞ்சம் இருக்குது. ஒன்று வந்து அது வந்து ஒரு இது ஆல்மோஸ்ட் நிறைவேற போகுது. ஏன்னா ஒரு மல்டி ஸ்பெஷாலிட்டி ஹாஸ்பிட்டல். ஸோ நம்மலாம் வந்து என்ன நினைக்கிறோன்னா ரிட்டையர்டாக வராங்கன்ட்டு. ஸோ ரொம்ப 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 அதெல்லாம் வந்து ரொம்ப முக்கியமானது. லைஃப்பில் நம்ம வந்து ஃப்ரீயாக நிம்மதியாக வெளியில் ஒர்க் பண்ணுறோம் அப்படின்னா நம்ம மைண்டு ஃப்ரீயாக இருக்கும். சார் சொன்ன மாதிரி வந்து எப்படி இவ்வளோ ஃப்ரீயாக இருக்காங்கன்னா வந்து பின்னாடி ஒரு சப்போர்ட் இருக்குது, அவ்வளோதான். வீட்டப்பான ஒரு சப்போர்ட் பின்னாடி இருக்காங்க. அதனால் எதுக்குமே அவங்க வந்து நம்மளை விட மாட்டாங்க. நான் கண்டிப்பாக வந்து சார் ஒத்துக்கணும்னு நினைக்கிறேன். ஸோ எப்போவுமே எந்த ஒரு இதுவும் யோசிப்பாங்க, இல்லைப்பா ரொம்ப வருத்தப்படுவாங்க, வேண்டாம் அப்படிம்பாரு. அதே மாதிரி இந்த அரசியல் அப்படிங்கிற ஆசையை மூட்டை கட்டி வச்சதுக்கு மெயின் காரணம். ஆனால் ஒரு நல்ல விஷயந்தான் அதுவும். இல்லாட்டா நாங்களே கூட பார்க்க முடியாது கிட்ட போய். ஸோ அந்த மாதிரி ஒரு இது இருந்திருக்கும். ஸோ ஒரு இது பண்ணுவாங்க, அதாவது வந்து வெள்ளத்தனைய மலர் நீட்டம் மாந்தர்தம் உள்ளத்தனைய உயர்வு அப்படின்ட்டு ஒரு குறள் இருக்குது. ஸோ நம்ம வந்து ஒரு என்றைக்குமே பார்த்திங்கன்னா ஒரு குளத்தில் ஒரு தாமரைப்பூ இருக்குன்னா அது வந்து தண்ணி எவ்வளோ மட்டம் வந்தாலும் தாமரைப்பூ மட்டும்தான் மேலே இருக்கும், கீழே எவ்வளோ ஆழம் இருக்குது என்னன்னு தெரியாது. ஸோ நம்ம வந்து உயர உயர வந்து பார்த்திங்கன்னா அந்த தாமரைப்பூவோட மட்டமும் உயர்ந்துகிட்டே இருக்கும். அதே மாதிரி அண்ணனோட உயரம் வந்து எவ்வளோ தெரியாது வெளியில், ஆனால் மேலே அந்த நீர்மட்டம் உயர உயர அவங்க அந்த தாமரை மாதிரி மேலே வந்துகிட்டே இருப்பாங்க. அதே மாதிரி வந்து அந்த ஒரு எல்லாருக்கும் எல்லாருமே சொல்லிட்டாங்க உதவி பண்ணுறதுன்ட்டு. நான்லாம் பல முறை போய் வந்து உதவி கேட்டுக்கான்னு சொல்ல முடியாது, கூப்பிட்டே கொடுத்துருக்காங்க. இப்போ இன்றைக்கி ஒரு கிளினிக் ஆரம்பிக்கிறோம், அது வந்து அதுக்கு அடித்தளம் போட்டது அண்ணன் தான். அதுக்கு நான் ஒரு லேண்ட் வாங்கும்போது எனக்கு ஹெல்ப் பண்ணது அண்ணன் தான் ஹெல்ப் பண்ணாங்க. அது மட்டும் இல்லை, சின்ன சின்ன விஷயங்கள் எந்த ஒரு சாதாரண சின்ன ஒரு இதாக இருந்தால் கூட எதாக இருந்தால் கூட நம்ம ஷேர் பண்ணோம் அப்படின்னா உடனே சொன்ன மாதிரி தான் ஃபோன் தான். அது என்ன மேஜிக் ஃபோன் அப்படின்ட்டு யாருக்குமே தெரியாது. அந்த ஃபோன் எடுத்தாங்கன்னா அவ்வளோதான், அப்படி கொஞ்சம் யோசிப்பாங்க, டக்குன்னு கரெக்டாக வந்து பண்ணுவாங்க, அதை சால்வ் பண்ணி கொடுத்துருவாங்க. இதில் எனக்கு ரொம்ப வந்து என்னென்னா வந்து ஒரு பெரிய ஒரு தூண் மாதிரி எங்கள் டிபார்ட்மெண்ட்டில் இருந்தாங்க. போகிறது வந்து எனக்கு ரொம்ப ரொம்ப ஒரு மன வருத்தமாக தான் இருக்குது ரொம்ப. ஏன்னா அவங்க இருக்காங்க அப்படிங்கிறது வந்து ஒரு கிருஷ்ணர் வந்து நம்ம பக்கம் இருந்தால் எப்படி வந்து அவங்களுக்குலாம் ஒரு பலமோ அதுமாரி வந்து அண்ணன் கூட இருக்காங்க அப்படிங்கிறதே எங்களுக்கு வந்து ஒரு பெரிய பலமாக இருந்தது. இப்போ அந்த டிபார்ட்மெண்ட் அப்படிங்கிறது வந்து இப்போ வந்து எங்களுக்கு வந்து ஒரு பெரிய ஆமாம் அதனால் அந்த ஒரு என்ன தான் வந்து ஒரு அடுத்த லெவல் போனாலுமே கொஞ்சம் எங்களுக்கு ஒரு டிபார்ட்மெண்ட் அப்படிங்கிற முறையில் வந்து இதுதான் எல்லா அதாவது சீனியர் ஜூனியர்லாம் பார்க்க மாட்டாங்க, எல்லாருக்குமே தெரியும். பிஜிஎஸ் கூட மட்டும்தான் ரொம்ப பழக்கம் இல்லை, பட் வந்து எல்லா அசிஸ்டன்ஸு என்னை விட ரொம்ப க்ளோஸாக இருப்பேன். நானே எல்லோரோடையும் க்ளோஸாக இருப்பேன், என்னை விட ரொம்ப க்ளோஸாக எல்லோரோடையும் ரொம்ப நெருக்கமாக பழகியிருப்பாங்க. எல்லா அசிஸ்டன்ஸ் டிபார்ட்மெண்ட்டில் எல்லாம் பார்த்தீங்கன்னா அவ்வளோ ஒரு பெட்டு, அவ்வளோ க்ளோஸு. அந்தளவுக்கு வந்து இன்னொன்று வந்து ரெஸ்பான்ஸ் அட் எனி டைம். நிறைய பேர் ஃபோன்லாம் வந்து பிடிக்கவே முடியாது, அண்ணா அப்படி கிடையாது, எப்போனாலும் ரெஸ்பான்ஸ் இருக்கும், இல்லாட்டா உடனே கூப்பிட்ருவாங்க. ஸோ நிறைய வந்து அந்த ஹெல்பிங் டெண்டன்சி, நல்ல குவாலிட்டிஸு, அந்த மாதிரி வந்து நிறைய கான்டாக்ட்ஸு. ஸோ வி மிஸ் யூ ஃப்ரம் த டிபார்ட்மெண்ட். ஸோ ஐ ப்ரே த அல்மைட்டி காட். அண்ட் ஒன் மோர் திங் டு சே அபவுட் சாரோட பையன். அதாவது வந்து 16 அடி பாயிற மாதிரி குட்டி, ஏன்னா 16 அடி குட்டி பாயிற மாதிரி தான் வந்து இப்போ வந்து அவங்க வந்து இப்போ யூகேல ரொபாட்டிக் சர்ஜரியில், அதாவது சர்ஜரி அப்படிங்கிறது வந்து யூகேல எடுக்கிறதே ரொம்ப கஷ்டம் அப்படிம்பாங்க. யூகே வந்து தே வைட் நெவர் அலவ் தி இது டு டேக் சர்ஜரி. நம்ம போனால் பீடியாட்ரிக், சைக்காட்ரி, அனஸ்தீசியா இந்த மாதிரி தான் வந்து பேஷண்ட்ஸ் டச் பண்ணாத டிபார்ட்மெண்ட்ஸ் தான் மேக்ஸிமம் கொடுப்பாங்கம்பாங்க. நம்ம தே வில் நாட் அலவ் அஸ் டு கோ இன் டு த கிளினிக்கல் டிபார்ட்மெண்ட். சர்ஜரி வந்து கண்டிப்பாக எடுக்கவே முடியாதும்பாங்க. ஸோ சாரோட அதே ஒரு டேலண்ட் எல்லாமே இருக்குது. சர்ஜரியில் வந்து முடிச்சிருக்காங்க, எஃப்ஆர்சிஎஸ் முடிச்சிருக்காங்க, முடிச்சு இப்போ ரொபோட்டிக் சர்ஜரியில் இருக்காங்க. ஸோ ஹீ இஸ் ஆல்சோ எ ஸ்பீக்கர் ஃபார் இன்டர்நேஷ்னல் கான்ஃபரன்சஸ். ஹீ இஸ் டூயிங் லாட் ஆஃப் ஒர்க்கு ரிஜிஸ்டராக. அது வந்து பார்த்திங்கன்னா அந்தளவுக்கு வந்து அதாவது ஒரு இல்லை என்ன அப்படின்னா வந்து அங்கே எல்லாமே பார்த்திங்கன்னா செகண்ட் நேம், ஃபாதர் நேம் ஒரு குமரன்ட்டு வரும். எல்லாம் ஒவ்வொரு இதையும் காமிப்பாங்க. குமரன், யூ ஹவ் பீன் செலக்டட், யூ ஹவ் பீன் கிவன் வாஸ் குமரன். சார் ஒன்றுமே இல்லாமல் நீங்கள் எல்லா அவார்டும் நீங்கள் வாங்கிட்டு இருக்கீங்க, பையன் கஷ்டப்பட்டு உழைக்கிறான், ஆனால் எல்லாமே குமரன் வருது. அந்தளவுக்கு வந்து அது ஒரு நமக்கே ஒரு பெருமையாக இருக்கும்னா அவங்க வந்து இந்த செகண்ட் நேம் தான் ஃபஸ்ட்டாக கொடுத்து பண்ணுவாங்க அங்கே. அதனால் எல்லா லெட்டர்ஸ்லேயும் வந்து அண்ணனோட பேர் தான் இருக்கும். அவன் பண்ணுற எல்லா அச்சீவ்மெண்ட்டுக்கும் டாக்டர் குமரன் தான். ஸோ அந்தளவுக்கு வந்து ஒரு நல்ல நிலைமை. அதாவது 16 அடி சொல்லிட்டு அதான் அண்ணனே வந்து பெரிய லெவல்னா அதை விட நல்ல ஒரு சிறப்பான லெவல் போயிருக்கிறாங்க. ஸோ எல்லாத்துக்கும் காரணமாக இருந்தால் மேடம் அவங்களுக்கு உண்மையிலே வந்து வி ஹவ் டு தேங்க் ரொம்ப. இந்த அளவுக்கு வந்து நெவர் ரெஸ்ட்ரிக்ட் மேடம் பண்ணவே மாட்டாங்க. வெளியில் சொல்ல மாதிரி சார் தான் ரெஸ்ட்ரிக்ட் பண்ணி போவாங்க. அவங்க வந்து ஹி வில் அலவ். அதனால் வந்து சார் வந்து கண்டிப்பாக அந்த அன்பு அந்த அவங்களுக்குள்ள அந்த ஒரு இது இருக்கிறதுனால தான், அந்த கெமிஸ்ட்ரி நல்லா இருக்கிறதுனால தான் இந்த அளவுக்கு இளமையாகவும் இருக்கிறாங்க. ஸோ உங்களுடைய ரிட்டையர்மெண்ட் இது வந்து மென்மேலும் சிறக்க கடவுளை பார்த்து வாழ்த்தி வணங்குகிறேன். வணக்கம்.
தேங்க்யூ சார் ஃபார் யுவர் வண்டர்ஃபுல் வேர்ட்ஸ். கடனில் தொடங்கி கடமையை பற்றி பேசி, தன்னுடைய அண்ணன் கண்ணியத்தை பற்றி பேசி, அண்ணனின் ரகசியங்களையெல்லாம் மேடையிலே போட்டு உடைத்த எங்களுடைய பேராசிரியர் அவர்களே, தம்பியுடையான் படைக்கு அஞ்சான் என்று சொல்வார்கள். நம்முடைய குமரன் சார் அவர்களுக்கு நல்ல தம்பி கிடைத்திருக்கிறார். அதனால்தான் இவ்வளவு சிறப்பாக அவருடைய பணி நிறைவு விழாவை அவர்கள் செய்து கொண்டிருக்கிறார்கள் என்று சொல்லி, நவ் ஐ ரெக்வெஸ்ட் அவர் ரெஸ்பெக்டட் RMO Dr. J. Silas sir to honor our Professor HOD Department of Pediatrics Dr. Arnachalam sir with a memento. Now I request our respected Vice Principal Madam, our beloved Dr. Professor Kalaivani Madam, to share few words and her working experience with dear Kumaran sir. Thank you, ma'am.
Respected Dean sir, Medical Superintendent, இந்த விழாவின் நாயகன் Deputy Superintendent Dr. Kumaran sir, RMO Mrs. Kumaran Dr. Naren Kumaran, previous HOD of Pediatrics, Dr. Vellapandian sir, Deputy Director of Family Welfare, Dr. Ponravi sir, HOD of Pediatrics, Dr. Arunachalam, the other senior professors, other faculties, other professors, assistant professors, and my dear students, a happy good morning to you all. So in this occasion, I want to say a few words about our Kumaran sir. I know him for the past 25 years. More than the faculty of our college, he is a good family friend, sir and his wife and his son. His son Naren is my son's friend, so we know him from his childhood itself. Madam also we know for past 25 years. In all family functions, everywhere we meet. Coming to Kumaran sir, he is closely related in academic activities in our medical college activities. From the Department of Community Medicine, he worked there for many years, 14 years, and then as academic officer in our medical college, he has done a wonderful work during MCA inspection. As all of them told, during MCA inspection, he is the backbone behind for all the academic activities and getting information about the inspectors. So we are very free because he will guide us in all the other academic as well as the other activities. Then he worked as Gents Hostel warden for many years. He has many close relationship with the students and he guided the students in academic as well as in other activities also. Then after that he worked in our medical college hospital as deputy superintendent for so many years recently. So his work is enormous in upliftment of our college in academic as well as in all other activities. And I want to pray God for his happy, peaceful and healthy retirement life. And I want to say another few words about our Department of Pediatrics. They are conducting this CME in a great manner. So I congratulate the HOD, Dr. Arunachalam and his colleagues for conducting this CME on the superannuation of our Kumaran sir. So I pray Almighty, thank you.
Thank you, ma'am, for your wonderful words. Now I request Dr. Dhanlakshmi ma'am to honor our Vice Principal, Dr. Kalaivani ma'am, with a memento. Thank you, ma'am. Now, I request our chief guest of the day, man behind the success of our TKMC, respected professor, respected dean, Dr. Sivakumar sir, to give chief guest address on this wonderful occasion and to share his working experience with our dear Deputy Superintendent sir. இப்பொழுது விழா பேருரையாற்ற வருமாறு நம்முடைய மருத்துவக் கல்லூரி முதல்வர் பேராசிரியர் திரு சிவகுமார் ஐயா அவர்களை பணிவன்போடு அழைக்கிறோம்.
Respected Vice Principal, Medical Superintendent, Deputy Superintendent Dr. Kumaran sir, Deputy Director Dr. Ponravi, HOD of Pediatrics, Arunachalam, retired Professor Dr. Vellapandian sir, all the eminent professors and retired persons and postgraduates and all the people assembled here, our sir's son and madam, a very good afternoon to one and all. Presidential address ன்னு சொல்லிட்டாங்க. அப்படி சொன்னோடனே எனக்கு ஷாக் தான் அடிக்குது. என்ன சொல்கிறதுனே தெரியல. சரி இருந்தாலும் everybody has gone through with him, traveled with him for a long time, but my travel with sir and association with him was only for a if you correctly say around 2 years, 8 months and 10 days, I think so. That is what correctly if I tell that. And within this short period, the amount of support sir has given to me is enormous. நான் வந்து இந்த காலேஜில் ஜாயின் பண்ணும்போது சார் அப்போ வந்து இல்லை. சார் ஆனால் பேர் சொல்லி அனுப்புனாங்கன்ட்ட. டாக்டர் குமரன் ஒருத்தர் இருப்பார், அவர் வந்து எல்லா ஹெல்ப்பும் பண்ணுவார் அப்படின்னு மட்டும் ஒரு வார்த்தை சொல்லி அனுப்புனாங்க. திஸ் இஸ் ட்ரூ அண்ட் திஸ் இஸ் ஃபேக்ட்டு. டாக்டர் ஸ்ரீஹரி உங்களை சொல்லி அனுப்புனார் சார். ஐ ஓப்பன் திஸ் ஒன். ஸோ ஒருத்தர் இருக்கார் நமக்கு சப்போர்ட்டுன்னு மட்டும் எனக்கு தெரியும். இன்னொரு பர்சன் எனக்கு தெரிஞ்ச ஆள்னு அப்போ பார்க்கும்போது வந்து கான்டாக்ட் இல்லாத ஒரு ஆள், ஆனால் நம்ம விபி மேடத்து கூட நான் கொஞ்சம் அசோசியேஷன் ஒர்க் பண்ணியிருக்கேன் கூட கன்னியாகுமரி மெடிக்கல் காலேஜில். ஸோ ஐ நோ ஹிம் தேட், பட் நோ அதர் பர்சன் இஸ் நோன் டு மீ ஹியர் in this Thuthukudi, and that was the first time I am coming to Thuthukudi itself. Earlier I came in 2003 for MCI. அதுவும் ஒத்துக்கிறேன். நான் ஒரு ஃபேக் டிபார்ட்மெண்ட் ஃபேக்காக நான் வந்தேன். நான் அப்போ அந்த ஒரு பீரியடில் that is one of the truth. ஸோ இந்த ஒர்க்கோடு தான் நான் இங்கே வந்து லேண்ட் ஆனேன். அதுக்கப்புறம் பார்த்தீங்கன்னா the support given to me by all the people who are sitting in the stage, இன்க்ளூடிங் நான் வந்து இப்போ ரீசெண்டாக தான் அவர் சப்போர்ட் எனக்கு கிடச்சிச்சு. அவரும் எனக்கு சப்போர்ட் பண்ணியிருக்காரு. ஸோ இட்ஸ் எ கிரேட் சப்போர்ட். அந்த சப்போர்ட் இல்லைன்னா நான் இவ்வளோ தூரத்துக்கு இங்கே உட்காந்துட்டு இருப்பானு எனக்கு தெரியல. என்னை எப்போயோ தூக்கி விட்டுருப்பாங்கன்னு நினைக்கிறேன் நான். தட் இஸ் த ஃபேக்ட், ஐ திங்க் ஸோ. ஸோ இன் டைம்ஸ் ஆஃப் க்ரைசிஸ் ஆல்வேஸ், இப்போ எல்லாருமே சொன்னாங்க, இன் டைம்ஸ் ஆஃப் க்ரைசிஸ் ஒருத்தர் வேணும் அப்படின்னு நினச்சேன்னா குமரன் சார் தேவை. அவர் நமக்கு கடவுள் மாதிரி தான் வச்சுக்கோங்களேன். ஸோ நான் எப்போதுமே வந்து எல்லா ரிசோர்ஸையும் எனக்கு ஏதோ கொஞ்சம் தெரிஞ்ச இதில் எல்லாமே அப்படியே பார்த்துட்டே வருவேன். அப்படியே பார்த்துட்டே வந்துட்டு இருக்கும்போது ஒரு பாயிண்ட் ஆஃப் டைமில் வந்து ஒரு முடியாது, நமக்கு ஒருத்தரை கேட்டு தான் ஆகணும், அவர்கிட்ட நம்ம பொறுப்பை கொடுத்து தான் ஆகணும் அப்படின்னு முடிவு பண்ணிவிட்டு சார் கையில் அதை கொடுத்துட்டு நான் வந்து அதை மறந்துடுவேன், அவ்வளோதான். அதுக்கப்புறம் அவர் பார்த்துக்க வேண்டியது தான். ஒரே வார்த்தை தான், சார் இது உங்களோட டாஸ்க், அப்படி தான் சொல்லுவேன். சாருக்கு தெரியும், சார் இன்றைக்கி உங்களுக்கு ஒரு டாஸ்க் இருக்குது சார், இதை நீங்கள் எப்படியாவது தீர்த்து வச்சுருங்க சார் அப்படின்னு சொல்லிட்டு விட்டுடுவேன். சார் அதுக்கப்புறம் பார்த்துட்டு அதை சரி பண்ணி நமக்கு கொடுத்துருவாரு. நம்ம கொஞ்சம் நிம்மதி ஆகிடும், அவ்வளோதான். திஸ் இஸ் வாட் ஐ ஹேவ் டு சே வித் தெம். ஸ்டார்டிங் வித் தி ஃப்ளட் சுச்சுவேஷன் ஆகட்டும், இல்லை எதனாவது ஒரு கிரிட்டிக்கல் சுச்சுவேஷன்ஸ் ஆகட்டும், எல்லாத்துலேயுமே வந்து இது எம்சிஐ சுச்சுவேஷன் ஆகட்டும், நமக்கு வந்து ஹோட்டலில் அங்கே சார் அங்கே சொல்லிடுங்க சார் அப்படின்னா அங்கே சொல்லிவிட்டு நமக்கு சார் எம்சிஐ ஆள் வந்திருக்காங்க, யாரோ டெல்லியிலேருந்து வந்திருக்காங்க, நமக்காக கூட இருக்கலாம், நம்மளை மெஷினரியை ஆக்டிவேட் பண்ணி விட்டுருவாரு, நம்மளை வந்து அலர்ட் ஆகிடுவோம். ஸோ திஸ் இஸ் ஹவ் அட்மினிஸ்ட்ரேஷன் சைட் கோஸ் ஆன். அது ஒரு சைடில் போயிட்டே இருக்கும் நமக்கு. ரீசெண்ட்லி கூட இப்போவும் நம்ம அவரை மிஸ் பண்ணுவோம். இல்லைனாலும் நான் நடுவில் கூப்பிடுவேன், சார் நீங்கள் வந்து ஹெல்ப் பண்ணணும். என்னென்னு கேட்டிங்கன்னா, இப்போ நாங்கள் கான்ஸ்டண்ட்டாக அந்த சூப்பர் ஸ்பெஷாலிட்டி ஹாஸ்பிட்டலுக்காக ஒர்க் பண்ணிகிட்ருக்கோம். அதில் பார்த்திங்கன்னா ஏதாவது ஒரு இது நடந்துக்கிட்டே இருக்கும். இந்த ஃபர்னிச்சர் இதுன்னு இப்போ லேட்டஸ்ட்டாக பார்த்துட்ருக்கோம். அது சார் அமௌண்ட்டு கூட வருது சார், குறைச்சி போட்டு கொடுங்க சார் அப்படின்ட்டு நம்ம சேர்ந்து உட்காந்து போடுவோம் அப்படின்னு சொல்லுவார் சார். ஒரு 2 hours உட்காந்து சார் நான் பத்மநாபன் சார் உட்காந்து போட்டு அந்த அன்றைக்கே அந்த ஒர்க்கை நாங்கள் வந்து அரைவ் பண்ணி முடிச்சுருவோம். அது இன்னும் கண்டினியூஸாக தான் போய்கிட்டு இருக்குது. அந்த மாதிரியான ஒர்க்ஸ் எல்லாம் சார் வந்து எங்களுக்கு பண்ணி கொடுத்துட்டே இருப்பார். ஸோ அதே போல் சார் எல்லோரும் சொன்ன மாதிரி இந்த ஃப்ளட் சுச்சுவேஷன்ஸில் அதுக்கப்புறம் அவரோட கான்டாக்ட்ஸால் வி ஆல்மோஸ்ட் சப்மர்ஜ்டு இன் தி வாட்டர் தான், அப்படி தான் சொல்லணும். இந்த ஃப்ளட்டில் அதுலேருந்து நம்ம வந்து இப்போ வந்து வெளியில் வர்றதுக்கான காரணம் ஒன் ஆஃப் த மெயின் பர்சன்ஸ் சாரை தான் சொல்லுவேன் நான். அது ஒரு சைடு அப்படி இருக்கும்போது எப்போதுமே சொல்லுவார், ஃபேமிலி மெம்பர்ஸ் பற்றி சொல்லுவார். நரேன் ஒன்று சொல்லுவார், ஃபோட்டோஸ் எல்லாம் காட்டுவார், மேடம் ஃபோட்டோஸ்லாம் காட்டுவார். ஸோ என்னென்ன செஞ்சிட்ருக்கார் அப்படின்லாம் சொல்லிகிட்டு இருப்பார். இப்போ எல்லாருமே சார்லாம் சொல்லிகிட்டு இருந்தார். அருணாச்சலம் சார் சொன்னார் இல்லையா, அதே தான், பேர் சொல்லும் பிள்ளை, உங்கள் பேர் அவர் சொல்லிகிட்ருக்கார், அவ்வளோதான். தட் இஸ் வாட் இட் கோஸ் அரவுண்ட். அது மட்டும் இல்லாமல் சார் வந்து 3 ஜென்ரேஷன்ஸ், இது அப்பார்ட் ஃப்ரம் திஸ் ஒன் 3 ஜென்ரேஷன்ஸாக இங்கே தூத்துக்குடியில் இருக்கார் அப்படின்னு சொல்லிட்டு இருக்காங்க. ஸோ 3 ஜென்ரேஷன்ஸாக நம்ம பார்க்கும்போது ஐ ஆல்சோ கம் அக்ராஸ் திஸ் டூரிங் அவர் ப்ராக்டிஸ். நம்மளும் பார்த்துட்ருப்போம். மதருக்கு சர்ஜரி பண்ணியிருப்போம், அந்த டாக்டர் வந்திருக்கோம், அந்த டாக்டருக்கு ஒரு சில்ட்ரன் வந்திருக்கோம், அதுக்கும் சர்ஜரிக்கு ஏதாவது பண்ணி நம்ம ஹெல்ப்ஃபுல் பண்ணிட்டுருவோம். திட் ஆல் கோஸ் ஆன் அண்ட் ஆன். அதுவும் இந்த ஜென்ரேஷன் பார்த்துருக்கீங்கன்னா சாரோட நாங்களாம் அதே ஒரே சேம் ஜென்ரேஷன் தான். அந்த ஜென்ரேஷன் இஸ் அ கண்டினியூஸ் டிரான்ஸ்ஃபர்மேஷன் ஜென்ரேஷன் அண்ட் இட் இஸ் அ க்ரோயிங் ஜென்ரேஷன். அப்படியே நம்ம வந்து டிரான்ஸ்ஃபர்மேஷன் டெக்னாலஜிக்கலி எல்லாத்துலேயுமே மாறிக்கிட்டே இருக்கும். அந்த மாறிட்டு இருக்கும்போது பார்த்திங்கன்னா ஃபஸ்ட்டு வந்து இந்த கம்ப்யூட்டர்னு வரும்போது பார்த்தா நாங்களாம் தலை சுற்றி குழம்பி போய் இருப்போம். அது வந்து இப்போலாம் பார்த்திங்கன்னா ஃபோன்லேயே வந்துட்டு அந்தளவுக்கு ஈஸியாகிடுச்சு. அதில் கற்றுக்கிறது அப்போ வந்து நமக்கு வந்து இனிஷியல் பீரியடில் கொஞ்சம் டிஃபிகல்ட்டி இருந்தது. நவ் இட் ஹஸ் பிகம் வே ஆஃப் லைஃப்னே மாறிடுச்சு. அந்த மாதிரி அந்த எல்லாமே மாறிட்டே வந்தது. லேர்னிங் பாயிண்ட்ஸ் இப்போ வர்றவங்களுக்கு பார்த்திங்கன்னா ஈஸியாக லேர்ன் பண்ணிக்கிறது, ஈஸியாக மெட்டீரியல்ஸ் எல்லாமே கிடச்சிருக்கு. அந்த பீரியடில் வெரி டிஃபிகல்ட் டு கெட் தி மெட்டீரியல்ஸ் டு லேர்ன். அவங்கள்ட்டேருந்து நம்ம வந்து லேர்ன் பண்ணிக்கணுன்றது வந்து அகாடமிக்கலி சார்கிட்டலாம் பார்த்தீங்கன்னா என்கிட்டே சார் காட்டுவார், ஃபோனில் காட்டுவார். சார் இந்த பேஷண்ட்டு வந்து இந்த பேபியோட இதுன்னு காட்டுவார், எக்ஸ்ரேஸு அதை பற்றிலாம் டிஸ்கஸ் பண்ணுவோம். நாங்களும் சாரும் டிஸ்கஸ் பண்ணுவார். ஸோ அதில் போட்டிருந்தாங்க த பேர்ல்ஸ் ஆஃப் பீடியாட்ரிக்ஸ். ஸோ எல்லா டிபார்ட்மெண்ட்ஸ்லையுமே பேர்ல்ஸ் இருக்கும். அந்த பேர்ல்ஸ் ஆஃப் பீடியாட்ரிக்ஸில் நமக்கு தெரிஞ்சு சப்ஜெக்டில் சொல்லும்போது தூத்துக்குடியில் எடுத்துக்கிட்டிங்கன்னா சார் ஒரு பேர்லாக எடுத்துக்கலான்னு நினைக்கிறேன். ஸோ திஸ் இஸ் வெரி everybody should get the knowledge from him also. He is very depth of knowledge is very high. பட் இவ்வளோ தூரம் சொல்லும்போது பார்த்தோன்னா சார் வந்து டிபார்ட்மெண்ட்டில் ஒர்க் பண்ணாமல் அதர் டிபார்ட்மெண்ட்ஸில் ஒர்க் பண்ணிக்கும்போது ஐ திங்க் மெனி பீப்புள் ஹவ் மிஸ்ட் ஹிஸ் நாலேஜ். தட் இஸ் ஐ ஃபீல் பர்சனலி அவரோட நாலேஜ் பார்க்கும்போது ஸ்டூடெண்ட்ஸ் வந்து நிறைய பேர் போஸ்ட் கிராஜுவேட்ஸ் தட் ஹவ் மிஸ்ட் இட். பர்சன் வித் ஹிம் கூட இருந்து இருந்திருந்தாங்கன்னா அவரோட ஸ்கில்லு டெக்னிக்கல் அந்த ஃபைனர் பாயிண்ட்ஸ் எல்லாம் வந்து இந்த பேர்ல்ஸ், அதுதான் அந்த பேர்ல்ஸ் த ரேர் எக்ஸ்பீரியன்ஸஸ்ஸு நமக்கு வந்து மிஸ் ஆகாமல் கிடைச்சிருக்கும். இருந்தாலும் சார் அப்பப்போ ஷேர் பண்ணுவாருன்னு நினைக்கிறேன் எல்லாருக்கும். ஸோ யூ ஆல் பி having this experiences and others' experience is our learning experience. That is what medicine is always concerned about. And the teaching other people, now sharing our knowledge போனால் தான் அது இன்னும் நல்லா வந்து வெளியில் வரும், நமக்கு மக்களுக்கு வந்து யூஸ்ஃபுல் ஆகும். அண்ட் எவ்ரி மேன்ஸ் பிகைன் சக்ஸஸ் மேனாக இருக்காங்க, சாரோட பேரண்ட்ஸ் இருக்காங்க, தேவர் ஆல்சோ தேர். இதெல்லாமே இருந்தால் தான் சார் இந்த லெவலுக்கு வந்திருக்காங்கன்னு எல்லாம் சொன்னாங்க. தட் இஸ் ட்ரூ. அண்ட் வித் காட்ஸ் கடவுளோட அருள் கூட இல்லைன்னா அதுவும் நடக்காது, எதுவுமே நடக்காது. ஸோ தட் இஸ் ஆல்சோ வித் தம் சார். ஸோ ஃப்ரம் த பிகினிங் நாங்கள் இருக்க வரைக்கும் பார்த்துட்டு இருந்தது. ஸோ this is what I want to convey the message, and this I pray to God to give him a happy and healthy and peaceful retired life. Thank you for giving me the opportunity. Thank you one and all.
Thank you, sir, for your wonderful words and sharing a lot of experience with working our Deputy Superintendent Dr. Kumaran, sir. Now I request Professor and HOD Department of Pediatrics, Dr. Arnachalam, sir, to honor our Chief Guest and respected Dean, Professor Dr. Sivakumar, sir, with a memento. Thank you, sir. Now, it's a nostalgic moment for the man of the day. முகநக நட்பது நட்பன்று, நெஞ்சத்து அகநக நட்பது நட்பு. ஒவ்வொரு மருத்துவரின் வாழ்விலும் அவர்களுடைய இளம் கலை பருவம், யூஜி பீரியட் இஸ் அ கோல்டன் பீரியட். நம்முடைய குமரன் சார் குமாரராக இருக்கும் பொழுது மதுரை மருத்துவக் கல்லூரியில் அவரோடு பயின்ற ஏனைய மருத்துவர்கள் அவருடைய பணி நிறைவு விழாவை சிறப்பிப்பதற்காக இங்கு வந்திருக்கிறார்கள். Now, I request the proud 82 batch of Madurai Medical College to honor and felicitate man of the day and their dear friend, our Deputy Superintendent, Dr. Kumaran sir. I request Dr. Ilangovan sir, Dr. Ramanathan sir, Dr. Manimaran sir, Dr. Magendran sir, Dr. Jayalakshmi ma'am, Dr. C.R. Kumar sir, Dr. Krishnaveni ma'am, Dr. Guru Prabhakaran sir. We request you all to felicitate our DS sir.
அவையோருக்கு வணக்கம். Respected learned persons on the dais and off the dais. I am a proud batchmate of Dr. Kumaran. I like to say a few words. அறுபடை வீடு மாதிரி குமரன்னு பேர் கரெக்டாக வச்சுருக்காங்க. இவர் 6 விஷயத்தில் சக்ஸஸ்ஃபுல்லாக இருந்திருக்கார். யூஸ்வலாக எல்லாத்துலேயும் வந்து எல்லோரும் சக்ஸஸ்ஃபுல்லாக இருக்க முடியாது, கரெக்டாக. நம்பர் 1, இஸ் அ சக்ஸஸ்ஃபுல் சன். அதோட எவிடன்ஸ் வந்து அவங்க பேரண்ட்ஸ் வந்து இங்கே இருக்காங்க. ஸோ தே ஆர் வெரி ஹாப்பி டு ஹாவ் அ சச் அ சக்ஸஸ்ஃபுல் சன். and of course he is a very successful practitioner. இப்போ ஒரு மேம் வந்து கொஞ்சம் நெஃப்ராட்டிக் சிண்ட்ரோம் பற்றி பேசினாங்க. இதில் என்னை ஒரு நெஃப்ராலஜிஸ்ட் வந்து பார்த்தாரு ஓபியில். சார் நானும் பீடியாட்ரிஷியன் தான் சார், ஒவ்வொரு அம்மாவும் வந்து உங்களுக்கு 10 கேள்வி கேட்குறாங்க சார், அதனால் நீங்கள் பார்க்குற ஒரு 10 பேஷண்ட்டுக்கும் நீ ஒரு டம்ளர் தண்ணி குடிக்கணும்னு சொன்னார். அப்புறம் தான் தெரிஞ்சது குமரன் வந்து ஒரு ஈவினிங் ஓபி வந்து 20 டம்ளர்ஸ் தண்ணி குடிக்கிறாரு. ஸோ யூ கேன் ஜஸ்ட் காஜ் இஸ் practice strength. I am sorry if I have underestimated. 20, I think it's enough, into 10. Number 3, he is a successful father. Evidence வந்து நரேன் தம்பி இருக்காரு. He is a successful administrator. இவ்வளோ பேர் அவரை பாராட்டுறீங்க. That is absolute evidence. That is number 4. And amongst friends, he is very successful. அது இவங்கெல்லாம் சாட்சி. ஒரு 6 பேர் நாங்கள் வந்திருக்கோம். அப்புறம் கடைசியாக ஒரு சீக்ரெட்டு, இஸ் ஆல்சோ அ சக்ஸஸ்ஃபுல் ஹஸ்பண்ட். அது ரொம்ப கஷ்டம், நிறைய பேருக்கு தெரியும், பட் போஸ்ட் கிராஜுவேட்ஸுக்கு வந்து தெரியாது. ஸோ எ ஸ்மால் மெசேஜ் டு ஆல் தி மேல் போஸ்ட் கிராஜுவேட்ஸ். சொல்லட்டுமா? ஐ திங்க் குமரன் வில் நாட் மிஸ்டேக் மீ ஃபார் த சேக் ஆஃப் த யங்ஸ்டர்ஸ். ஸோ குமரன் வீட்டில் பேசுகிற 2 வார்த்தை வந்து சரிம்மா சாரிம்மா. எல்லாம் நோட் பண்ணிக்கங்க, டேக் அ நோட் ஆஃப் இட். தம்பி பர்டிகுலராக அந்த தம்பி. அப்புறம் இன்னும் 2 விஷயம். பொதுவாக வந்து தூத்துக்குடி வந்து உலகத்துக்கே முத்து கொடுக்கலாம், ஆனால் அது வந்து புது விஷயம் கிடையாது. அங்கே 82 பேட்ச் வந்து தூத்துக்குடிக்கே வந்து முத்து கொடுத்துருக்கோம். அதான் முத்துக்குமரன். இது யாருக்குமே தெரியாது. கடைசியாக நம்ம நாட்டுக்கு வந்து கொடி காத்த குமரன் இருந்தார். எங்கள் குரூப்பை இன்றைக்கு வரைக்கும் அரவணைச்சி கட்டி காக்கிறது வந்து எங்கள் முத்துக்குமரன். சூப்பர் குமரன். ஆல் தி பெஸ்ட். ஐ ரிக்வெஸ்ட் மை batchmates to ascend the dais.
Now we request the proud 82 batch of Madurai Medical College to honor our Deputy Superintendent Sir and their dear friend with a memento. Thank you to all the proud 82 MDMC members for gracing this moment. நம்முடைய மருத்துவமனை கல்லூரியில் செயல் வீரமும் விவேகமும் நிறைந்து விளங்கக்கூடிய நம்முடைய துணை கண்காணிப்பாளர் ஐயா அவர்களை பாராட்டுவதற்காக தமிழகம் எங்கும் விவேகத்திற்கு பெயர் பெற்ற விவேகம் திரு ரமேஷ் ஐயா அவர்களை பணிவன்போடு மேடைக்கு அழைக்கிறேன்.
என்னை நன்றாக இறைவன் படைத்தனன் தன்னை நன்றாக தமிழ் செய்யுமாறே. அருமையான ஒரு நிகழ்ச்சி. பீடியாட்ரிக் வேர்ல்ட்ஸ் 2025 இந்த ஹாலுக்குள்ளே வரும்போதே நானும் என்னுடைய ஃப்ரெண்டு ஒருத்தரும் வந்தோம். வரும்போதே எனக்கு வந்து டாக்டரான ஃபீலிங் எனக்கு ஒரு இருந்துச்சு. ஏன்னா அந்த அந்த என்ட்ரன்ஸில் இருந்த சில சகோதரிகள் வந்து நான் உள்ளே என்ட்ரு பண்ணும்போது சொன்னாங்க, சார் இது ரெஜிஸ்டர் பண்ணிவிட்டு நீங்கள் அந்த இன்னொரு வழி இருக்குது அது வழியாக போகணும் அப்படின்னு சொன்னாங்க. எனக்கு புரியலை. அப்போ நான் சொன்னேன், ஐ எம் நாட் அ டாக்டர், ஐ ஹவ் கம் ஹியர் அஸ் அ கெஸ்ட் அப்படின்னு சொன்னேன். அப்போ பரவாயில்ல சார், அப்போ நீங்கள் உள்ளே போங்க அப்படின்னு சொன்னாங்க. ரொம்ப மகிழ்ச்சியான ஒரு தருணம். இங்கே எனக்கு முன்னாடி பேசியவர்கள் எல்லாம் சொன்னாங்க, டாக்டர் குமரன் அவர்களை பற்றி, அவருடைய சிறப்புகளை பற்றி எல்லாம் சொன்னாங்க. எனக்கு உண்மையிலே நான் வந்து ஒரு ஆர்எஸ்எஸ் மெம்பர், சுயம் சேவக் என்று சொல்வார்கள். நான் எத்தனையோ எங்களுடைய அமைப்பில் மேடைகளில் பேசியிருக்கிறேன். இப்போ நான் இருக்கின்ற கட்சி சார்பாகவும் எத்தனையோ மேடைகளில் பேசியிருக்கிறேன். அப்பெல்லாம் இல்லாத ஒரு நடுக்கம் இந்த மேடையில் பேசும்போது எனக்கு இருக்குது. ஏனென்று சொன்னால், இங்கே இருக்கின்ற இந்த மேடையில் அமர்ந்திருக்கின்ற அத்தனை மருத்துவர்கள், திறமை வாய்ந்த அனுபவமிக்க மருத்துவர்கள் முன்னிலையிலே பேசுவது கொஞ்சம் கடினம் என்று எனக்கு தோணுது. டாக்டர் அருணாச்சலம் அவங்க பேசும்போது சொன்னாங்க, டாக்டர் குமரன் அண்ணா அவர்கள் வந்து அவருக்கு ஒரு சின்ன ஆசை உண்டு, பாலிடிக்ஸ்குள்ளே என்ட்ரு பண்ணணும் அப்படின்னாங்க. ஆனால் அவரே பேசும்போது பெரிய அரசியல்வாதி மாதிரி தான் பேசினார். இங்கே மேடையில் அமர்ந்திருக்கின்ற அத்தனை மருத்துவ அறிஞர் பெருமக்கள் அனைவருக்கும் மற்றும் இந்த கூட்டத்திலே பங்கு கொண்டிருக்கிற அத்தனை நல்ல உள்ளங்களுக்கு முதற்கண் எனது வணக்கத்தை தெரிவித்துக் கொள்கிறேன். குமரனனை பற்றி சொல்ல வேண்டியது எல்லாமே எனக்கு முன்னாடி பேசினவங்க சொல்லிட்டாங்க. எனக்கு அவர் வந்து ஒரு நெருங்கிய உறவினர் அப்படின்னு இல்லாமல் எனக்கு ஒரு மிகப்பெரிய நண்பர் என்று சொல்லலாம், மோர் தென் எ ஃப்ரெண்ட் என்று சொல்லலாம். அந்த அளவுக்கு எங்களுக்குள்ள ஒரு நெருக்கம். அவருக்கு எது ஒன்றுனாலும் சரி, மகிழ்ச்சியானாலும் சரி, எது ஒன்றாலும் என்கிட்ட ஷேர் பண்ணிக்கிடுவார். எந்த ஒரு கஷ்டம் வந்தாலும் என்கிட்ட உடனடியாக முதல்ல கூப்பிட்டு சொல்லுவார். அந்த அளவுக்கு எங்களுக்குள்ள ஒரு பெரிய நெருக்கம் உண்டு. அதே மாதிரி என்னுடைய ஒய்ஃப் வந்து ஒரு மருத்துவர், டாக்டர் சுனிதா. எனக்கு ஏதாவது ஒரு சிகிச்சை வேண்டும் என்று சொன்னாலும் தான் வந்து எந்த மெடிசனும் கொடுக்க மாட்டா, உடனடியாக அண்ணன் குமரன்கிட்ட தான் போய் கன்சல்ட் பண்ணி தான் நீங்கள் மருந்து சாப்பிடணும் அப்படின்னு சொல்லி அனுப்பி வைப்பாப்புல. எனக்கு முன்னால் பேசியவங்க பெரியவங்கள்லாம் சொன்னாங்க, இப்போ இருக்கிற 35 வயது இளைஞர்கள் எல்லாருமே குமரன்கிட்ட வந்து மருத்துவம் மெடிசன் சாப்பிட்டவங்க அப்படிம்பாங்க. அப்போனா நானும் அவர் கூட மெடிசன் சாப்பிட்டோம், எனக்கும் வயது 35 தான் நினச்சிக்கிட்டேன். அந்த அளவுக்கு ஒரு நல்ல ஒரு மருத்துவர். எல்லா வகையிலையுமே அவரை பாராட்டினாங்க. அதில் பாராட்டுவதற்கு எந்த விதமான ஒரு காரணமும் எனக்கு தெரியவில்லை. எல்லாமே அவங்க சொல்லிட்டாங்க. புதுசாக சொல்கிறதுக்கு எனக்கு ஒன்றும் தெரியலை. இருந்தாலும் அவர் வந்து குழந்தை நல மருத்துவர் அப்படின்னா அந்த பீடியாட்ரிஷியன் வந்து ஒரு குழந்தை போல் இருக்கணும்பாங்க. அதை விட முக்கியமானது எப்போவுமே குழந்தை தன்மையோடு இருக்கணும்னு சொல்லுவாங்க. குழந்தை மாதிரி இருப்பது வேறு, குழந்தை தன்மையோடு இருப்பது வேறு. அதாவது ஒரு சின்ன கதை சொல்லுவாங்க. ஒரு தாய், ஒரு அம்மா வந்து அவங்களுடைய பையனை வந்து பெட்லேருந்து எழுப்புறாங்க. தம்பி எழுந்துரு, நீ வேலைக்கு போகலையா, நீ காலேஜுக்கு போகணும்ல, நீ காலேஜுக்கு டைம் ஆயிடுச்சு, நீ எழுந்துருன்ட்டு ரொம்ப நேரமாக எழுப்புறாங்க. அந்த பையன் எழுந்திருக்கலை. அப்போ அந்த அம்மா சொல்கிறாங்க, நீ வந்து காலேஜுக்கு போகாததுக்கு 2 காரணங்கள் சொல்லு, உன்னை விட்டுறேன் அப்படின்றாங்க. அப்போ அவர் சொல்கிறாரு, என்னைய வந்து இந்த காலேஜில் வந்து எந்த ஸ்டூடெண்ட்ஸ்க்கும் பிடிக்கல அப்படின்றாரு. இன்னொரு காரணம், அங்கே இருக்கிற ஃபேக்கல்ட்டிஸ், அங்கே உள்ள ஆசிரியர்கள் பெருமக்கள் யாருக்குமே என்ன பிடிக்கல அப்படின்றாரு. அப்போ அவர் திரும்ப அந்த அம்மாட்ட கேட்குறாரு, நீ எனக்கு 2 காரணம் சொல்லி நீ ஏன் காலேஜுக்கு போக சொல்கிற அப்படின்றார். அப்போ அந்த அம்மா சொல்கிறாங்க, மொதல் காரணம் உனக்கு 52 வயசாச்சு, 2வது காரணம் நீ அந்த காலேஜினுடைய பிரின்சிபல். இந்த 2 காரணத்துக்காக தான் உன்னை காலேஜுக்கு போக சொல்கிறேன். ஏன்னா எத்தனை வயதானாலும் தாய்க்கு அவர் மகன் என்பது தான், இதுதான் குழந்தைத்தன்மை. அந்த குழந்தைத்தன்மையோடு தான் நம்மளுடைய அண்ணன் குமரன் அண்ணன் எப்பொழுதும் இருப்பாங்க. அடுத்ததாக சொன்னாங்க, நம்ம டாக்டர் அருணாச்சலம் பேசும்போது சொன்னாங்க, நம்ம அக்காவை பற்றி சொன்னாங்க, டாக்டர் தனலட்சுமியை பற்றி. அவங்க சொன்னாங்கன்னா எதையும் தட்ட மாட்டாங்கன்ட்டு. அது அன்பின் வெளிப்பாடு. எப்போவுமே நம்ம குமரன் வந்து அர்த்தநாரீஸ்வரராக இருப்பார். 50-50. கவர்மெண்ட் கூட 33% தான் பெண்களுக்கு இடஒதுக்கீடு கொடுப்பாங்க. ஆனால் நம்ம குமரனை வந்து 50% இடஒதுக்கீடு எப்பவுமோ கொடுத்துட்டார். அவர் கல்யாணம் ஆன நாள்லேருந்தே கொடுத்துட்டார். அதே மாதிரி நம்ம வள்ளுவன் சொன்ன மாதிரி, தந்தை மகன் காட்டும் நன்றி அவ்வையத்துள் முந்தி இருப்ப செயல் என்று சொல்லுவாங்க. அப்படின்னு ஒரு குறள் இருக்கு. ஒரு நல்ல தந்தை தன்னுடைய பிள்ளைக்கு, மகனுக்கு ஒரு நல்ல கருவியை கொடுக்க வேண்டும், நல்ல ஒழுக்கத்தை கொடுக்க வேண்டும், நல்ல பண்பாடை வளர்க்க வேண்டும். அந்த மகனை சமுதாயத்திலே ஒரு நல்ல மனிதனாக வளர்க்க வேண்டும். இந்த எல்லாத்தையுமே செய்து நம்மளுடைய நரேன் அவர்களை நல்ல ஒரு நிலைமைக்கு, இன்றைக்கி யூகேயில் ஒரு நல்ல ஒரு நிலைமையில் இருக்கிறாரு. அந்த அளவுக்கு அவருடைய கடமைகளை செய்து முடித்திருக்கின்றார்கள். இங்கே பேசினவங்கெல்லாம் சொன்னாங்க, பணி நிறைவு விழா அப்படின்னாங்க. பணி நிறைவு விழா எதுக்காக வருது, அந்த ஏஜை வச்சு சொல்கிறாங்க. எனக்கு அதில் வந்து எப்போவுமே உடன்பாடு கிடையாது. வயது என்பது நம்ம மனிதர்களால் கொண்டு வந்தது தான். இப்போ பணி நிறைவு அப்படிங்கும்போது நம்மளுடைய இளைய தலைமுறைக்கு வழிவிட்டு அவர்களுக்கு நம்மளுடைய அனுபவங்களை, நம்மளுடைய திறன்களை, நம்மளுடைய ஆற்றல்களை எல்லாம் சொல்லி அவங்களை வளர்ப்பது தான் இந்த ஒரு பணி நிறைவு என்பது. வயதை வைத்து வருவதாக நான் கருதவில்லை. அப்படி பார்க்க போனால் காட்டில் பார்த்து எத்தனையோ மிருகங்கள் இருக்குது, நிறைய வயதான மிருகங்களும் இருக்கும். அங்கே ஒரு மிருகங்களுக்கு உள்ள ஒரு உயர் அதிகாரி வந்து உனக்கு 60 வயசாச்சு இல்லது 70 வயசாச்சு, நீ இனிமேல் வேட்டையாடவே போகக்கூடாது அப்படின்னு சொன்னால் அந்த மிருகத்தினுடைய நிலைமை என்னாகும்? அதுக்கு யார் உணவு கொடுப்பாங்க? அதனால் வயது என்பது ஒரு தடையல்ல. இனிமேதான் குமரனை வந்து மேலும் பல பணிகளை இந்த சமுதாயத்துக்கு செய்ய வேண்டும் என்பதை இந்த நேரத்திலே கேட்டுக்கொள்கிறேன். எப்பொழுதுமே இந்த மாதிரி நேரங்களில் நான் வந்து பொதுவாக சொல்கிறது, பாரதியாருடைய கவிதையை தான் நான் கோடிட்டு காட்டுவேன். எனக்கு ரொம்ப பிடித்த கவிதை இன்று புதிதாய் பிறந்தோம் என்று என்னன்னு சொல்லி ஒரு கவிதை சொல்லுவார். அண்ணனுடைய அனுமதியோடு அந்த கவிதையை மட்டும் ஃபுல்லாக சொல்லிக்கிறேன். சென்றது இனி மீளாத மூடரே, நீர் எப்பொழுதும் சென்றதையே சிந்தை செய்து கவலை என்னும் குழியில் வீழ்ந்து குமையாதீர். சென்றதனை குறித்தல் வேண்டாம், இன்று புதிதாய் பிறந்தோம் என்று எண்ணமதை திண்ணமுற இசைத்து கொண்டு தின்று விளையாடி இன்புற்று வாழ்வீர் என்று அந்த கவிதை முடியும். ஒவ்வொரு நாளும் நம்ம புதுசாக பிறந்தோம், அதில் தான் அருமையாக சொல்லியிருக்கிறார், தின்று விளையாடி இன்புற்று வாழ்வோம்ட்டு. நல்லா சாப்பிட்டு நல்லா விளையாடி இந்த சமுதாயத்துக்காக உழைத்து இன்புற்று வாழ்வோம். தீமையெல்லாம் அழிந்து போம், திரும்பி வாரா, எந்த விதமான தீமையும் நமக்கு அன்றாது என்று சொல்லி அந்த கவிதையை முடிப்பார் பாரதியார். அந்த கவிதையோடு இன்று இந்த விழாவின் நாயகன் அவர்களை வாழ்த்தி, மேலும் மேலும் அவர்களுடைய சேவை இந்த சமுதாயத்திற்கு எப்பொழுதும் வேண்டும் என்று கூறி, அவர்களுக்கு எங்கள் குடும்பத்தார் சார்பாக வாழ்த்துக்களையும் பாராட்டுகளையும் தெரிவித்துக் கொள்கிறேன். நன்றி, வணக்கம்.
அழகு தமிழில் அருமையாக பாராட்டிய விவேகம் திரு ரமேஷ் அவர்களுக்கு நம்முடைய நன்றிகளை தெரிவித்துக் கொள்கிறோம். அடுத்தபடியாக அன்பும் அறனும் உடைத்தாயின் இல்வாழ்க்கை பண்பும் பயனும் அது என்பார் வள்ளுவர். இந்த விழா மேடையிலே நம்முடைய துணை கண்காணிப்பாளருக்கு அடுத்தபடியாக மிகவும் பேசப்பட்ட நபர் இவர்தான். நம்முடைய துணை கண்காணிப்பாளருக்கு துணையாக இருந்து கண்காணித்து கொண்டிருக்கக்கூடிய மருத்துவர் திருமதி தனலட்சுமி அம்மா அவர்களை பேச வருமாறு அழைக்கிறோம். நன்றி. And now I request Dr. Naren, robotic surgeon, UK, the proud son of our Deputy Superintendent, to share a few words about his legacy.
Good morning. Good afternoon, sorry. Thank you for requesting me to speak. Thank you everyone for coming here and for gracing this wonderful function. It is with immense pride, deep emotion and heartfelt gratitude that I stand before you today to speak about someone who means the world to me, not just as a professional, but also as a human being. So, என்னோட first memory of தூத்துக்குடி மெடிக்கல் காலேஜ் அண்ட் கவர்மெண்ட் ஹாஸ்பிட்டல் வந்து நான் 10-12 years 24 hours டியூட்டி இருக்கும். ஐ திங்க் வீக்லி ஒன்ஸ் 24 hours டியூட்டி, சரிங்களா, எனக்கு ஞாபகம் இல்லை சரியா. பட் ஸோ காலையில் ஒரு ஷெட்யூல் வந்து ரொம்ப க்ரேஸியான ஒரு ஷெட்யூல் அப்பாவோடது. அந்த நாளில் காலைல ப்ரைவேட் ப்ராக்டிஸ் முடிச்சுட்டு ஹாஸ்பிட்டல் போவாங்க, திரும்ப ப்ரைவேட் ப்ராக்டிஸ் வருவாங்க, திரும்ப கவர்மெண்ட் ஹாஸ்பிட்டல் போவாங்க. ஐ டோன்ட் நோ ஹவ் இட் டஸ் இட். ஐ ஸ்டில் கான்ட் இமேஜின் ஹவ் இட் டஸ் இட். பட் அப்போ நான் அந்த சின்ன வயசில் இருக்கும் பொழுது நைட் டியூட்டி அப்போ என்னை கூட்டிகிட்டு போயிடுவாங்க. ஸோ எனக்கு பேசிக்லி அந்த ஈவினிங் வந்து ஒரு பிக்னிக் மாதிரி இருக்கும். ஸோ நைட் டியூட்டி போய் அப்போது இப்போ இந்த புது பில்டிங்லாம் இல்லை, இட் வாஸ் பழைய பில்டிங் அப்போது. ஸோ அந்த ஒரு அசிஸ்டன்ட் சர்ஜன்ஸ் ரூம் இருக்கும், டியூட்டி அசிஸ்டன்ட் சர்ஜன்ஸ் ரூம். அங்கே ஒரு 2 பெட் இருக்கும், அது இன்னும் நல்லா ஞாபகம் இருக்குது எனக்கு. அங்கே போய் நைட் ஃபுல்லாக ஸ்பெண்ட் பண்ணுவோம். அங்கே ஃபுட்பால் வேர்ல்ட் கப் மேட்ச்லாம் பார்த்துருக்கோம் நினைக்கிறேன். சாரி, அது இங்கே சொல்லாமா இல்லையான்னு தெரியல. So there are such lovely memories that I will always treasure. The one thing that has not changed about him is his hard work. I've seen it since I was a child. I still have no idea how he sees, 200 patients, 150 patients a day. I cannot do it, and I'm 30 years younger than him. I just can't do it. He's a big inspiration in hard work. So, whenever I'm busy or work, nariya pressure or tension, I just always think, me and my wife we talk about this, and we always think, how does he does so much work? I don't know. I wouldn't like to know because I don't want to do, I can't see 200 patients a day. Also, I would like to talk about a very important but very ignored aspect of any doctor's life, about the kind of husband he has been and about the kind of father he has been. Again, na school படிச்சிருக்கப்போ he would be so busy. சில சமயம் நான் எந்த கிளாஸ் எந்த ஸ்டாண்டர்ட் ஞாபகம் இருக்காது. பட் தட் டசன்ட் மேட்டர் பிகாஸ் ஹி வாஸ் ஆல்வேஸ் தேர் ஃபார் மீ வென் ஐ நீடட் ஹிம். That's what matters at the end. He's always supported me. He's never asked me any questions. Any major decisions in life, I've made it, and he's always supported me. Madurai UG முடிச்சிட்டு I just told him I think I want to go to UK. He said, okay, I mean, என்னால் கூட என் மேலே அந்த நேரத்தில் அவ்வளோ நம்பிக்கை இல்லை. பட் both of them, they really believed me. I still don't know why, I still don't know how, but they trusted me. They still support me no matter what I do. Another important thing, everyone said he is a crisis manager, crisis man. Yes, he is. 3-4 years ago, I told him, I have a girl, I found a girl that I want to marry. There was a crisis as well. He managed it very well. He just asked, is that the right girl? I said yes, and he made the wedding happen. So I'll forever be grateful for that. And we married, we have a beautiful baby boy now, he's 8 weeks old. He's not just a wonderful father, he's a wonderful husband as well. Mom has always stood by his side through professional difficulties, personal difficulties, any emergency. She looks after him in only a way that she can. So finally, after 3 decades of service, you're hanging up your coat, not because your spirit has grown tired, but because you've earned this rest. You've earned the peaceful mornings. You need to spend more time with family now, more evenings, more days, more time in the UK with your grandchild, travel the world, come to UK a lot. But knowing you, I don't think it means the end of service. It only means the beginning of a new chapter. So on behalf of all of us, your family, your colleagues, your friends, the countless patients that your lives have changed, thank you to you. Congratulations on your retirement, and may the next chapter be just as fulfilling and as joyful as the one you're leaving behind. And before I close, I want to say something to all the doctors here today. It's not advice, but it's just something that I love saying. Please take care of yourselves, take care of all your families. You give so much of yourselves to patients, to others every day, but don't forget, your own health and your loved ones is what matters at the end of the day. You deserve it. Thank you all for listening, and have a lovely day. Thank you.
Thank you, sir, for your wonderful speech. Now, it's time for acceptance speech for our Deputy Superintendent, Dr. Kumaran, sir. கடல் கொஞ்சும் தூத்துக்குடி மாநகரில் தன்னகரில்லா சேவையால் தனித்துவம் பெற்று விளங்கக்கூடிய அரசு தூத்துக்குடி மருத்துவக் கல்லூரியின் துணை கண்காணிப்பாளராக இக்கல்லூரியின் வளர்ச்சியில் தூணாக, துணையாக, ஊனாக, உயிராக, உற்ற உறுதுணையாக விளங்கக்கூடிய எங்கள் துணை கண்காணிப்பாளர் திரு குமரன் ஐயா அவர்களை ஏற்புரை ஏற்பதற்காக விழா மேடைக்கு அன்போடு அழைக்கிறோம்.
Very good afternoon, everyone. Respected Dean Sir, Vice Principal Ma'am, Medical Superintendent, and my dear family members, my parents, and the HOD of Pediatrics, Thambi, Dr. Arunachalam and his team, and all the guests, all the students, those who have come in an amazing way to grace this function, and all my personal guests, those who have admired me and honored me through their words and through so many gifts, and my 82 strong backbone of my spirit and youthfulness, my 82 batchmate from MMC. They have come all the way from Kerala, from Madurai, from Sivagasi, from Aruppukkottai, all my dear friends and dear colleagues. And I take this opportunity to thank everyone, those who assembled to grace this occasion. And it has been a long journey of 35 years when I entered myself, and I remember Dr. Murthy, he is also in UK. We joined the same day in Sivagangai district. I joined in Pulidipatti, he joined somewhere in Sayalgudi, that was the Sivagangai district then, and he moved to UK. I came to Thoothukudi after finishing my diploma course in pediatrics in ICH. So I too wanted to move to UK or US, but fortunately some of the happenings in my family, I could not move there. But I wanted to have a live like a man, like a Western style. So that's what I used to say. You may be staying anywhere, but your vision should be like what you want to do. So that's how. So I practiced a lot. I actually had a balance in my government service and private practice, and my communication skills are very broad. So even I used to astonish myself, how can I immediately எனக்கு ஒரு ப்ராப்ளம்னா டக்குன்னு அவங்கள காண்டாக்ட் பண்ணணும்னு ஒரு ஃப்ளிக்கர் அடிக்கும், அது எனக்குன்னே தெரியாது, பட் இட்ஸ் மை ஹேபிட். And as a government servant of 35 years of service,
ஒரு குழந்தை ஏதாவது வருதுன்னு நம்மளால் முடிஞ்ச அளவு பண்ணணும்னு பார்ப்போம். பிகாஸ் ஐ ஹவ் பீன் டு ஸோ மெனி கவர்மெண்ட் ஆஃபீஸஸ், நீங்களும் கவர்மெண்ட் ஆஃபீஸ் போயிருப்பீங்க, ஒரு ரிஜெக்ட் பண்ணுற மூட்லேயே தான் இருப்பாங்க. போனாலே என்னடா எரிச்சல் படுற மாதிரி இருப்பாங்க. நம்ம அப்படி இருக்கக்கூடாது நான் நினைப்பேன் ஃபஸ்ட் திங். பிகாஸ் எந்த ப்ராப்ளம் வந்தாலும் முடிஞ்ச அளவு சால்வ் பண்ணி கொடுக்கணும். அண்ட் வி ஷுட் நாட் மேக் தம் டு மூவ் அவே ஃப்ரம் பில்லர் டு போஸ்ட். ஸோ அது எனக்கு சுத்தமாக பிடிக்காது. ஈவன் இன் கவர்மெண்ட் சர்வீஸ்னாலும் ப்ரைவேட் ப்ராக்டிஸ் முடிஞ்சால் கேஸ் எடுக்கணும், இல்லைன்னா தயவுசெய்து ரெஃபர் பண்ணி போயிட்டே இருக்கணும். அதே மாதிரி தான் கவர்மெண்ட் சர்வீஸ்லேயும். ஸோ ஐ வாண்ட் டு சே ஒன் ஆஃப் த எக்ஸாம்பிள். ஒரு சைல்டு 3 months ஏஜ், ஒரு 10 years பேக் இருக்கும், பெர்சிஸ்டன்ட் வாமிட்டிங்கில் வந்துக்கிட்டே இருந்தது. And the child has seen so many pediatricians. I found that something is fishy and I admitted the child in my hospital, and I found some obstruction, intestinal obstruction. It's happened to be annular pancreas. You know, annular pancreas is a pancreatic tissue band obstructing the duodenum, and it is causing persistent vomiting. Then I referred immediately, the same night I referred to the higher center at Tinaveli. And the child did not go to the government hospital. The child was taken to some private hospital. They spent some lakhs. They did not get any remedy. And then child came to me. The child did not come to me. The father came and told me, sir, sir, sir. That child is a very poor child from Sayarpuram on the way to in Thoothukudi district. அந்த குழந்தை ரொம்ப கஷ்டப்படும் சார், என்னால் என்ன செய்யணும் முடியல சார், நீங்கள் தான் ஏதாவது ஒரு வழி சொல்லுங்கள் சார் அப்படின்னாரு. எனக்கு உடனே ஜஸ்ட் ஒரு பொறி தட்டுச்சு. உங்ககிட்ட காசு இருக்காப்பா, ஃப்ளைட்டுக்கு போகிற மட்டும் காசு இருக்கான்னு கேட்டேன். ஆமாம் சார் காசு இருக்குன்னா. 10,000 எடுத்துக்கோ, நீ ஃப்ளைட்டை முதல்ல புக் பண்ணு அப்படின்னு. ஹி புக்டு இமீடியட்லி த ஃப்ளைட் ஃப்ரம் ஐ திங்க் ஸ்பைஜெட் இருந்ததுன்னு நினைக்கிறேன். அப்போ ஒரு 2 ஃப்ளைட் தான் போயிட்டு இருந்தது. அந்த ஃப்ளைட்டை எடுத்தான். நான் சொன்னேன், I had a contact in சென்னை ஏர்போர்ட். என்னுடைய ரிலேட்டிவ் ஏர்போர்ட் அத்தாரிட்டியில் ஒருத்தர் இருந்தார். அவரை கான்டாக்ட் பண்ணேன். மாமா இந்த மாதிரி ஒரு சைல்டு அனுப்புகிறேன், அந்த சைல்டு ரொம்ப சிக்காக இருக்குது, யூ ஷுட் மேக் சம் அரேஞ்ச்மெண்ட் டு இமீடியட்லி ஷிஃப்ட் த சைல்டு டு ICH ஸோ தட் த சைல்டு வில் நாட் டை அப்படின்னு. அதில் இன்னொரு கஷ்டம் ஆகிப்போச்சு. ஃபார் த ஏர் ட்ராவல் தே டிட் நாட் அக்செப்ட் த ஏர் ட்ராவல் ஆஃப் த சைல்டு பிகாஸ் த சைல்டு இஸ் ஸோ சிக். ஏதாவது டெத் ஆகி போச்சுன்னு நாங்கள் இமீடியட்டாக வேறு எங்கேயா லேண்ட் ஆகணும் சார். The treating doctor from Tirunelveli, he did not give a letter in writing that the child is fit to travel. அம்மாவும் குழந்தை அங்கே இருக்காங்க, பேரண்ட் இங்கே இருக்கார், அப்பா இங்கே இருக்கார். I gave the letter, ஒன்றும் ஆகாதுப்பா, கடவுள் மேலே பாரத்தை போட்டு நீ கிளம்பு அப்படின்ட்டு. ஸோ I gave a fitness letter to the child, and the child went to Chennai, and the child was admitted in ICH. சூப்பராக டியூடினல் ரிஜினாஸ்டமி எல்லாம் பண்ணி இதெல்லாம் வச்சு சூப்பராக ஆயிடுச்சு சைல்டு. அண்ட் ஆஃப்டர் 3 weeks த சைல்டு கேம் அண்ட் இட்ஸ் எ பிளெஸ்ஸிங் ஃபார் மீ. ஸோ இந்த மாதிரி கவர்மெண்ட் சர்வீஸில் ஒரு சில சமயம் வி ஷுட் டேக் சம் ஸ்ட்ரிஞ்சன்ட் ஸ்டெப்ஸ். இமீடியட்டில் ஒரு சில இது எடுத்து ஆகணும். அஸ் அட்மினிஸ்ட்ரேட்டர் இருந்தாலும் சரி, அஸ் ஆல் த டாக்டர்ஸ் யூ ஷுட் ஹேவ் அ ஷார்ப் பிரெயின் டு ஆக்ட். நம்மளால் முடியாது, முடிஞ்ச அளவுக்கு நம்ம ட்ரை பண்ணி பார்க்கணும். முடிஞ்ச அளவுக்கு வி ஷுட் ட்ரை டு uplift the soul. So that's my thing in the government service. So I used to utilize, இப்போ நானே சொல்லுவேன், I got so many contacts, எனக்காக யூஸ் ஆகல. So I used to use it for some of the problems, for my friends, for my colleagues, patients. இப்போ ரீசெண்டாக கூட ஒரு சைல்டு, இப்போ அருப்புக்கோட்டையிலேருந்து the child of a staff nurse. So she had a high heart rate, 254. I know the child was diagnosed with the WPW syndrome, and அங்கேருந்து அந்த நைட்டில் ஒரு 11 மணிக்கு அந்த மாதிரி அழுகுது. என்ன செய்யுது டாக்டர், ஹார்ட் ரேட் 254 இருக்குது, என்ன செய்யறதுனே தெரியலன்னு. She called me, and I took 1 hour to sort out the problem. I talked to Dr. Ullas Pandurangi, who is a physiologist. He took my phone, அந்த டயத்தில் அவர் எடுத்தார். Because of my contacts, he is a leading electrophysiologist in Trippulam. Our doctor, he on Indral, yes sir, Indral தான் போட்டுருக்கார் சார், பட் ஸ்டில் நோ கண்ட்ரோல். அண்ட் 11 o'clock அந்தம்மா எங்கிட்டு கூட தூக்கிட்டு போவோம் ஃப்ரம் அருப்புக்கோட்டை. ஸோ ஐ ஆஸ்க் த சைல்டு டு கோ டு த GH. I instructed the pediatrician to give adenosine injection, and he was very afraid to go. Summa kudunga doctor, one problem irukku. I take the whole responsibility. Kudunga, the child adenosine normal cylinder infusion pota paragu, the child came heart rate was 120, 130. Then the next day morning, the child went to Triple M hospital. There he had a consultation with the doctor. So he told after 15 kilos of weight, we will have some interventional thing. So till now, you consult to a doctor. So just it happened some few weeks before. So I actually give my benefits of contacts to everyone. So that's my strength. I don't know, it's all given from the God Almighty. So that's how the youngsters should do. And நிறைய பேர் சொன்னாங்க என்னை பற்றி ஆகா ஓவன் போனாங்க. I don't know how far I am fit into that pricings. And என்னோட இதெல்லாம், and after my retirement I want to serve to the community, and we have got another proposal with Dr. Ramanathan. We are building a multi-specialty hospital on the highways, and I think I will be useful there also. And by the grace of God and by the grace of my family, I am fit and healthy now. இறையன்பு ஒரு இடத்துல சொல்லியிருக்காரு, ஓய்வுன்றால் என்னன்னு கேட்டிருக்காரு ஒரு இதில் கொஸ்டின்ஸு. ஓய்வுங்கிறது சும்மா போய் படுத்து தூங்குறது கிடையாது. காலையில் நம்ம இஷ்டப்பட்ட நேரத்துக்கு எந்திரிக்கிறது, இஷ்டப்பட்ட நேரத்துக்கு தூங்குறது, தட்ஸ் நாட் ஓய்வு, தட்ஸ் நாட் அ ரிட்டையர்மெண்ட். ஸோ உங்களுக்கு பிடிச்சதை மிக அழகாக ரொம்ப நேரம் நல்லா அனுபவித்து செய்கிறது தான் ஓய்வு. ஒரு தோட்டக்காரர் இருக்கார், வருஷம் முழுக்க தோட்டத்தில் வேலை பார்க்குறாரு, ஒரு நாள் ஜாலியாக புக் படிக்கிறாரு, சண்டே உட்காந்து புக் படிக்கிறது, தேட்ஸ் அ ஓய்வு ஃபார் ஹிம். அண்ட் ஒரு புக்கு பைண்டிங் பண்ணுறாரு, இல்லை ஒரு ட்ராமாஸ்டிஸ் நோட்ஸ் எழுதுறாரு, அவர் ஒரு நாள் கொஞ்ச நேரம் தோட்ட வேலை பண்ணுறது அவருக்கு ஒரு ஓய்வு. ஸோ ஓய்வு, retirement is not to take rest very leisurely and spend time with all your mobile phones or watching TV, all watching this drama. That's not a retirement life. So retirement life should be a beneficial one, and till the last breath of my life I should go for the community, I should do something for the community. So that's my vision. And in this juncture, I like to thank the whole pediatric department who has taken immense steps to conduct the CME. Now I told my brother Dr. Arunachalam, தம்பி இந்த மாதிரி நான் ரிட்டையர் ஆக போகிறேன் தம்பி ஜூன் மாதம் அப்படின்னு. I think I told some in the month of February or March. அண்ணே அசத்திருவோம்னே அப்படின்ட்டு ஒரே வார்த்தையில். எனக்கு ஐ டோன்ட் நோ, சிம்பிளாக பண்ணி சொல்லிட்டேன் ஒரு வார்த்தை. எனக்கு ஐ ஹேட் அ வெரி கட் ஃபீலிங் தட் வெதர் வி ஷுட் ஏபிள் டு டூ ஸோ மெனி திங்ஸ். இதெல்லாம் எனக்கு இது பிகாஸ் திஸ் இஸ் நான் ஒரு பண்ணுறது ஐ கேன் டூ இட் இன் அலோன், பட் அரேஞ்சிங் அ CME and in such a big way, and 450 members on online registration, that's a very great honor to me. I thank the Department of Pediatrics, all my assistant professors, all my PGs, all my students who have done this honor excellently. Thank you for giving me the opportunity. Thank you.
Thank you, sir, for sharing your experience of work to all the juniors right here. For a man like him, age is just a number and retirement is just a new beginning. Now it's time to congratulate him with a honor from the Department of Pediatrics on the wonderful people on dais with a memento. Now I request the proud parents of our Deputy Superintendent Dr. Kumaran sir to join the dais for this honoring moment. And I request all the members of Department of Pediatrics, respected professors, respected chiefs, respected assistant professors, and dear postgraduates of pediatrics to join the dais. I request the respected people of the dais to honor the legendary pediatrician and our Deputy Superintendent Dr. Kumaran sir with a memento. Thank you all. Now it's time to honor the winners of pediatric quiz conducted on the special occasion of pediatric pearls for undergraduates. I request the people on dais to honor and give away certificates for the winners of undergraduate quiz on pediatrics. Ando Suzai Anand, Afrin Taj. Winners of undergraduate pediatric quiz, Anto Suzai Anand and Afrin Taj. I request our respected Dean sir to give away with the certificates for the winners. I request our VP ma'am and DS sir to join to give the certificates. The runners of UG quiz, Mariappan and Vijay Shankar. Runners of UG quiz, Mariappan and Vijay Shankar. Runners of UG quiz, Vijay Shankar and Mariappan. Next is about the postgraduate quiz on pediatrics. The winners are Dr. Narendra Nath and Dr. Suraksha. Winners of postgraduate quiz on pediatrics, Dr. Narendra Nath and Dr. Suraksha. Runners of PG quiz, Dr. Ramya and Dr. Maunika. Winners of PG quiz, Dr. Narendra Nath and Dr. Suraksha. Runners of PG quiz, Dr. Ramya and Dr. Maunika. Next is the prize for pediatric case presentation for undergraduates. The prize goes to Syed Hamim. First prize goes to Syed Hamim for a pediatric case presentation. First prize of pediatric case presentation for UGs goes to Syed Hamim. Thanks to all the beloved respected people on the dais. A special thanks to the beloved parents of our Deputy Superintendent Dr. Kumaran sir for their presence and making this occasions more special. Now it's time for all to stood up for national anthem. I request all the people on the dais and off the dais to stood up for national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you all.
Now let's continue with our next scientific session. Our next scientific session is on Pearls and Perils of Jaundice with the Case Nuggets by pediatric gastroenterologist Dr. Kavita Sampath Kumar ma'am. We welcome you ma'am. Ma'am is a senior consultant of medical gastroenterology and hepatology at Kaveri Hospital, Vadapalani, Chennai. Ma'am has done various publications like a rare case of non-Hodgkin's lymphoma in IBD on immunosuppressive therapy and efficacy of application of formalin therapy in radiation proctitis, and she also done a genetic studies on esophageal carcinoma in a tertiary care center in South India. And the chairpersons of this session are Dr. Selvasegaran sir, HOD, Department of Medical Gastroenterology, Thuthukudi Medical College; Dr. Babu Kandakumar sir, Professor of Pediatrics, Tirunelveli Medical College; Dr. Venkatraman sir, Professor of Pediatrics, Tirunelveli Medical College. I request the speaker and the chairpersons to occupy the dais. I request the chairpersons to occupy the dais. Dr. Selvasegaran sir, HOD, Department of Medical Gastroenterology, Thuthukudi Medical College; Dr. Babu Kandakumar sir, Professor of Pediatrics, Tirunelveli Medical College; Dr. Venkatraman sir, Professor of Pediatrics, Tirunelveli Medical College.
Proceed then.
Good afternoon to all. I would like to thank the organizers who has given me the opportunity
to honor Kumaran sir in his retirement life. And I would like to thank the Thoothukudi Medical College, Government Thoothukudi Medical College, Department of Pediatrics, who has asked me to present this case. I'm just going to talk about the pearls and perils of jaundice, a case nuggets. So why jaundice in toddlers and preschool children deserves a special attention? As we all know, the jaundice is an yellowish discoloration of eyes and sclera because of an elevated serum bilirubin. And unlike the neonatal jaundice, the jaundice in preschool children between 1 and 5 years is less common and often signals the underlying etiology to be taken into account. The clinical challenge we come across as a pediatrician and a gastroenterologist because of the broad differential diagnosis having an infectious causes, metabolic causes, genetic causes, and obstructive causes and autoimmune causes. Many a time it is often under-investigated in a primary care settings. The hepatitis A remains the leading cause of infection in many developing Indian scenarios. The rising recognition of the genetic and metabolic causes like progressive familial intrahepatic cholestasis and glycogen storage disorders are now in a common lane. So understanding the landscape, who gets the jaundice and why? The prevalence was estimated around 3 to 5% of Indian pediatric visits to the pediatric OPD between the children 1 and 5 years. The higher the peri-incidents have been noted in the rural as well as the peri-urban areas because of poor sanitation and delayed diagnosis. As I already told you, the common etiology may be either an infectious etiology, metabolic causes, and genetic causes, and obstructive causes. And often the infective causes we come across the hepatitis A infections. And why it is deserved nowadays of more attention is because many a time the 1 to 4 year children presenting with cholestatic jaundice often misdiagnosed, and usually these children need a elaborative workup and need to be referred to a tertiary care centers. Many a time it has been delayed at least 3 to 6 months before reach to the tertiary care centers, and meanwhile the child would have had a irreversible damage in the liver. In most of the time it is very difficult for us to come back to the normal life, and usually the cost for the workup in an metabolic causes, the child also needs a lot of money to be spent in a peri-urban and rural areas. And the hepatitis A may be the common still outbreaks in the rural areas and urban slums, and lack of awareness lead to many a time the jaundice in a severe way. So according to the cause of pediatric jaundice in India, which have been estimated as the common causes and hepatitis A and hepatitis E infection, which accounts for 40% of the population of 1 to 5 years old, and remaining maybe the 25% of the patients may be of genetic causes, which is often misdiagnosed. And many a time, sometimes we have nowadays come across the drug-induced liver disease also seen in children which they have been treated for some other causes. And hepatitis A, as we all know, it is a common but self-limiting, but sometimes it may be prolonged, and the familial intrahepatic cholestasis to be looked into with a clear history, and is often genetic and progressive disorder, many a time missed and many a time mismanaged before they reach the tertiary care center. In the glycogen storage disorders type 1, 2 and 3, many of them will have only the hepatomegaly and hypoglycemia and growth delay, and many a time we miss the hepatomegaly because many of us are nowadays stop investigating the patients only with the labs and not by the clinical examination. I request all the undergraduates to go for the basic clinical investigations. Before that, please examine the child in toto from head to toe. And the autoimmune hepatitis, which is often misdiagnosed, and it may lead to immunosuppression to be delayed in later age. The choledochal cyst, which is a surgical emergency, which present the child with a triad with abdominal pain, intermittent abdominal pain, jaundice and fever. And the allergy syndrome, as we nowadays we start seeing very less among children with the child has the typical triangular faces, and the drug-induced liver injury from either the antibiotics or due to the herbal medicine with the parents use may lead to the long stages of the jaundice. Now, it's how we are going to diagnose. Basically, when we see the child, We examine from head to toe, and patient examination will give us a lot of clue, and talking to the parents will give us fetch a diagnosis many a time, and taking the personal history as well as the family history and the genetic history is a mainstay in a pediatric population to get a diagnosis. The early bilirubin fractionization, looking into the fractionization of the direct and indirect fractionization. When more than 20% of your total bilirubin level is more in a direct fractionization, it immediately warrants the diagnosis. The time level of action should be very taken into account. If the jaundice is present for more than 2 weeks of jaundice, it still need a mandatory elaborative workup. The child may be referred to us with the pale color stools and dark color urine, then it signifies something, it's a cholestasis or an obstructive. It needs to be handled by the senior people. The first line investigation, as we all know, we do the complete blood count to look for the infection, and the liver function test, which clinches us the total bilirubin level, and the serum albumin will tell us whether it is an acute or chronic. If your albumin levels are low, the child is having a chronic liver disease. If the albumins are perfectly normal, then it is an acute scenario. The gamma glutamyl transferase clinches the diagnosis whether the jaundice is involved with the help of liver or without the liver. And the bile acids will tell us all other diagnoses. So basically we want to do the infectious screening for all children who present to us with jaundice, usually the basic workup of hepatitis A and E, and nowadays we start doing the HCV, cytomegalovirus and Epstein-Barr virus, which may also cause to the jaundice. But we all taken into the pregnancy and antenatal history to be taken into account in these cases. And the metabolic panel, nowadays we come across, do the lot of metabolic panels, which is the diagnosis in the early period, and it helps in galactosemia, tyrosemia, and alpha-1 antitrypsin deficiency to be identified very earlier age, even before the presentations. So the imaging will help us and tell us whether the child has a bright liver, telling it is an infectious hepatitis, or if it is having a dilated intrahepatic bile ducts, then go for the MRCP to rule out whether it is a choledochal cyst, any other obstruction, with the anticipation to look for the obstructive lesion should be taken into account. The genetic testing is usually recommended when there is a progressive familial intrahepatic cholestasis or the Alagille syndrome to come to a diagnosis. So let us now go to the case discussion. I have given a few cases for the basic understanding so that you can be able to diagnose in your daily day-to-day practice. The first case, the child is present with 2-year-old with fever, with vomiting for the last 5 days, and the mother start noticing an yellowish discoloration of the eyes and the urine for the past 1 week. There is no history of any drug intake or any transfusion, no history of taking any native medicines or. When we examined the child, we found to have an icterus with mild hepatomegaly and sometimes mild tender hepatomegaly, but there is no splenomegaly or ascites, and the weight and height is normal for the age. So it clinches us. By the history, it is only of acute onset. By the fever, it clinches us. It is of infectious causes. So when we go into the laboratories, into the labs, the total bilirubin of 9.8 milligram, of which the direct is around 7.2, signifies the child need an investigation. In the AST-ALT ratios shows it is always the levels are more than 1500 international units, tells that something is hitting the liver cells, leading to the enzymes to be elevated. When these enzymes are elevated, we know that the child is having some hepatitis, and when the GGT is mildly elevated, it says it is not as more of liver oriented. By knowing the albumin levels are very normal and the child is having a fever, we signify it is mostly of infectious causes. We do come across most of the time the infectious causes, most of the time it may be a hepatitis A infection. You may think, why the 2-year-old child is getting an hepatitis A infection and the child is not going to how to have a food outside. But it may be a common outbreak, or it may be the child would have gone to a function to have a food and child is easily affected there. So when we examine the anti-HIV levels, it was found to be positive. When the ultrasound, it is always as shown you a bright liver with hepatomegaly with normal biliary history. So by going into the history and these, we clinches our diagnosis, it is an hepatitis A infection. So by knowing hepatitis A infection, we all know we are going to only support the child properly to cross the next 4 weeks. So mainly the fluids, the nutrition and the fat soluble vitamin. We all know the liver is the storage organ and helps in the glucose metabolism. Whenever there is an infective causes, there are more possibility of hypoglycemia in these children. So we should concentrate more for the sugar methods and more carbohydrates and fat soluble vitamins to be given properly, and we should monitor the child with weekly LFT levels with improving the symptoms of the bilirubin related symptoms to be looked into it. Very rarely child may develop pruritus. Most of the time the child become completely normal by the end of 4 to 6 weeks. But the child to be monitored for the next 12 weeks until the LFT levels are coming to the baseline of normal. We all should know the child may be during this period may be infectious to the next neighboring kids, to be taken into account and to be instructed to the public health when they will come across with hepatitis A infection. This will have a normal growth and liver function test within 3 months of age. Sometimes this child, when it grows up, we all should remember that the hepatitis A may have a chronic course. Coming to this case, the child is 3-year-old, is having only fever and vomiting. For last 3 days, the child started showing yellowish discoloration of eyes and urine. The child also started developing pale color stools. This means the child is having the infection for long back, but the child is now only presenting as with fever. So because the pale stools and pruritus will not come immediately, when there is only an obstruction, you are expect it to happen within a day or 2. There is no history of drug intake or any transfusion, but one history clinches our diagnosis. The child's mother says the child has the similar episodes few months back. The next thing should come into our mind is we always want to rule out a hepatitis A infection because the child has similar infection few months back. So the child on examination will have icterus and hepatomegaly. There will not be have splenomegaly or ascites, but this child clinches and tell us the weight and height is less than 5th percentile. So it is a progressive disease. The child is having for long months, so it affects its growth and height, and the initial labs tell us the bilirubin of 9.8 grams. With ALT and AST, it's moderately elevated, more than 20 times the upper limit of normal of about 800 international units, and GGT is mildly elevated. The PT-INR is within normal limits, but anti-HIV IgM positive. So taking all into this, we all should know the hepatitis A infection may have a relapse, and sometimes it may have a chronic course. Whenever you come across a child with a young child with a jaundice with history of previous episode, please look into them and ask them. And this case is a prolonged cholestasis in a 3-year-old child with the following and hepatitis A infection. This child to be properly treated with a supportive care, mainly the fluids, nutrition and fat soluble vitamins. For pruritus to be controlled, the child may be started on cholestyramine. Many a time they may have partial response and sometimes they may not have, and that to be taken into account. These prolonged cholestasis, the child may need some amount of steroids to be taken into account, 1 milligram per kilogram per day for 2 weeks, not more than 30 milligram, to be tapered weekly, and slowly the symptom dissolves. The completion will resolution to become a normal child, it takes 6 weeks. By normal growth and LFT, later at the end of 3rd month of completing your treatment, the child may achieve. So we want to know something about the prolonged cholestasis of hepatitis A infection. Usually the features of viral hepatitis A are pruritus, diarrhea, fever and weight loss. The serum bilirubin will be more than 10 milligram per deciliter. The clinical course may last for more than 12 weeks, and many a time it would have been missed. The initial episode of 3 to 5 weeks and followed by a period of remission is characterized of normal liver chemistry, where we think the child has become perfectly normal, having some amount of cholestasis. So we ask the pediatrician to follow up with the LFT for the next 3 to 4 months, because sometimes the cholestasis only will signify only with a slightly elevated alkaline phosphatase and GGT. Later they may be having a rise. The relapse may mimic an initial episode of acute hepatitis. The full duration of the illness ranges from 16 to 40 weeks from the onset, and the immunoglobulin level of IgM antibody level may be present throughout all this 12 to 40 weeks may be there in children, signifies it is an acute infection with a prolonged course. And hepatitis A have been recovered from the stools during the relapse, and extrahepatic manifestation of hepatitis may include evanescent skin rashes and transient arthralgias. So the rare neurological manifestation, sometimes we come across in the neurological ward where we do go for the rounds, we found the child is presenting with seizures. We would have got a call, madam, the child is having elevated liver enzymes even before we are starting our drugs. So these are the hepatitis A is not only known for generally the liver symptom, and sometimes it may directly affect the nervous system, leading to encephalitis and meningitis and other neurological issues. Seizure may be a only presenting symptom in some children where they may not manifest with the other typical acute fever or pruritus and admitted in the neurological ward. The possible mechanism was thought to be is because the virus directly affecting the brain tissue leading to encephalitis and indirectly through the metabolic disturbances. The importance of differential diagnosis in this case, when the seizures the child is present during an hepatitis A infection, it is crucial to cut other causes of seizures also should be worked out in detail before we are not ordering the drugs for that and only going to continue the drugs for this. And the encephalitis protocol also to be followed in these children. Coming to the third case, the child is 3-year-old with the persistent jaundice noted since infancy. The child slowly developed increase in pruritus, especially during the night, and the child is having a pale color and dark color urine, and the child also, the pediatrician started noting there is a growth faltering and irritability in the child. When we go into the family history, the mother having a consanguineous marriage and having the elder sibling of the child died at liver cell failure around 6 years of age. So on examination, the child has icterus and excoriation marks with shiny nails and hepatomegaly. There is no ascites or splenomegaly. The weight and height is less than 3rd centile. So these children, they are present from young age but was undiagnosed. When we do the initial workup, the bilirubin may not be that much elevated, it is around 6.2 gram. AST and ALT levels are mildly elevated, and gamma GGT levels are perfectly normal, making us more confused whether it is a liver related or a hemolytic causes or other causes, and the bile acids significantly slightly elevated, and ultrasound shows a normal biliary. We want to rule out all other causes of hepatitis, of infective causes, taking into account of torch infections of hepatitis A, B, C, and everything is normal. This child may be having a progressive familial intrahepatic cholestasis. We all know the progressive familial intrahepatic cholestasis are of 3 types, type 1, type 2, and type 3. All involve the gene mechanisms. The type 1 may not lead to their life into the adulthood. The type 2 is more commonly going for an adult life, and type 3 having other ear infections to be taken into account. The management may be the medical management is a simple UDCA. When not controlled, we may add on rifaximin and cholestyramine for the itching and pruritus. Mainly these children should be given a nutritional support with fat soluble vitamins. Many a time they may go to their normal life. The surgical, we want to find the cause, how we are going to drain it, and help with the partial external biliary diversion to be performed if needed, and significant improvement of the pruritus and growth will occur over 6 months. Coming to the fourth case, this child is a 5-year-old child. The child present with jaundice and abdominal distension for the last 3 weeks. There is no fever, there is no vomiting, there is no any drug history, but the child is only presenting with jaundice and fatigue with slightly abdominal distension. There is no family history of liver disease or no autoimmune conditions, and on examination, as we all know, when we come across when the child is having only fever and vomiting with jaundice, it always signifies hepatitis A. When there is a prolonged course, we all know the cholestasis, but this child having a fatigue and jaundice, but there is no fever. On examination, the child is having icterus and hepatomegaly. There is no splenomegaly, but some amount of ecchymotic patches are seen on the skin. Non-examination of the CNS, the child is drowsy and the plantar extents are bilaterally. But the growth parameters are normal. It signifies it is not a prolonged course. In initial workup, the total bilirubin is around 12.8 grams and the ALT and AST levels are mildly elevated and normal serum bilirubin. So it signifies it is not a prolonged liver disease, but something is happening to the child. And the gamma glutamyl transferase is mildly elevated. Since the child is having ecchymotic patches, the PT-INR is slightly elevated of around 1.5. Here that clinches the diagnosis. The serum ceruloplasmin levels are low and the serum copper levels are low and the viral markers are negative and the ultrasound says the liver is having a coarse echo structure and the KF rings is absent. So I know you all clinch your diagnosis, it's Wilson disease. See, in a pediatric age group in a Wilson disease, most of the time up to 5 years many Wilsons may not manifest. We all know Wilson's is an autosomal recessive trait. Many a time they start manifesting from 3 to 5 years of age. We should be very careful. We should ask for the maternal history so that we can get a diagnosis. So the liver of the Wilson disease may manifest in a different forms. It may be manifesting with the liver chemistries like the patients having asymptomatic elevation of transaminases, hepatomegaly and splenomegaly, and it sometimes present like a neuro-Wilson where the child parents come to us and say, my child is not writing good as the child was earlier. That because of the writhing movement, the child may not able to complete the handwriting in a proper way, which may clinch us a clue and we should take it into account to work up in detail. Sometimes the child may present with very KF ring, but it's very rare. Most of the time KF ring we have come across only more than 8 years of child, and sometimes they may present with simple acute hemolytic anemia with a high colored urine with normal color stools. So we become confused. So anyway, going to the history will help us in diagnosis. So what are the therapies nowadays available for the Wilsons? So the research on new ongoing therapies say such biscoline thymolibdate, which may offer a good treatment in near future, and gene therapy has been explored and restore the function in ATP78 gene, which is defective in Wilson on the way. And the important consideration is these children to be counseled in a great way, both with the parents, that the child may need a long course of treatment, and never ever the parents should take the child for the native treatment. Because many parents, what they do, when they come across, when the jaundice is not settling, they automatically go to the native treatment. It should be clearly explained them, will worse the diagnosis and they may leave the child. So hence we should be properly counseling to the parents. The Wilson disease requires a lifelong treatment to prevent the copper accumulation and the disease progression. Early diagnosis and treatment helps the liver modification in a better way and significantly help the child. The family screening should be done. Many a time the first degree relatives of the individual should be screened for the condition, because they may be having a trait and they may not have manifested the disease and the child would have manifested. The treatment strategies include the copper chelation. Chelating agents like D-penicillamine or trientine binding to the copper in the body, allowing to excreted in the urine, and penicillamine is more likely to cause side effects, fever or the kidney problems, and trientine and dosage adjustments to be given. The management includes the zinc acetate and modifications with low copper diet and water source. It's important for copper levels to increase in drinking water to be taken into account and the copper pipes to be avoided. The case 5, I just say this is a case with 4-year-old with jaundice with abdominal distension with 3 years, where there is no splenomegaly, only hepatomegaly with icterus, with ALT levels are more than thousands, PT-INR levels are very high and immunoglobulin levels are very much elevated with ANA positive and ASF positive. Probably this is a case of autoimmune hepatitis. We all know we have a lot of workup and these things for the autoimmune hepatitis. This child may be an autoimmune hepatitis. The child would have been benefited by giving treatment with steroids. When the early diagnosis and the immunosuppression, would this help the child? Before starting the steroids, please look into that the child is being immunized completely to be taken into account before starting a steroids, because the child may need the lifelong time. And The case 6, this is a 2.5-year-old child with progressive abdominal distension with afebrile seizures in an infancy, with round face, with hepatomegaly and splenomegaly, with height and weight is less than third centile, will always say yes, this is probably some amount of metabolic disorders where the child present with low clinches your diagnosis whenever the child is having an hypoglycemia with hepatomegaly and splenomegaly with round faces, with failure to thrive. It should be always many a time any metabolic disorders. First of its which the child surviving, you should think about the glycogen storage disorders should be worked into account. In this case, the erythrocyte glycogen which was very high and the leukocyte glycogen debranching enzyme activities was very low, helps in diagnosis of glycogen storage disorders. The management will be only to complete the diagnosis. We want to do a liver biopsies to help us to clinch the diagnosis. Only the frequent feeds with the cornstarch therapy with long standing action will help the child to help in long term treatment. So the management guidelines, when we want to refer these children to the higher referral centers, when you have seen an autoimmune control, autoimmune hepatitis, where the prurite is not coming into control, the child may need a steroids as well as the azathioprine to be started and to be maintained in a different way, to be referred to the higher referral center. When there is a metabolic causes, when they have, you couldn't able to diagnosis to be worked up in detail and genetic causes to be worked up to be referred to the tertiary care centers. And always the supportive and specific therapy to be directed to the children. The supportive therapy may be like hydration, fluid, fat soluble vitamins, and this glucose level to be monitored, and the pruritus to be handled in a very proper way. The pruritus most of the time handled with ursodeoxycholic acid will help. The second line drugs, when it not settled, sometimes the rifampicin and naltrexone will help you. The direct specific therapy, if you diagnose as particular infections, then it can be treated, especially the antiviral drugs. In the case of hepatitis B, because many a time the hepatitis B may not manifest as a disease. The childhood may be having a carrier, may manifest the disease in the later age. The metabolic disorders, the dietary modifications to be taken into account, and the genetic disorders, you should always think about the biliary diversion in the case of progressive familial intrahepatic cholestasis. Whenever you come across an autoimmune hepatitis, the first thing and foremost to check the child for all vaccination to be completed. Once we are going to start the steroids, we are not going to stop it. The nutritional support is a mainstay of the treatment in the case of cholestasis. The prevention of malnutrition and the fat soluble vitamin should be completed, and the calorie intake should be increased to 120 to 150% of the daily needs to be given, and mainly the medium chain triglycerides are given to correct the fat soluble vitamins. All the fat soluble vitamins of A, D, E, K should be taken in proper account to be given to the children, and the anthropometry will clinch the diagnosis whether the child is growing well or not. So the referral to gastroenterologist when the conjugated bilirubin is more than 20%, having more than 1 milligram per deciliter for more than 2 weeks, persistent abnormal LFT when there is a transplant indications. The transplant indications may be differ from each and every children. We want to counsel as well as the parents and the family for the transplant. Nowadays we do lot of transplant for the young children for the metabolic disorders, but before that we want to do a workup in a great way before we tell them, the parents. In the case of intractable pruritus, the growth failure and decompensated cirrhosis or acute liver cell failure where the INR is very high and rising in an alarming level, all these children to be referred immediately when there is a coagulopathy, encephalopathy, and rapid worsening of liver functions. So absolute liver transplant indication may be when the child is having a fulminant hepatitis. As we all know, the fulminant hepatitis is an acute hepatitis where the child goes for an acute liver cell failure with all the coagulopathies and jaundice and neurological manifestations. When there is an end-stage liver disease going for a decompensation, when there is even an intractable pruritus for the children which is very difficult to treat, may be an indication for the liver transplant. Growth failure and nutritional support should be adequately achieved. When not done, can be think about it. The relative indication may be that when there is a recurrent cholangitis and hepatic malignancy or any progressive fibrosis. Going back to home, what we are thinking about, the jaundice in toddlers is always a red flag sign. think always beyond the hepatitis A infection between 1 and 5-year children. It may be a genetic cause, autosomal cause, or autoimmune causes may be increasingly nowadays are recognized beyond hepatitis A. The timely bilirubin fraction taken into account, because many a time what we do, the LFT in the children, they say only the total bilirubin level. When we ask for a complete LFT only, they will give us the, because very difficult for us to take in a children. To be done always, the structured and diagnostic pathways improve the efficacy and reduce the misuse diagnosis. The primary care providers, you are the first line people, you are going to diagnose and send us to the patients for the further treatment. I hope you would all understand with the basic needs which I have given you. And the multidisciplinary care and early nutrition and family counseling are always essential in the jaundice when there is prolonged, because it needs a long time treatment, because many times the parent jump to the native treatment and come back in a different way, in a different schedule, and make us more worrisome to treat them. Thank you.
Very nice presentation. I have two questions.
Yes.
One regarding hepatitis E virus infection.
Yes, sir.
How far it is common in the pediatric age group? And we know that E is most commonly associated with the pregnancy population.
Yes,
Is there
come across only, I have seen of my practice only one children with hepatitis E infection. Mother had an infection and the first sibling also had. Otherwise, we do not most of the time come across with hepatitis E infection. We more come across only with hepatitis E. Yes, sir.
And second thing is the role of steroids. Most of the time, acute viral hepatitis A, most of the time the patient will recover without starting any steroids.
Yes, sir.
Is there any clinical guidelines to state it is a steroid has a beneficial definitely, or in which condition? Not all cases will need steroids. Is there any guideline to say?
So in a hepatitis A infection, during the primary infection, many a time the child will get recovered within 4 weeks of treatment. We don't use steroids, but sometimes we do become because of the prolonged course, and sometimes when the child is having an intractable pruritus and cholestyramine not, the child is going for very underneath of their growth centiles. This yardstick is decided by only is. There is no definite guidelines to start steroids in the children. But we do use in the adult population nowadays in many a time. When it is present for more than 6 weeks, not at getting control, we are using. But in the pediatric, we assess each case in a different way. According to the case needs, only guidelines to start steroids in acute hepatitis A. But when there is a prolonged course of cholestasis, we are using it, sir.
That means in prolonged
Yes,
steroids. Thank you. Any question from audience?
One question, ma'am.
Yes, sir.
When we have to give hepatitis A vaccine?
So usually what happens, we say the hepatitis A virus, when the child got the infection, usually we don't come across, earlier days we don't give vaccine once the child has got. But nowadays what do we say? We wait for 6 months after the normalization of LFT, the child may be vaccinated in the routine schedule with hepatitis A vaccine. But most of the time we don't advise, sir, once the child has got it. But nowadays nowadays the hepatitis A vaccination schedule has been preponed. So it has been, the first dose has been received at the 12th. The second dose will be pending before they reach us, sir.
Thank you, ma'am. That was an informative session. Now I request Dr. Selvasegaran sir, HOD Department of Medical Gastroenterology, to felicitate Dr. Kavita Sampath Kumar, ma'am. Now I request Dr. Naresh sir, Associate Professor, Department of Pediatrics, Thuthukudi Medical College, to felicitate Dr. Selvasegaran sir. Thank you, sirs. Thank you, ma'am. Now let's move on to our next session, management of common congenital heart disease. Before moving on to the next session, I call upon the Department of Obstetrics and Gynecology to felicitate Dr. Kumaran sir. Thank you, ma'am. Now, Kumaran sir to stay on the dais. Now I call upon the TKMC alumni members to felicitate. Thank you, sir. Now let's move on to our next session on management of common congenital heart disease by pediatric cardiologist Dr. T. Vishwanathan, sir. We welcome you, sir. The chairpersons of this session are Dr. Balamurugan, sir, HOD Cardiology of Thuthukudi Medical College, Dr. Venkata Saravanan, sir, HOD Pediatric Surgery of Thuthukudi Medical College.
Good afternoon to all. This being the pre-lunch session, I don't think I'll be taking much of your time. So I switched to adult cardiology quite early. The first posting after I finished my pediatrics was Tuticorin Medical College, and I still have fond, vivid memories of all the colleagues and who are professors now, Dr. Arunachalam sir, Padmanabhan sir, Vellapandiyan sir, Venkatraman sir, and Kumaran sir. So I think I cannot forget, and that 1 year was it is still a beautiful memory. And I wish Dr. Kumaran good health, wealth, and a nice retirement life. So moving on to the topic per se, and it is not about management of congenital heart diseases. I'll deal shortly about when to refer, when to intervene, what is the timing of interventions in congenital heart disease. And again, congenital heart disease as such is a big topic. Cyanotic, acyanotic, valvular, cardiomyopathies. I'm not going into everything. It is basically about common acyanotic heart diseases, your VSDs, ASDs, PDA, and your aorta pulmonary window, and maybe valvular heart disease. And I'll touch upon tetralogy of valve, these being the most common. because all other cyanotic heart diseases, you take TGA or TAPVC or single ventricle, tricuspid atresia, truncus, all of them will be referred quite early because cyanosis will be picked up and child will be sick and they will be referred early. And it is with these acyanotic heart diseases, VSDs, and you have seen so many stories of parents saying this hole will close by itself and child landing up later with Eisenmenger syndrome. We've seen so many patients like that. So when to refer and what will be the ideal mode of intervention will be the focus of my talk. And this, I think this is a useful classification when you classify into acyanotic and cyanotic heart disease. So acyanotic is what we are going to primarily deal with. It is the left-right shunt lesions. So pre-tricuspid, the ASDs, and post-tricuspid you have got the commonest being VSD and the PDA, AP window, and you can also have obstructive lesions which are not so common, like pulmonary valve stenosis or aortic stenosis and coarctation of atresia. Other things like rarer coronary anomalies and LV outflow obstruction, congenital MR, congenital MS are very, very rare, and if you get to see them, they will be referred immediately. So the focus of the discussion will be about how to identify this and when to refer. So coming to the first and very common thing is atrial septal defect. So atrial septal defect, may not be symptomatic even in childhood. A child will have a large ASD and still be alert, active, and it is most commonly diagnosed by say 20 years of age when they land up with some palpitations or something. And a point to note is Eisenmenger is also quite late in ASDs. When you know there are several types of ASD, you have like the commonest being the ostium secundum ASD, and then the sinus venosus ASDs, and the ostium primum ASDs, and the rarer variants like unroofed coronary sinus. So of these, the commonest we get to see is the ostium secundum, and which typically presents with volume overload, whereas the other rarer types, the sinus venosus ASDs, SVC or IV, need to be referred for surgical closure because they do not close spontaneously. It is only the ostium secundum ASDs that close spontaneously, and again ASDs into small, moderate and large based on the size. It differs, varies, but again the point to remember is a large ASD diagnosed say more than 8 millimeter in the newborn is unlikely to close. So it is not so malignant and they can wait, it will close is not true. And again ASD with ASD in combination with the PDA, they are more prone to develop heart failures and develop pulmonary hypertension much earlier. And ASDs in Down's phenotype, they develop pulmonary hypertension much earlier. So ASD, suppose you get a report of ASD from echo, what is the type of ASD, what is the size, and is or not. These three things are important. If it is a sinus venosus ASD, SVC or IVC, you cannot ask the child to wait because they do not close. They have to be closed surgically. Now they are doing stenting. Covered stent is being used. That is a rarer type. Ostium primum also do not close spontaneously because they are associated with the AV canal defects. So this is from a left atrial point of view. Sometimes with a finding of PFO, patent foramen ovale, and is it to be closed? And again depends. The role of PFO device closure is being debated, and there are certain indications for PFO closure. But PFO, as the anatomy says, it is between the ostium primum and secundum, and it is very important to differentiate it from a true ASD, because a small child with PFO diagnosis should not be alarming for the parents. The parents should not be a hole in the heart because many of the PFOs might close spontaneously later in life unless they are associated with other defects. Echo picture, transesophageal echo picture of ASD, where you are able to see the defect between the left atrium and right atrium, and you know what happens in ASD. The shunting across LA and RA causes volume overload of RA and RV, and over time these patients can go on to develop pulmonary hypertension, and then they will develop symptoms, commonly by 20 years of age. Are several types of ostium secundum ASD itself. Like there is something called multiple fenestrated ASDs, where it may appear as a single ASD, but the ASDs may be very, very small, and all of these can volume overload. And the shape of the ASDs may be different. It may be large. So decide on closure, and somebody decides on closure, or the ASD with volume overload. When you say volume overload, if RA and RV is dilated, the ASD is a significant ASD. If RA and RV is not dilated, the child has not gone into volume overload status, and ASDs need not be closed. So it is not about the size, it is about the presence of RA RV volume overload, which indicates the shunt is at least more than 1.5:1. Is more than 1.5:1. So the ASDs can vary in shape. They can be oval, circular, multiple, fenestrated, Swiss cheese. There are several varieties. So all these have implications on choose a device. You may have to choose a different device. So Swiss cheese, other multiple fenestrated ASDs, you might need to choose a device which is large and should close all the defects. And the commonest device we have is the Amplatzer device. There are several variants. LifeTech produces one, Cocoon produces one. So when you go to the guidelines, these with volume overload, that is again RA and RV dilatation, or a QP/QS ratio more than 1.5:1, they need closure. When to close? You can wait up to 2 years. 2 to 4 years is the ideal age, because younger children it is a little difficult to give anesthesia, but you can close. A 1-year-old child with a large ASD with symptoms, you can close even with the device. The other thing which is important when you choose a device closure is proper assessment of the ASD. That is, the ASD needs to have adequate rim in place. So if the device ASD is amenable to device closure will be the ideal choice between 2 to 4 years. But what are the ASDs which will require surgical closure? As I said, sinus venosus ASDs, ostium primum ASDs, and large ASDs where the rim is not adequate. So we say typically the IVC rim and the aortic rim, if they are absent, then the device is likely to embolize and your device closure may not be good. Assessment of the rims is important. Sinus venosus ASD surgery is the only option, no longer. They are using covered stents nowadays. Small ASDs you can follow up, as I said, less than 1.5:1 you can follow up. Moderate ASDs, 1.5:2:1, closure. Large ASDs, anytime when you diagnose, you have to close. What will happen if you don't close? We have seen patients with ASDs presenting at 40 years and 50 years of life. So when they become ASD, the shunting worsens because the LV diastolic dysfunction sets in. They have associated hypertension. So the diastolic filling is impaired, LA pressure gets increased. The shunting across the defect worsens, and adults with ASD fare poorly, and they can still undergo closure, either surgical or device, and after properly assessing. So this is one thing, and certain select subgroups. For example, if the pulmonary pressure is more than 50, it means the pulmonary hypertension is at least moderate to severe. So you have to be a little careful, because if you close a ASD for a child with moderate to severe pulmonary hypertension, of course the forward flow may not be there at all. So you have to do cath studies and then decide on closure. And the next would be your commonest, which will be the ventricular septal defects. Important diagram to understand. This is from the right atrial perspective, right ventricular perspective. You remove the anterior part of the right ventricle, and the blue shaped thing there overlies the tricuspid valve. And remember, the aorta, the cusps, RCC and NCC. The anterior most is RCC and the posterior is NCC. The septal tricuspid leaflet is closely related to non-coronary cusp. And any defect in this region is a membranous defect. A membranous VSD is where the septal tricuspid leaflet and the NCC is joined together. That is called the membranous septum. And anything below the tricuspid valve is the inlet septum. And the right ventricle, the morphologically, you've got a band of tissue which runs beneath the non-coronary cusp, that is called the crista. So any defect above it is called supracrustal defect, and below it is called infracrustal. So this is important because most of the perimembranous VSDs are infracrustal, and supracrustal is just beneath the aortic valve. They are called outlet VSDs, doubly committed VSDs, subarterial VSDs, different names. So why this distinction is very important? Because supracrustal VSDs, outlet VSDs, they rarely close. The commonest VSDs which close spontaneously are the perimembranous VSDs, we know, and of course the muscular VSDs, whereas the supracrustal VSDs do not close. So a proper echo and identifying what type of VSD it is very important. And assessing the size, the sizing the VSD, again it can be assessed in various ways. Yeah, you can say it in size in relation to the aortic annulus, or more commonly, just like your ASD, whenever there is volume overload, here the LA and LV will be dilated. If there is a VSD with LA and LV dilatation, it is a significant VSD with significant QS more than 1.5:1. That needs to be closed. So again, the commonest thing which we see is, we have seen so many parents saying, child had a hole in the heart and the doctor said it will close spontaneously, so don't worry. So that is not to be encouraged, and you have to make sure it is a perimembranous VSD, small VSD or a small muscular VSD before telling them you can wait. Because once they go on to develop Eisenmenger, there is no way out for them, just drugs. So this will be the inlet VSD cartoon, where I said just beneath the aortic valve we have got the supracrustal VSDs. Spontaneous closure is uncommon, though they are very rare. They just form only 6 to 10%, but they do not close. The problem is they can go on to develop the aortic cusp prolapse and aortic regurgitation. Whereas your commonest perimembranous, which constitutes 80% of the VSDs, they can close spontaneously. There are several mechanisms which you would have read, by aneurysm formation or spontaneous closure, other things. Your muscular VSDs, they close, but again, the child can have a very large muscular VSD with LALV dilatation, which needs to be closed. Simply because it's a muscular VSD doesn't mean you have to wait. And the inlet VSDs, they also do not close spontaneously. If you want to close, you can do surgery, but some VSDs are amenable for device closure. Just like your ASD device closure, you've got dedicated VSD closure devices, particularly for the perimembranous defects. And the defect has to be little away from the aorta, because if it is very close to the aortic annulus, it can impinge upon the aorta, can cause aortic prolapse, can cause heart blocks. So again, assessing what type of VSD, whether there are adequate rims, whether this can be closed with a device are important. So these are the echo views which will tell you which type of VSD you'll be picking up. Echo views. So your RVOT, the commonest plaques view, so which will be a perimembranous, subarterial, inlet and muscular. So these are the echo views. C, cartoon C will be your typical perimembranous VSD. It is not right to say subaortic VSDs because all VSDs are subaortic. So subaortic VSD is not a correct term to use. So you use either a perimembranous VSD, and pediatric cardiologists, they use intraconal VSD conus. So when you say subaortic VSD, it is not equal to perimembranous, because perimembranous VSD, outlet VSD, inlet VSD, all of them are subaortic. Okay. So just remember that. So gradient VSDs, as I said, spontaneous closure is common, you can wait. Moderate VSDs, where the shunt ratio is more than 1.5:1, you can close as early as by 1 to 2 years of age. Suppose the child is symptomatic with recurrent respiratory infections, failure to thrive, or features of failure, you can close much earlier. Large VSDs, when they are diagnosed, they need to be closed. But suppose a large VSD child is very small, you have to wait till the child gains some weight, at least 5 kgs or 6 kgs, or up to 6 months, because the results are better when the child's weight is good. So this will be an example of a device closure of a perimembranous VSD. You see the device has got 2 discs on either side. There are several variants, and depending on the type of VSD, there are several devices. And for muscular VSDs, very small, intervention is unnecessary. Outlet VSD, early closure. The third important acyanotic congenital heart disease will be your patent ductus arteriosus. So PDA can present in the newborn, can present in the infancy or childhood period, or people can come with PDA. And again, PDA can be isolated PDA, or it can present with other associated anomalies like a coag or something. It is not a single entity, it has got multiple presentations. Isolated PDA is what we are concerned about, because newborn PDA, you have to classify that as a hemodynamically significant PDA or not, and whether it produces desaturation or congestion, worsening of RDS, and they may have to try a pharmacological therapy or other things. Associated with congenital heart diseases, it is treated as part of the other things. And the diagram type A, B, C, D it's a classification, just to know the types of PDA. It's called Kirchenko's classification. The shape of the PDA is tubular, window type, and then right-sided. So these are important to know, but for closure, it is not that important. So this will be a typical ductal view. So ductal view is when you do echo, so you exactly place your probe on the left infraclavicular view, 90 degrees, the pointer facing upwards, where you can see a turbulent jet from the descending aorta flowing into the MPA. So that will be the ductal view. This view is very, very important to assess the size of the PDA. And usually you measure the pulmonary end, that is the size of the PDA. And you can also measure whether the PDA is tubular, window type, or long. And you can measure the gradient also. So what do you do if it's a small PDA? Again, sizing a PDA, saying a PDA is small or large in the newborn or a preterm, again you've got different criteria to say whether which is hemodynamically significant or not. You've got LA to aortic ratio, you've got flow velocity in the left pulmonary artery. There are several criteria by which you can say preterm PDA, is it hemodynamically significant or not. Isolated to say it as a small PDA, a moderate, a large PDA. Again, you can use the size, but more than that, it is the QP is to QS ratio, the volume overload of LA and LV, that decides whether this PDA. Small PDAs, you just have to follow up, and they rarely need closure. And moderate PDAs, ideally they should first year of age. A large PDAs, if they are producing failure, they should be closed as soon as they are diagnosed. Again, as I said, you can most of them are amenable for device closures, and this will be a typical duct occluder, PDA duct occluder, and the panel B would be a lateral view, the aortogram, where you can see the flow of blood, that is the PDA flowing into the pulmonary artery, and the PDA duct occluder is after closure, there is no more shunt. So in neonatal, I think PDA, I think we know either pharmacological closure if it is hemodynamically significant PDA, either IV paracetamol, Brufen or Indomath. If it fails, there is still a role for surgical ligation. And there is one point to remember: in a PDA, preterm PDA with failure, giving Lasix will prevent closure of a preterm PDA. Lasix actually causes alterations in the prostaglandin metabolism, and your PDA may be patent in a preterm PDA with failure. So early intervention is needed, often within the first few days of life, depending on the interventions. Isolated PDA, small to moderate PDAs, they also close spontaneously, but if they do not close, duct occluder. Prematurity, we discussed. With other congenital heart diseases, like say, for example, with a complex cyanotic heart disease, a VSD, a coactation, by the time you close the VSD, you close this PDA also. So this is summing up. These are the class indications. So these three are the common acyanotic heart diseases. Of course, you've got AP windows, which are very, very, very rare. Commonly are the pulmonary stenosis and aortic stenosis. Pulmonary stenosis, you know, the commonest is the valvular pulmonary stenosis, dysplastic pulmonary stenosis, where the pulmonary valve domes during systole, and the other things are the either subvalvular stenosis or the infundibular stenosis, and the supravalvular stenosis, which may be associated with many syndromes, and branch pulmonary artery stenosis, which may be part of syndromes, congenital rubella, etc. So any of these can present, but when do they need intervention? Only when they produce symptoms. Like, and how to decide that? You have to take the gradients. Any pressure gradient more than 50 indicates it is a significant pulmonary stenosis. So this needs to be treated. So most of the time you do not require a valve replacement or surgery. You just need a balloon pulmonary valvuloplasty. You put in a balloon across the pulmonary valve, open up the valve according to the size of the annulus, and most of them do well. And if they develop subsequently a pulmonary stenosis in later life, they can again and have a dilatation. So severe pulmonary stenosis more than 50, because if you do not, okay, they will go on to develop right ventricular dysfunction. So depends on the right ventricular pressure you are going to treat. So this will be the example of pulmonary balloon valvuloplasty. So see, the balloon has got a waist, and after expansion, very well, the waist expands, and then the gradient also comes down. So I discussed it. Same with aortic stenosis. Aortic stenosis, again, mild, moderate, and severe. Rarely children can present with critical AS in the newborn period itself. It may be isolated, bicuspid, congenital bicuspid aortic valve, or part of this Schoen's complex, where they can have AS, coactation, interruption, supramitral rings, all those things. So what you do is, again, same in the newborn period, you do a balloon pulmonary, balloon aortic valvuloplasty. And the other thing is coactation. There are, I think you know, it is a spectrum. It can be a preductal, postductal, or long segment coactation. And in the newborn, a coarctation and infusion. In the ductal patency, you need to ventilate, give inotropes. In critical coarctations, surgery as early as possible. And what the types of surgery is end-to-end anastomosis, or they can do a subclavian flap. Rarely, you can also do a balloon dilatation of the coax segment. So AP window, I said, it is purely surgical. Medical treatment is temporary. You have to send for surgery. Early closure as soon as diagnosed. Cyanotic congenital heart diseases are a huge group which I am not going to talk about. I may talk 2 or 3 slides about tetralogy fallow. So you know the common components of tetralogy fallow, but the 2 other things which we need to recognize are TOF with pulmonary atresia and TOF with absent pulmonic valve, because the management of these 2 are little different. Classical TOF, where you're going to classically do a surgery by 6 months of age, where you patch closure of the VSD with either a RV annuloplasty or a conduit. Pulmonary atresia, you have to initially they may need a BT shunt or a palliative shunt to restore blood flow to the pulmonary artery, and then a stage procedure. Absent pulmonic valve is an interesting entity where the newborn child can be present with a murmur, with a large to and fro murmur, can present with respiratory symptoms, with large dilated pulmonary arteries obstructing the airways. So that needs to be recognized, and again the mode of management is surgery. And children with MAPCAs, multiple aortic pulmonary collaterals, you have to unifocalize them first and then do a stage surgery. At the neonatal tetralogy, prostaglandin E1 or a neonatal BT shunt, complete repair you do somewhere after 6 months. Thank you. So these I just wanted to impress upon ASD, VSDs and PDS, where when to refer and can you leave a child with a hole in the heart to just heal by itself? No. You just have to really know whether it is a small defect, a larger defect with volume overload, where is the location, and then can advise. Thank you.
So it's a very nice presentation. Though it's a very big topic, you presented everything, what we need, everything in a nutshell, so it's crystal and clear. And what will you do for patients in bidirectional shunt in case of ASD or VSD? Otherwise, early Eisenmenger, like it's not severe pulmonary hypertension as established Eisenmenger. It's early Eisenmenger or borderline bidirectional.
Yeah, that's a really gray area where a child is not diagnosed, ASD not diagnosed, suddenly presenting say 12 years or 13 years. When you look at the pulmonary pressures are a little high and saturation is borderline. And if the resting saturation is less than 85, people say they are inoperable. They can straight away say Eisenmenger. But people say you still have to give them benefit of doubt, make them undergo invasive cath and measure the pressures by balloon occlusion. You occlude the ASD by a balloon and see if the pressure rises. If the pressure is borderline, they can undergo still occlusion with a fenestrated device so that it acts as a pop-off valve. But if the pressure is low, both ASD and VSD with borderline pressure, they need to undergo invasive cath.
It's a very
Yeah, that is again important thing. Like you see adults, pregnancy coming with a PDA 1 millimeter or 2 millimeter, you auscultate, there is no murmur, but echo, there is a PDA. All those PDAs, they said there is a risk of infective endocarditis, you should close. But now they say the annual risk of that you can leave them. The Doppler PDAs or silent PDAs need not be closed. You can just observe and then wait. Pediatric age group, again, the small PDAs you just have to wait. Small PDAs you have to wait. No, that is not the case.
That was an excellent presentation.
Okay, sir.
But I was like a child lost during a festival during your presentation. I want to ask an interdisciplinary question. Baby with the vectoral anomaly, with the cardiac anomaly, which should be treated first? Cardiac anomaly or anomaly? it should be operated first?
Sir, again, it depends. If it is a complex issue where you think the child will need multiple stage procedures, whichever is the emergency takes precedence first. You can treat your gastrointestinal emergency first and then go for stage things. But if it is a simple condition, for example, or ASD or VSD, isolated defects, the risk for the baby for the procedure may not be that great. So the gravity particular problem, whether it is a significant gastrointestinal problem, needs to be addressed within 24 hours. That takes precedence. And again, the complexity of the congenital heart disease, isolated versus syndromic, not have good results with your even with correction of your heart diseases. So what you might be doing for a gastrointestinal thing might be just a palliative thing. So it needs to be case-based or individual case-based.
Congenital cardiac conditions presenting as acute abdomen, sir. It's for pediatric research. What are the cardiac conditions which can present as other surgical problems, acute abdomen-like things?
Congenital cardiac conditions, because congenital aortic stenosis or severe aortic stenosis can have angiodysplasia, can present as hematochezia, but pediatric, maybe it is part of a PDA, can have necrotizing enterocolitis, so association. So only that kind of things I can think of.
Thank you, sir. Thank you.
Thank you, sir, for patiently explaining our questions.
Thank you.
Sir, we have some questions. So, usage of Lasix will delay the closure of PDA. So, if you are receiving a baby with PDA with the failure, then how should we manage it?
If the baby has got overt failure like severe volume or lungs are congested, you have no other go. You just have to titrate, restrict fluids and maybe give a guarded dose of diuretics, and then once you decongest, you can try your pharmacological closure. The point I said was Lasix given will delay closure, but it is not that you should not give Lasix. Obviously, you have to treat it.
Sir, in cardiogenic shock, which is preferred, sir? Either adrenaline or
cardiogenic shock. Dobutamine is to be given only when the systolic BP is within the mean. If the systolic BP is less than the age percentile, dobutamine is not the first choice. Either your inotropes, adrenaline is your first choice or dopamine is your first choice, cardiogenic shock. So when you say cardiogenic shock, only when you are able to feel the dorsalis, you can think of dobutamine. Otherwise, your choice will be adrenaline plus dopamine.
So last month in PICO child, dilated cardiomyopathy is diagnosed. We received with cardiogenic shock, sir. So initially we started with adrenaline. Then after stabilizing of BP, then we added dobutamine for improving the contractility. And then we thought of adding anti-failure measures like enalapril and digoxin, sir. But before that, unfortunately, the baby expired. So what is the when is the appropriate time to start these anti-failure management in such cases?
See, first thing is in the acute setting, your adrenaline or dobutamine, they are only transient things. They are going to give you over time, you can gain say 48 to 72 hours or maybe 5 days, up to 5 days you can give an infusion. Beyond that, continuous dobutamine or adrenaline infusion, they are not going to help. So it depends on the etiology also. Like, so if it is a idiopathic dilated cardiomyopathy in a newborn child or 1-year-old child, so your choice of anti-failure therapy has to be, you can safely start on digoxin, because digoxin might be helpful in these cases. Whereas if the etiology is something else, a sepsis with myocarditis, you have to treat that also, part of sepsis, and your inotropes buying time. So initially you stabilize with inotropes for 72 hours or so, and then if the child is in failure or pure cardiogenic shock, you may add plus or minus diuretics. You can start a ACE inhibitor initially, and then digoxin may be optional later.
Sir, in cardiac, sir, in between dobutamine and milrinone.
So both have got good roles, and most of the trials are of the dobutamine. But milrinone, of course, got in particular in pediatric age group, has got far greater and cardiogenic shock also. But only thing is a little more pro-arrhythmic milrinone, so you have to be a little more careful. So both can be used.
So last question, role of sildenafil in pulmonary hypertension secondary to VSD.
Secondary to?
VSD.
Okay, so pulmonary hypertension secondary to VSD is, you just have to decide is the pulmonary hypertension is flow dependent or irreversible vascular changes have occurred. Suppose the VSD has got a large left to right shunt, and because of the shunt there is pulmonary hypertension. Your sildenafil is not going to act. If the VSD has caused Eisenmenger, it is irreversible, again your sildenafil. But still, so many VSDs who got high pressures, inoperable, they are on drugs. They have got a certain role, but that is not the treatment for VSD with hypertension.
Thank you, sir, for such an enlightening session. Now I request Dr. Balamurugan, sir, HOD Department of Cardiology, to honor Dr. Vishwanathan, sir, with a memento.
Sir is apart from a pediatrician, he is an adult intervention cardiologist, and he is a cricket player and athletic sportsman.
I request Dr. Venkata sir to join for felicitation. I request Dr. Balamurugan sir to honor Dr. Venkata sir with a memento. I request Dr. Balamurugan sir to honor Venkata sir with a memento. Before the next session, I call upon the people from Foxy who have come here to honor our legendary pediatrician, Deputy Superintendent of our TKMC, Dr. Kumaran sir, to the dais. Thank you, ma'am and sir.
Sir, இன்று போல் என்றும் இளமை துடிப்புடன் வாழ்வாங்கு வாழ வாழ்த்துகிறோம்.
Now, it's time for the next session, a session on childhood pneumonia, a case-based approach. For this session, the speaker is pediatric pulmonologist Dr. Anthony Terrace Benjamin, sir. I request you to the dais, sir. For this wonderful session, the chairpersons are Dr. Naresh, Chief Department of Pediatrics, TKMC, Dr. Thomas Kingley, Chief Department of Medicine, GTKMC, Dr. Rajavel Murugan, HOD Department of Medicine, GTKMC. About the speaker, he holds a degree of Pediatric Respiratory Medicine, Diploma in Pediatric Sleep Medicine, Diploma in Asthma and Allergy. He is as a designated consultant pediatrics and pediatric pulmonology, GKNM Hospital. He has an experience of 12 years. He has several publications such as high-speed video microscopy in a teenage boy with chronic cough, service delivery modes for primary ciliary dyskinesia, meconium ileus due to GUCY2C gene mutation in 3 unrelated South Indian families, and an approach to recurrent and persistent pneumonia in children. I request the speakers and the respected chairpersons to the dais. The session is over to the chairpersons.
respected chairpersons, teachers, pediatricians, and pediatric trainees. It gives me immense pleasure to be here and talking to you and discussing with you about childhood pneumonias. I think whatever you may be, like a primary pediatrician working in a secondary setup or a tertiary care, you do come across childhood pneumonias. And is it a big problem? Yes, it's a big problem. And worldwide, about 1 million deaths occur due to pneumonia every year, and 20% of these deaths are in India. Therefore, we contribute to 20%. Almost 2 lakh deaths occur in India due to pneumonia. And if you take the under 5 mortality, 15% is contributed by pneumonia. Therefore, it's a global problem and an Indian problem as well. And how do we define pneumonia? Pneumonia is an infectious process that we all know, and that's usually associated with fever, respiratory symptoms, and evidence of parenchymal lung involvement, either clinically or radiologically. And how does this definition differ from WHO definition? WHO definitions say only about respiratory symptoms and presence of tachypnea. Therefore, WHO definition is for screening pneumonias. Therefore, it's for screening pneumonias. It's not a specific, definition for, confirming pneumonia. Therefore, it's a very useful screening tool for pneumonias. But as a clinician, to diagnose pneumonia, we should have some evidence of lung parenchymal involvement. Let's see this first patient. The first patient is a 3-year-old child who presented with acute onset of fever, cough, and shortness of breath. Therefore, this child classifies the WHO definition of pneumonia. And on examination, child was sick-looking, tachypnic with chest indrawing, and has reduced air entry on the right side, and was grunting as well, and had crackles. Therefore, if you look at the clinical examination, definitely there is evidence of parenchymal involvement in the form of crackles, reduced air entry, and there was grunting as well. And therefore, this patient, you all know that child has got a clinical pneumonia which was confirmed radiologically as well. And again, WHO, there is a classification of pneumonia into pneumonia and severe pneumonia. In the presence of chest indrawing or hypoxia or any danger signs, you can classify the severity as severe pneumonia. Therefore, this patient is classified as severe pneumonia. Whether we need to admit this child, what are the factors you need to take into consideration for admission of a child with pneumonia? Any young child less than 6 months, even if the child has a pneumonia, ordinary pneumonia without severe pneumonia, then definitely the threshold for admission is very less. You have to admit the child. Any child having severe pneumonia, definitely you are going to admit. And any child having underlying medical condition, like a congenital heart disease or immunodeficiency, you need to admit that child. And what about workup? Chest x-rays, if you are admitting the child, definitely you need to take a chest x-ray. Or if you have a diagnosis in doubt, or if you are considering complications, definitely you are going to take a chest x-ray. And what about the microbiological investigations? In a simple uncomplicated pneumonia, the yield of blood culture is only 5% or less. Therefore, it's not necessary to do a blood culture in simple uncomplicated pneumonia. But in the same case, if a child is sick, the bacteremia chances are quite high. In a severe pneumonia, getting admitted in ICU, or if the child is not hemodynamically stable, then the yield will be more. Your chance of getting a positive blood culture is about 20 to 30%. In those cases, definitely you need to take a blood culture. What about other specific investigations? Specific investigations like BAL and pleural fluid cultures and PCR are reserved for very severe cases or immunocompromised children. And nasopharyngeal aspirate we do during the viral season, and it's useful for viruses. If you are taking a swab from the upper respiratory tract, it only represents viral respiratory infections as well as atypical mycobacteria like Bordetella pertussis, Mycoplasma. It might indicate the lower respiratory involvement with the same organism. But for pyogenic organisms and bacteria, whatever you take in the throat won't guide the organism inside the lungs. Therefore, that might not be useful. Therefore, whenever you ask for a PCR from a nasopharyngeal swab, you just look at the viruses and atypical bugs. But in case if you want to do PCR for a lower respiratory infection, you should take a tracheal aspirate or a BAL. That will be representative. What about inflammatory markers? Inflammatory markers cannot be taken alone. It should be taken in coordination with the clinical picture of the patient, and it helps to differentiate viral and bacterial infection if you take the clinical picture in addition to the inflammatory markers. And it will also help actually to monitor therapy, like monitor your antibiotic therapy. And regarding the different markers, PCT or procalcitonin is more specific than CRP, but it's very expensive as well. Therefore, it has limited use in ICUs and immunocompromised patients. Therefore, in very few patients you will be having a bacteriological diagnosis or microbiological diagnosis. Therefore, you have to depend on empirical antibiotic therapy for these patients. Therefore, how to decide on empirical antibiotic therapy? Therefore, before you write your prescription, you have to consider the epidemiological triad. In epidemiological triad, you have the agent, host, and the environment. You want to guess the agent. Therefore, you should have an idea of the environment. Therefore, you have to ask the question, is it a community-acquired pneumonia or a hospital-acquired pneumonia? That's the first question. Therefore, because antibiotics totally will change for a community-acquired pneumonia and a hospital-acquired pneumonia. Second, a few questions are about the host. You have to ask the age of the child. You have to consider the age of the child, severity of the illness, and you have to ask yourself whether I am treating an immunocompetent child or immunocompromised child. And finally, what is the risk of aspiration for this particular child? If you ask all these 4 questions and about the environment, totally 5 questions, then you can prescribe a rational antibiotic for this particular patient. And regarding the bugs, community-acquired pneumonia, less than 5 years, most of the times we will be dealing with Streptococcus pneumoniae or Staphylococcus. If it is more than 5 years, definitely your atypical bugs like Mycoplasma come into picture. And if it is healthcare associated pneumonia, like you need to think about gram-negatives, MRSA, and drug-resistant bugs. If you are thinking about aspiration pneumonia, you need to cover for anaerobic organisms in addition to gram-positive and gram-negative. And in immunodeficiency, you have the unusual bugs, the fungal infections, the PCJ, and the viral infections. We will come back to this patient. Our patient is a 3-year-old child and who had acute onset of respiratory illness and had features of pneumonia, and the severity we said like it's a severe pneumonia. Child is admitted in ICU. Therefore, the plan is to cover for like strep pneumoniae, and we also add vancomycin to cover for MRSA, and in severe cases we do cover for mycoplasma. If it is a viral season, we are going to give oseltamivir, where fluivir as well. What about the drug resistance patterns for like strep pneumonia? In the strep pneumonia, this is one study is showing very high resistance for macrolides and cotrimoxazole. Therefore, if you are considering a bacterial pneumonia, we should not prescribe like if you are targeting strep pneumonia, we should not be prescribing azithromycin or any other macrolide antibiotics. And our strep pneumonia are quite sensitive to penicillins and the 3rd generation cephalosporins. If you are prescribing antibiotic for like community-acquired pneumonia as outpatient, you can give amoxicillin or amoxiclav, and we don't give oral macrolides. And with oral cephalosporins, the bioavailability is very less. Bioavailability is quite variable. Therefore, generally I don't prescribe cephalosporin or cephalosporins for pneumonia, for outpatient pneumonia management. And why do we give high dose amoxicillin? And if you are considering penicillin resistance, most of the penicillin resistance is intermediate resistance. It can be overcome by giving a high dose of amoxicillin. That's why we give high dose amoxicillin. coming back to our patient who had a severe pneumonia, we started on ceftriaxone, vancomycin, azithromycin, and Fluvair, and the child failed to improve after 3 days of antibiotics. Therefore, if the patient is improving, if not improving after 48 to 72 hours of antibiotics, you might think about complications. The commonest complication being the empyema or pleural collection. Therefore, once you make a diagnosis of empyema by chest X-ray, the next step is to do an ultrasound to see what kind of stage the empyema is in. The stage 1 empyema is usually a free-flowing fluid, and it's called symptomatic effusion. Stage 2 empyema is a loculated empyema. Stage 3 empyema is the last stage where you have a fibrous peel around the lungs, and it causes restriction. Therefore, usually in the first week it's the first stage, and second week is the second stage, and third or fourth week you go into the organizational stage. Our patient is almost end of the first week into second week, and we have lots of loculations. Once you find loculations, you have to there are two ways you can manage stage 2 empyema. One is doing a VAT surgery, early VAT surgery, and second is putting an ICD and giving a fibrinolactic like a streptokinase. We do give streptokinase because it's it's cost effective. It's cost effective, and second thing is we have good outcomes with intrapleural streptokinase. And once you take the child for surgery, at least it will cost 1 lakh, and this is not that expensive. Therefore, we have had good results with intrapleural streptokinase. And the second case is this is X-ray of a child with acute pneumonia not responding to therapy. We did the X-ray, we couldn't find pleural effusion, but ultrasound was also done. Ultrasound showed something suggestive of lung abscess, but they were not very sure. And CT chest was done, which showed lung abscess on the left lower lobe. When there is a lung abscess, usually for children, they already have drainage through the bronchus. There is no need to drain the abscess unless if it is not responding to therapy, or if the size of the abscess is quite large, more than 6 centimeters. Our patient had a very large lung abscess, therefore we had to drain, and drainage was done by CT guided aspiration. And another important point after treating lung abscess is you have to make sure it's just an isolated lung abscess. Sometimes congenital pulmonary airway malformation or lung cyst might be underlying, and the child might be developing infection on top of that. For that, you have to remove that particular lobe. Therefore, once you treat a lung abscess, make sure it completely resolves with your antibiotic therapy. If not, it could be a CPAM or a congenital lung cyst. And another common problem we come across is not a common problem, complication is necrotizing pneumonia. The necrotizing pneumonia, where you have pneumatoceles because of liquefaction necrosis inside the lungs, and again here the organisms are the same, strep, pneumonia and staphylococcus, probably more virulent strains, and treatment is mainly IV antibiotics. And here you have to watch for pneumothorax and the child developing empyema. Therefore, you have to closely watch for the child getting pneumothorax or empyema, and with antibiotic therapy they do quite well. Therefore, for complicated community-acquired pneumonias which are pyogenic, what differently we have to do is, usually for ordinary pneumonias we give antibiotics for 7 to 10 days. If it is a complicated pneumonia, the duration of treatment is going to be long. At least a month we have to give antibiotics, and we have to ensure resolution by taking the chest X-ray 4 to 6 weeks after treatment. And this is the third patient. This is a 5-year-old kid who presented with acute pneumonia, not responded to amoxicillin, and had a erythema multiforme like rash, and therefore its features are atypical. No response to regular antibiotic, child having extrapulmonary features. Therefore, here it's likely to be atypical pneumonia. It's usually mycoplasma. We had an epidemic of mycoplasma pneumonia last year, and we saw lots of patients. And This is one of my postgraduates who did a study on mycoplasma pneumonia. She recruited 30 patients who had confirmed mycoplasma pneumonia, and conclusions were like most of the patients were above 5 years, but 1/3 of the patients were below 5 years. Therefore, 5 years is not a cutoff, and 50% of the patient after 48 to 72 hours of azithromycin didn't respond properly. Therefore, that was an indication. There was like 50% resistant to azithromycin. During the last epidemic, we used lots of doxycycline and levofloxacin, but these are only for confirmed mycoplasma pneumonias. We can't empirically give levofloxacin for all patients because it's anti-tuberculous drugs. Therefore, only for confirmed mycoplasma pneumonia infections and which are not responding to azithromycin, you have the option of oral doxycycline or levofloxacin. Therefore, for younger children, like we prefer levofloxacin. For older children, we can give doxycycline. And this is another study done by a postgraduate looking at the seasonality of viral respiratory infection in children, and the findings were like viral respiratory infections were common in the monsoon season from July to February, and the one shown, the curve which is shown in blue is the seasonality of RSV. RSV had an early peak before December, but it continued till March, and influenza is shown in red. It had a late peak between December and March, but it started in July. Therefore, if you want to give vaccination for flu vaccination, better start like in June itself. Therefore, you will get protection. And last week we already started testing positive for flu viruses. Therefore, timing of vaccination is also important. If you are giving flu vaccination, you should not give late like September, October. It not be that effective. It's better to start early on. And this is a 16-year-old boy who presented again with acute onset respiratory illness and initially looked like atypical pneumonia. He didn't respond to amoxicillin and azithromycin, and we were following up quite closely, and after 2 weeks he had worsening of symptoms and had a very bad X-ray, and he was worked up for tuberculosis AFE stain both negative, and gene expert was also negative. And we are lucky that we did MGIT culture for this patient, and it turned out to be positive. Therefore, like any child, having fever, cough of more than 2 weeks duration, weight loss with or without contact, we have to suspect tuberculosis. Once you suspect tuberculosis, apart from a regular investigation like AFB stain, which has a sensitivity of less than 10%, gene expert, I think it's better to do a MTB culture as well to improve your yield. Pneumonia in special situations, pneumonia immunocompromised is an interesting, child who is a 10-year-old girl who presented with DKA for the first time. This is the first diagnosis of diabetes mellitus for this child. She also had respiratory symptoms in the form of fever, cough, hurried breathing for 7 days, and she was sick-looking, tachypneic, and had localized lung signs on the right side. And we started treatment for community acquired pneumonia. There was no improvement. An X-ray was taken. There was a little bit of patch on the right paracardiac region, and because she was not responding, and she is immunocompromised, because in DKA and if diabetes mellitus, your neutrophils won't function properly. Therefore, we wanted to proceed to CT scan, and we did a CT scan which showed reverse or inverse halo sign, which is a peripheral rim of consolidation and a ground glassing in the middle, and it usually indicates fungal infection, either aspergillus or mucormycosis. And a bronchoscopy was also done, and it showed fungus inside the right bronchus intermedius, and we did BAL and also biopsy, and the biopsy showed fungal hyphae on the HP examination, and PCR also was done. It was positive for both aspergillus and mucor. And the important lessons we learned is, immunocompromised, you have to be aggressive getting a microbiological diagnosis. CT scan might give a clue, and culture takes a while to get the results. Therefore, PCR is quite helpful in these situations. And this patient, is immunocompromised patient. Therefore, we treated with antifungal medications, and we have to reverse the immunosuppression. With insulin itself, neutrophils will function well. Therefore, treatment of diabetes is very important. And for MUCAR, you have to give clearance. Therefore, surgical resection of the right lower lobe was done, and child did well actually afterwards. And I think pulmonary mucormycosis, has a very grave prognosis. The mortality is around 90%. Therefore, the child was quite lucky. And in case of persistent and recurrent pneumonias, persistent is pneumonia lasting for more than 1 month without any radiological clearance, and recurrent pneumonia is pneumonia at least 2 episodes in 1 year or 3 episodes during any time frame with radiological and clinical improvement in between. In those situations, I follow this particular approach, I'll try to identify the invader, because that will give a clue. If I identify PCJ, it tells, this child is immunocompromised. Therefore, identifying the bugs is important. Next, I look at the defenses, the airway defenses. We look at the mucociliary apparatus we do for cystic fibrosis, primary ciliary dyskinesia testing. We also test HIV and primary immunodeficiency testing. And important to look at the neighbors as well, because aspiration syndromes can present with recurrent pneumonias, and congenital heart disease also can present with recurrent pneumonias. And we have to ask the question, is there any foreigner inside? Because we had retained foreign body presenting with recurrent pneumonia in the same lobe, and other congenital malformations can also present with recurrent or persistent infection. Therefore, cure is better, but it's important is prevention. We all know the vaccines, especially pneumococcal vaccine, reduces pneumonia deaths by 50%, pneumonia deaths by 50%. Therefore, universal PC vaccination is quite welcome. And apart from reducing pneumonia deaths, it actually reduces the antibiotic use, and reduced antibiotic use lead to reduced emergence of resistant strains. Therefore, it has multiple beneficial effects. And we all know indoor pollution and outdoor pollution play a big role in children having recurrent chest infection. We need to talk about indoor air pollution, especially to families, because they will have some form of pollution like Udupati Vipanga and somebody smoking at home. And if you stop that, it will make a lots of difference to that particular child, especially children having recurrent chest infections. And this is an interesting study from Australia which showed that during COVID, the number of bronchiolitis and emphysema drastically came down because the pollution was low and we were actually using respiratory hygiene during that time. Therefore, reducing pollution, vaccination, these are some measures that we could advise. And in summary, I think we pediatricians at primary care should concentrate on simple things like good nutrition, vaccination, and reduction in indoor air pollution. And while you write antibiotic for pneumonias, as I said, we have to ask 5 questions before writing antibiotics, because you will be more rational if you ask questions before writing antibiotics. And in case of complicated pneumonias, I think better refer early to a center where the child can be taken care of in a safe manner. Thank you.
Thank you, sir. That was a wonderful presentation. As we all know, pneumonia itself is an enigma. One time the child will be sitting quiet, next time it will be collapsing. A lot of take-home messages like giving a flu shot even before the month of June. We have only one question. Parents are nowadays giving antibiotics just like that. Even for a sneezing, they give an antibiotic. Again, next month, they might give the same antibiotic over the counter. So what is your take on this? Because both from the doctor's perspective, prescription is also even for whatever is not needed, they are giving an antibiotic, and babies, parents also themselves are getting the antibiotic over the counter. So how is it going to affect this spectrum of pneumonia?
Yeah, definitely. I think doctors have, the primary, apart from giving medicines, our role is to educate the parents. I think most of us are very busy practitioners. We don't spend time with the parents. If we can spend time, educate and empower parents, they will also behave rationally. And we also sometimes, write antibiotics very frequently. And I think you see two kinds of parents coming with a prescription which was given 1 year back. I am using the same medicine you gave. They will also include us in their sin. And another parent, sir, antibiotic irka? There are two spectrum of patients. I think the most important thing is we have to spend time talking to the needed or not, and I think you will have, after some time you will have patients who like you and they will follow, what you prescribe.
Yes, sir, that's a very interesting topic. I think you have completed everything about pneumonia. One question I want to ask, what are the surgical indications for lung abscess? When will you advise surgery in lung abscess?
Lung abscess, we had only very few patients. The patients who had we did CT guided drainage for this patient, and we had a patient with lung abscess we treated, and finally, the child had a recurrent infection at the same site, and therefore we again did the imaging. It turned out to be a CPAM, underlying congenital pulmonary airway malformation. Therefore, in that case, we actually removed that part of the lung. Otherwise, most of them will do medically quite well. If there is any, underlying lung lesion, definitely they might require surgery, a sequestration or a CCAM or a lung cyst, in those situations.
Thank you, sir. Any question from the audience?
Sir, is there a role for biofire, sir? So biofire, how much it is useful in case of pneumonia presentation?
Pneumonia, you are asking about multiplex PCR.
Yes, sir.
We do use multiplex PCR in our hospital, and we have an in-house multiplex PCR. And sick patients in ICU, it's quite helpful. And whenever you do a multiplex PCR, if it is from a nasopharyngeal sample, you have to interpret only the viral part as well as mycoplasma and pertussis. And other things, if you identify some strep pneumonia, H influenza, they're usually the colonizer. They are not the one from in lower respiratory pathogen, identified as lower respiratory pathogen, you have to do a tracheal aspirate, mini ball or a proper ball. Then only it will represent the organism inside the lungs. Otherwise, it's not useful. Therefore, you should not go by a nasopharyngeal or a throat swab for treating the lung infection.
Thank you, sir. Thank you for such an enlightening session. Now I request our beloved chairpersons to honor pediatric pulmonologist Dr. Anthony Terence Benjamin, sir, with a memento. I request Benjamin, sir, to honor our Chief Department of Pediatrics, Dr. Naresh, sir, with a memento. I request Chief Department of Pediatrics, Dr. Naresh, sir, to honor Chief Department of Medicine, Dr. Thomas Kingley, sir, with a memento. Thank you, sirs, for a wonderful session. Next is in session. It's a sponsored session. It's all about typhoid. For this session, I like to invite the speaker, Dr. Durai Padmanabhan, sir, Senior Pediatrician, Kovilpatti Government Hospital. We welcome you, sir. About Dr. Durai Padmanabhan, sir. He has a qualification of MBBS, DCH, MBA about hospital management. He is a designated NICU nodal officer at Government District Headquarters Hospital, Kovilpatti. Active participant as a chief pediatrician in Infant Death Audit Committee, headed by District Collector for the past 15 years. He is a secretary IMA Association Kovilpatti branch and IAP State Executive Member. He has many poster presentations on GOD in asthma and on propranolol therapy in hemangioma. Over to you, sir.
Thank you for the introduction. A very warm good afternoon to all. It is a session between pre-lunch and lunch session, so I'll make it soon as early as possible. And as it is mentioned, it is a sponsored session about typhoid. Let us have a brief recap about typhoid. So typhoid fever, it is a potential life-threatening infectious gram-negative disease caused by gram-negative bacteria caused by Salmonella typhi. The symptoms, as you know, high fever, fatigue, headache, and loss of appetite will be there. And bacteria. The species is characterized by 3 antigens present on the cell. O antigen, that is the somatic antigen, and H antigen, it is the flagellar antigen, and third antigen is the VI capsular antigen. So how typhoid spreads? It spreads through contaminated food or water, and from the carriers through food handlers. And coming to the global prevalence of typhoid, it is African countries in the near the equator. So where there is the temperature is ideal, and the number of cases is around 12.6 million. Of that, 10 million cases are from India, and India and Pakistan are known for typhoid with multi-drug resistant typhoid incidence. So age-wise distribution, as you know, it is more prevalent in younger children in the age between 5 to 15 years. So also when you take disability adjusted life years, the developing countries and underdeveloped countries in Africa and Asia are affected more. And season and climatic changes also worsen typhoid. As the global warming precautions we are having, the increase in transmission is more during flooding, droughts, and famines. All these situations, either flood, droughts, or famine, there is a paucity in food chain, and food handlers, when they are handling very without any caution, the spread is more. And there is sudden upswing of typhoid cases with more transmission during famines, flood, and droughts. So unaddressed gaps in typhoid management, the main 2 gaps we think is carriers. All food handlers should be given typhoid vaccine. So then only carrier state will be prevented, and reinfection. So once typhoid is any child is infected with typhoid, many people think that they may not need a vaccine, they may not get typhoid again, but it is not so. The reinfection is more common, and it is missed very frequently. Coming to the antimicrobial resistance in Salmonella typhi, in earlier days, the first drug which is used for typhoid was chloramphenicol. As you see, from chloramphenicol, resistance is reported. Ampicillin was used. Then after ampicillin, Ceftriaxone was used. All those 3 drugs got resistant subsequently of increased usage. And then also quinolones also now in 1985 demonstrated efficacy, which was now not so active against typhoid. And slowly there is we used more with the introduction of cephalosporins. We used more 3rd generation cephalosporins, which is very efficient in controlling typhoid. But in 2016, there is a breakout in Pakistan where extensively resistant typhoid strain is reported, which is also resistant to ceftriaxone. Ultimately, the drugs which we are left out is only azithromycin and carbapenems, penicillins. And if these are getting resistant, then it is very difficult for us, as there is no further antibiotic discovery is made after carbapenems. So multi-drug resistant, 3 drugs are resistant: ampicillin, Ceftriaxone. If it is extremely drug resistant, along with these 3, including fluoroquinolones, the 3rd generation cephalosporins is also resistant. So XDR typhoid strains are resistant to at least 5 classes of antibiotic, including ampicillin, chloramphenicol, fluoroquinolones, ceftriaxone, and cotrimoxazole. As I told, there is only limited options beyond for extremely drug resistant typhoid, where we have only azithromycin and carbapenem. So coming to the investigations, As we know, blood culture is the standard diagnostic method, but it is not possible in many places. And Vidal is extensively used, but it is also the most extensively misused investigation also. So two titers in a 1 week interval with rising titers is more significant. But with a single Vidal report, many people stamp as typhoid and they start on treatment, which leads to antimicrobial resistance. So coming to the complication, it almost involves all systems from CNS, bone and joint, respiratory, genitourinary, beyond, though it is a primarily disease in gastrointestinal tract system. So choice of empirical therapy for typhoid is if the severe illness, inpatient ceftriaxone can be given, if the child is taking orally, and if it can be managed outpatient. And second line of choice for inpatient is cefotaxime or aztreonam, and oral azithromycin can be used for outpatient department. And there are some clues in treating typhoid. Treat at least 7 days after defervescence or 14 days of antibiotic in sick children. Azithromycin can be given for 7 days alone, IV azithromycin. Quinolones are not used unless the culture is shows sensitivity to quinolones. One more thing, many people use aminoglycosides like amikacin for typhoid. They are not at all useful since their action is only in extracellular area, but salmonella is an intracellular pathogen. So coming to the treatment, as we have discussed already, coming to the prevention, typhoid conjugation vaccine. A conjugate vaccine is a substance that is composed of a polysaccharide antigen fused to a carrier molecule, which is usually conjugated, and this enhances the efficacy of vaccine. So as many people know, previously we were using polysaccharide vaccine. Now polysaccharide conjugate vaccine is available. The advantages is the maturation affinity is more, and memory antibody production is long-lived unless in polysaccharide vaccine. And immune response is enhanced even in infants, that is less than 1 year. So an effective conjugate vaccine will decrease the disease incidence, will decrease the severity of infection, and also decrease in transmission of the disease, and prevent carrier stage also. So also typhoid conjugate vaccine is more effective against extensively so typhoid vaccine can be given to children who have suffered from typhoid. Many times one child is getting typhoid, after that vaccine can be given or not. Yes, they can be given vaccine as early as say 4 to 6 weeks after recovery. And also typhoid vaccine should be given to all food handlers and carriers. So coming to some specific points to recollect, typhoid fever continues to be an important public health issue in India, where there is an increase in multi-drug resistant typhoid, and also we had started reporting extensively resistant drug typhoid in Chandigarh also. So though blood culture is the gold standard in diagnosing typhoid, positive blood culture rates are low in our setup. Blood Vidal test has a high negative predictive value, but the positive value is very less. Improving sanitization, hygiene, and vaccination with typhoid conjugate vaccine may reduce the disease incidence very much. With this, I come to the conclusion. Thank you. Thank you.
Thank you, sir, for an enlightening session. I request pediatric neurologist Dr. Nandakumar sir from TVMC for honoring our speaker, Dr. Durai Padmanabhan sir, with a memento. Thank you, sir. Our next session is about holistic health guide by senior pediatrician Dr. P. Ilangovan, sir. I request you, sir, to the dais. This session will be chairpersoned by Dr. Saravanan, President of IMA, of OG, Thuthur Medical College, Dr. Sivasailam, Senior Psychiatrist and IMA Secretary. Over to the chairpersons. About the speaker, he is having a qualification of MD DCCH and he is a consultant pediatrician at Abhiram Children's Hospital with an experience of 20 plus years.
A warm good afternoon to all of you. At the outset, I want to thank this Pediatric Pulse 2025 organized by Department of Pediatrics, Government Thuthukudi Medical College. I also sincerely congratulate Dr. P. Kumaran sir, my role model, for his happy retirement life. So with this, we'll go to an interesting topic now. Holistic Health, a Guide by Senior Pediatrician Dr. P. Ilangovan, Abhiram Children's Hospital from Madurai. Actually, in our medical curriculum, what we have been taught and we have been seen is, we are sitting in the OPD and we used to see patients with their symptoms and we will give a diagnosis, we'll have a diagnosis for this, and with this we'll treat the patient, remedy to the patients. But actually what the patients need is a holistic health. So giving them good guidance to have a good mind, good body, good spirit and good environment. So let us listen to Dr. P. Ilangovan sir's lecture. Thank you, sir.
Thank you, sir. My sincere thanks to the persons who have taken pain to invite me into this learned forum. And we live in a time when we can track our children's height, weight and milestones on apps. The silent needs that matter most. As a doctor, I have written countless prescriptions in the past. Today, I want to talk about the one I don't write on paper. So, this will be the invisible prescription. One made not of medicines, but of meals shared with your children, of course, grandchildren, hugs given, and time spent truly. This is the invisible prescription, and it's the most powerful one we have. In the next few minutes, we'll journey through what truly nourishes a child, not just with medicines, but physically, emotionally. We shall talk about quality food, screen time, water requirement, mental health, and something more rare and more precious, usually the forgotten thing, that is the sleep hygiene for children. One of the most overlooked elements of child health is one of the most powerful, that is the sleep. We often focus on what our children eat or how they play, but forget that the brain grows, heals, and organizes itself only during rest. In fact, for babies and toddlers, sleep is like a daily dose of brain fertilizer. Good sleep, it's not just about the number of hours, it's about the quality and the consistency. A calming bedtime routine, like a warm bath, a gentle lullaby, a quiet cuddle, signal safety to the child's brain. This helps them fall asleep faster and they stay asleep longer. Avoiding overstimulation, especially screens, before bed is crucial. The blue light, as you know, can delay melatonin release, making it harder for children to fall asleep. Even playful TV shows can keep their little brains wired even long after the screen is switched off. sleep needs change with age considerably. Newborns, of course, have fragmented awake and sleep pattern. During the first 3 months, it will be around 14 to 17 hours, sorry. Thereafter, till 1 year, it shall be around 12 to 15 hours. After 3 to 5 years, naps aren't necessary. Some tips to help children sleep better. Sleeping at the same time every night, you are obeying your body clock. During holidays, the difference in sleep time should not be more than an hour. So, not like you can go to bed on Saturday or Sunday by 12 midnight. It's not the way. Now, how to improve the sleep environment? Please allot a separate room, quiet environment, dimmed lighting. Child, of course, should feel safe. Comfort bed. Absence of TV, computers. You can tell them a bedtime story. When I talk to my son regarding pediatrics, he says, "Daddy, I feel comfortably sleepy." So the quality of the lecture also matters. Earplugs can control noise. A warm bath and a warm milk. With regard to the, for 0 to 6 months, or how to promote sleep rather. Till 6 months, baby can held in the arms until they fall asleep. You can place the baby in a cot and gently stroke till they fall asleep, comforting them with soft sounds. But after 6 months, you don't need to carry them in your arms. This terminology is called controlled comforting. Mother leaves the room before the baby is asleep and waits outside the room. She comes back if the baby cries after a brief time, for example 2 to 4 minutes, and talks or pats the child without picking him up. But remember, leave the room as soon as the child is calm. Then wait outside till the baby is asleep. Don't be near the child till the child falls asleep. Think of sleep as your child's invisible medicine. It strengthens memory, improves mood, boosts immunity, and regulates emotions. A well-rested child is just happier, more attentive, more secure, and ready to learn. So let's protect the bedtime hours just as much we have to protect meal times, because while the world sleeps, a child's brain is quietly doing the hard work of growing. So, பாட்டி சொல்லும், பிள்ளை என்ன சாப்பிட்டு தூங்கினா தான் மூளை வளரும்னு சொல்லிட்டு. That's a concept. The second thing will be, of course, screen time. Under 2 years, strictly no screen time. Unfortunately, when I vaccinated a 45-day-old baby, I could see a horrible father showing his cell phone to calm down the 45-day-old newborn. It's atrocious. I just banged him and sent him away. So children between 2 to 5 years, around 1 hour per day. So mothers ask me, switch off the TV. My daughter-in-law is a psychologist. What she will do, she will hide the remote beneath her lap. And after 1 hour, she will secretly switch off the mute mode and tell my granddaughter, TV has developed a sore throat, it's not able to speak well, it will take rest, it will regain its voice only after tomorrow. My grandchild will accept happily. These are small tips. Children between 5 to 12 years, around 2 hours per day. But unfortunately, this applies for parents and grandparents who are sitting here. Same thing applies to you also. Some tips to reduce screen time. Eat together as a family without a screen. Develop intimacy with your children and help them to solve their problems, both in the Milli Interior and in the schools. Never forget to appreciate their achievements. No screen in bedroom. Take toys and play equipments and books instead of tabs when you go for outing. So I have seen people sitting in Kodaikanal with their tabs, with beautiful sceneries around. No child is interested in that. One more thing, as a family you can dance to music videos rather than sitting idle and watching it. So dancing improves your physical efficiency also. Disadvantage of screen time, everyone knows: poor communication skill, poor socialization skill, risk of obesity, behavior problems when they face gross restriction of screen time. Cognitive development, this is about how children think, explore and learn. A red flag here is if the child doesn't show curiosity, like not reaching for toys or reacting to new things even by 6 to 9 months. We can support this by giving them safe space to explore, by talking through everyday activities, offering open-ended cups or puzzles. Subsequently, language and communication. Language development begins long before a child speaks. A red flag would be if a child isn't babbling for 9 months or not saying even a few words by 16 months. Another is when they don't respond to their name. Prevention is simple but powerful. Describe what you are doing. Sing. If a baby doesn't look at faces, rarely smiles, interested in people by 6 to 12 months, worth paying attention. Support this by playing face-to-face games, encouraging interaction, including the child in daily family routine. Might be anything, dishwashing, or even drying your clothes. Screen time steals social time. Nothing replaces real connection. Some 10 years back, grandmother bring her grandchild to the OP. She will tell, doctor is tired, prepare a dosa for him. What the girl child will do, you know, it will just say, "Ush," and come and feed me. But now, when I ask them dosa, just child picks up the phone to order in Swiggy. So times are changing. With regard to emotional development, this is how a child learns to understand and manage feelings. If a child doesn't show joy, fear, or affection appropriately, or if meltdowns are extreme, past toddler years, you may need to step in gently. We can help by labeling their feelings. You are upset because the toy broke. So futurely, you be careful. Create predictable routines, stay calm, and model healthy emotional responses. Emotional literacy starts at home. The another facet will be key for physical fitness. The slogan will be sit less, move more. Babies need 30 minutes of tummy time, each crawling and rolling over. Toddler and preschoolers need 3 hours of play every day. By 5 to 12 years, it should be around 3 hours of physical activity. Tips to get the child active. This is, of course, the disadvantage of screen time. Choose toys that helps kid move. Don't carry tabs for outing. Show your kids you like being active too, like cycling in a hill station or dancing together. Ask. I prefer this monkey bar. Monkey bar, I don't know how many of you are aware of this. This is an excellent toy. It can be altered in several ways. It helps the child to climb, which needs hand-eye coordination, then improves motor skills. Foot arches also develop. For a 2-month-old baby, you can show wiggle toys which develop vision and tracking skills. Talking your baby helps listening, vocal and language skills. Cuddle time helps bonding. Exploration to touch builds sensory skills. Reading builds cognitive and language skills. For a 4-month-old baby, reading and bonding develops imagination and vocabulary. Exploration time. Introduce your baby to different textures and toys. Teaches them cause and effect. The bubble game develops hand-eye coordination. Singing boosts baby's cognitive and social skills. Strengthens a bond between a parent and child. For 9 months, you can have a toy in the bucket. It develops motor and language skills. Squeak and hide enhances cognitive auditory development. Ball rolling develops gross motor and imitation. Hide and seek strengthens visual tracking and object permanence. Clapping and singing promotes muscle growth and hand-eye coordination. We'll move on to sensory processing and regulation. This is how children respond to sight, sounds, texture, and movement. If a child overreacts to normal sound, or if they constantly seek spinning or crashing movements, it may be a sign of sensory regulation difficulty. Support this by offering a variety of sensory experiences like soft fabrics, music, sand, water play, what they enjoy or avoid. Every child possesses or processes the child differently. Our job is to understand their unique rhythm. Social and emotional development. You have to teach them how to express their happiness. Share my happiness with the loved ones. They can clap their hands and jump up and down. They can sing and dance to a favorite song, or they can draw a rainbow and be happy. How to express sadness? You can tell your mom or teacher. You can sit quietly and color song. Or of course you can cry a little, it's okay. Prolonged cry is not necessary. Or sit in a quiet corner and look at books. How can they express when they are angry? They can squeeze a stress pillow or a ball. Count slowly from 1 to 10. Jump or run in a place to release energy. Take 5 big dragon breaths. Deep breathing can. How can you express when you are scared? Say brave words. I can over this. I must. Take 5 slow belly breaths. Hold a stuffed toy or blanket. Think of a safe place to sit or talk to someone you trust. Another important facet will be drink. For 1 to 5 years, it's around 1.5 liters per day. Beyond 6 years, 1.5 liters. Requirements might increase with physical activity or summer or sickness. So, encourage kids to drink water. Show them you like water too. Carry a water bottle when you go out. With regard to vegetable and fruit intake, everyone knows it. You can include a vegetable and fruit every day. But you can train your child to prepare healthy snacks at home. This will increase the intimacy of the also. So cut fruits in an awesome manner, which increases craving for fruits. My elder son used to follow this. He will not cut in the routine way. For example, you can cut your tomatoes like butterfly or cucumber like a heart. same cucumber, and carrots, watermelon. This will increase the curiosity and child will take more. With regard to moral and spiritual development, the key factors are building empathy, respecting differences, developing values. Moral and spiritual, key strategies for building empathy. Empathize with your child. Encourage perspective taking. Accept your child's emotions. Be a role model. Talk about others' feelings. Active listening. Praise acts of empathy. Moral and spiritual. Respecting differences means treating everyone with kindness and understanding, regardless of how they are different from you. Closing lines. Every child is beautifully unique. While they grow at their own pace, it's our consistent nourishment, nurture, and presence that lays the strongest foundation. By staying observant and involved, we can support their growth and catch concerns early. Remember, the most powerful prescriptions for a child's development aren't written by hand, and they are given through love, time, and trust, the invisible prescription. The carry-home messages will be: sit less, move more water, more veggies and fruits. Never forget to expose your child to failures. In that sense, video games are doing good. In one game you will fail and you will be called as busted. So that helps the child to accept failures. And never forget to write an invisible prescription every day in your busy practice. Finally, never forget to respect your child. Thank you, and I make myself invisible, and of course, invisibly yours. Thank you.
Thank you, sir, for your extensive and elaborative presentation. So as a treating psychiatrist, we are all having illness center. So we are providing treatment. It's our duty to provide treatment, but also to provide them physical, mental, spiritual, and social wellness. So a new concept, wellness center, is nowadays arriving. As a psychiatrist, I am seeing a good number of children with yearly exposure to electronic gadgets coming to me with attention deficit disorders, eating disorders, sleeplessness, and impulsivity, and self-harm behaviors. And even a lot of children will be having poor academic performances also. So I'm having a practical pediatrician with more than 30 years of experience. So you have seen quite good number of parents. So what are the difficulties now you are facing with the current generation parents? I'm asking about 2020s to 2025 current generation parents. So how they take your advice, and what are the difficulties to give them understand about the illness, their children's illness?
So, right in front of my eyes, when both parents, they come with their kid, the kid will be sitting in the center, mother will be having on phone, swiping it the other side, father will be turning to the other side. A cute little girl around 3 years will be sitting in the center. Baby will ask, I'll have a Spider-Man right behind me. The child will ask, Daddy, what's that? The father will say, even not lifting his eyes from the phone, stupid, shut up, doctor is seeing cases. That is a watchman, shut up. So 99% of the parents, they never ever spend a single minute with their babies. Educated, okay? The bitter side. The more beautiful side is, a lady of my age brought her 3.5-year-old kid, girl child, to my consultation. I was writing a prescription. But I could hear what she was telling to her grandchild. She was telling, இந்த வருமா வெளியில் ஒரு கேட்டில் வாட்ச்மேன் தாத்தா இருந்தார். அவர் ஒன்றுமே படிக்கலை, வெயிலில் மழையிலலாம் இருக்கார், பேடு ஹேபிட்ஸ் இருக்குது, சிகரெட்லாம் குடிக்கிறாரு, சட்டை பட்டன்லாம் போடலை, ஏன்னா அவர் படிக்கலை. நீ படிக்கணும். இங்கே உள்ள சிஸ்டர்லாம் இருக்காங்க, எல்லாம் கோட் போட்டு இருக்காங்க, கொஞ்சம் படிச்சிருக்காங்க, ஆனால் நின்றுக்கிட்டே இருக்கணும். டாக்டருக்கு திட்டுவார், கொஞ்சம் தான் படிச்சிருக்காங்க. இவரை பார்த்தியா நிறையா படிச்சுட்டு டாக்டர் சேர் சீட்டோல் வீல் சேர். டாக்டர் பார்த்தியா நல்லா ஜாலியாக வீல் சேரில் உட்காந்து சுற்றிக்கிட்டே இருக்காரு. குளிர் வந்து நீ படிக்கணும். ஸோ ஐ வாஸ் டோட்டலி ஷாக்ட். அடுத்த பேர் இந்த அம்மா வயிற்றில் பிறக்கணும்னு நினச்சேன். இட்ஸ் டிஃபரன்ஸ் பிட்வீன் எஜுகேட்டட் அண்ட் அன்எஜுகேட்டட். எஜுகேட்டட் தான் தே with their kids. It's a horrible fact.
Thank you, sir, for sharing your wonderful experiences. Any questions from audience?
So future parents will be aware.
Sir,
Postgraduates.
We are seeing a good number of anxiety parents. They are more anxious nowadays. So in dealing with the childhood disease, so they won't be able to understand the disease pattern and the course of illness, everything. So I am seeing a lot of parents coming to me with more anxiety.
Anxiety, but I could even I would have seen mother, because of conflicts between their child and their what to say, our chittapaoda son, co-sisteroda son, controversiesnala I have seen young mothers committing suicide also.
Any questions from audience? So if there is no question, let me wind up the session. So thank you, sir. Thank you so much.
Thank you, sir, for a wonderful session. Now I request Dr. Sivasailam, sir, Senior Psychiatrist, IMA Secretary, to honor our speaker, Senior Pediatrician, Dr. Ilangovan, sir, with a memento. I request Dr. Ilangovan, sir, to honor our chairperson, Dr. Sivasailam, sir, with a memento.
Thank you, sir. Now let's move on to the next session on pediatric epilepsies by Dr. N. Nandakumar, sir, who is a pediatric neurologist. Sir is a pediatric neurologist at Nambiappan Hospital, and sir has a total years of experience of 18 years. And he was a principal investigator at ICMR project on phenotype and genotype correlation in DMD. And sir has done many publications, like he has done a retrospective study of FARES and common neurological manifestations with uncommon inherited metabolic disorders. We welcome you, sir. The chairpersons of this session are Dr. Kannan, sir, Senior Neurologist, Thuthukudi Medical College; Dr. Flora, ma'am, Head of the Department of Radiology, Thuthukudi Medical College; Dr. Babita, ma'am, Chief, Department of Pediatrics, Thuthukudi Medical College. I request all the chairpersons to occupy the dais.
Good afternoon.
Good afternoon, sir. Good afternoon to one and all, sir. So I first wishes Dr. Kumaran, sir, happy retirement life, sir. Thank you, sir. With this, so Dr. Nandakumar, sir, is a senior pediatric neurologist. He will define the pediatric epilepsy very simplified manner, because epilepsy, we all know, it is very complicated. One of the super specialty from epilepsy, from neurology. Still, pediatric epilepsy is a very important topic that will be clinically very useful. Over to you, sir. Over to you.
Good afternoon. Thank you for inviting me to this retirement function of Dr. Kumaran. தூத்துக்குடியின் மார்க்கண்டேயர். எப்போ சார் வயசாகும்? Topic. I specifically chose this pediatric epilepsy simplified. பின்னாடி இருக்கிற எல்லாருக்கும் இப்போ ஸ்லீப் மயக்கலோனஸ் வந்துடும். பின்னாடி இருக்கிறது அண்டர் கிராஜுவேட்ஸா போஸ்ட் கிராஜுவேட்ஸாங்க? Can I have a show of hands for post graduates? ஒரு பயம் இல்லை. அண்டர் கிராஜுவேட்ஸ் எல்லோரும் அண்டர் கிராஜுவேட், சூப்பர். எல்லோரும் அப்படியே கொஞ்சம் முன்னாடி வந்துடுறீங்களா? கொஞ்சம் எந்திரிச்சு நடந்து வாங்க, தூக்கம் போகும். சும்மா வாங்க, கேள்வி கேட்க மாட்டேன். This lecture will have about 5-7 minutes of written material, and rest of the time is only videos. If we come forward, you will be able to see the videos bit better. That's all I wanted you to do. If you want to stay at the back, feel free to stay. இப்போ பார்த்தது சீஷரா இல்லையா? யாரும் எப்படி ஒன்றும் பதில் சொல்ல மாட்டாங்க, நானே சொல்லி முடிச்சிடறேன். இது ஒரு நர்ஸோட குழந்தை. கன்சர்ன். உங்களுக்கு பின்னாடி எல்லாருக்கும் எப்படி தூக்கம் அப்படியே தலையை தட்டிக்கிட்டு இருக்கீங்களோ அதே மாதிரி தான் அந்த குழந்தையும் பண்ணிக்கிட்டு இருக்கு. திஸ் இஸ் இப்போ ஒன் டைப் ஆஃப் அ ஸ்லீப் மைக்ளோனஸ் விச் இஸ் அ பெனைன் கண்டிஷன். ஒரு மைனர் ஃபார்ம் ஆஃப் ஸ்டார்டல் ரிஃப்ளெக்ஸ்னு சொல்லிக்கலாம். பீடியாட்ரிக் எபிலிப்சி உண்மையிலேயே ரொம்ப சிம்பிள் தான். ஹிஸ்ட்ரி கரெக்ட்லி. I cannot emphasize more on this. History does clinch the diagnosis. Not any of the investigations or your tests or any other thing will not do anything. Exact details of what has happened before, during and after, like your antenatal, natal and postnatal. You have to choose the appropriate drug at the appropriate dose. இல்லைனா ஸ்விக்கிலையாவது ஆர்டர் பண்ணிடுங்க, எங்கள்கிட்ட ரெஃபர் பண்ணிடுங்க. எய்ம் ஃபார் மோனோதெரப்பி. ஒரு ட்ரக்கில் கண்ட்ரோல் பண்ண முடியுமான்னு பாருங்கள். முடியலன்னா அதுக்கப்புறம் என்னென்னு பேசுவோம். இது நார்மலா அப்நார்மலா? People will often start anti-epileptic drug thus for this one. This is again a sleep myoclonus. காரணம் என்னென்னா கொட்டாய் விடுற குழந்தை it is normal. As soon as the baby had a seizure or a myoclonic jerk, the baby yawned, which is normal. ஆண் பெண் இருபாலர் மாதிரி ரெண்டு டைப் ஆஃப் எபிலெப்சி தாங்க. ஜென்ரலைஸ் சீஷர் இல்லைன்னா ஃபோக்கல் சீஷர். இன் பிட்வீன் கொஞ்சம் இருக்குது. All the epilepsies can be classified into these three categories: idiopathic, symptomatic and cryptogenic. Idiopathic na யாராவது விளக்கம் சொல்ல முடியுமா? Not related to epilepsy for anything. இது அண்டர் கிராஜுவேட் கொஸ்டின் தானே. என்னம்மா காரணம் தெரியாது. அது வெள்ளக்காரங்க எப்படி சொல்லுவாங்க அப்படின்னா, இடியாட்டிக் அண்ட் தி டாக்டர்ஸ் பார்ட், பெத்தட்டிக் அண்ட் த பேஷண்ட்ஸ் பார்ட். அப்படி தானே. நமக்கு தெரியாது, ஆனால் நம்மகிட்ட வைத்தியம் பார்க்க வந்திருக்கான். காசையும் வாங்கிட்டு மருந்தும் எழுதி கொடுக்குறோம். எவ்வளோ பெரிய கில்லாடி நம்ம. நெக்ஸ்ட் ஒன் இஸ் சிம்டமேட்டிக். ரைட். some abnormality in the brain or EEG or somewhere and you have the seizure, we call it a symptomatic. There is a cause, there is a problem. Cryptogenic. ஸோ இன்வெஸ்டிகேட் பண்ணால் எல்லாம் நார்மலாக இருக்கும், ஆனால் சைல்டுக்கு ஃபிட்ஸ் மட்டும் இருந்துக்கிட்டே இருக்கும். திஸ் இஸ் கிரிப்டோஜெனிக். ஆனால் இதெல்லாம் இட் இஸ் எவால்விங் இன்டு சம்திங் கால்டு ஜெனட்டிக்ஸ் இன் எபிலெப்சி. ஜெனட்டிக்ஸ் இட் இஸ் ஆல் கோயிங் டுவர்ட்ஸ் ஜெனட்டிக்ஸ். இனிமேல் வந்து ஜெனட்டிக்ஸ் எல்லாமே எபிலெப்சி இல்லை. அந்த ரெண்டு டைப் ஆஃப் சீஷர் சொன்னோம் இல்லைங்களா. ஜென்ரலைஸ்ட் சொன்னோம், ஃபோக்கல் சொன்னோம், அப்புறம் இடியோபதிக், சிம்டமேட்டிக் அண்ட் கிரிப்டோஜெனிக் சொன்னோம். நீங்கள் எந்த எபிலெப்சியை உங்கள் கிளினிக்கில் பார்த்தாலும் யூ கேன் pigeonhole into these 6 box. இதுக்குள்ளே உங்களுக்கு போட முடியலன்னா go back to the history and ask the history again. இதுக்குள்ளே தான் இருக்கும் எனி ஹிஸ்ட்ரி. எப்லெப்டிக் என்ன இருந்தாலும் சரி, எவ்வளோ காம்ப்ளெக்ஸ், எத்தனை பெரிய பெரிய நியூராலஜிஸ்ட் பார்த்துருந்தாலும் சரி, ஜெனட்டிக்ஸாக இருக்கலாம், எதா வேணா இருக்கலாம், ஆனால் இது உள்ளுக்கு ஃபிட்டின் பண்ண முடியல அப்படின்னா உங்கள் ஹிஸ்ட்ரி சரியில்லைன்னு அர்த்தம். இது தெரிஞ்சிச்சுன்னா ட்ரீட்மெண்ட் ஈஸி. ஸோ இது போக சிண்ட்ரோமிக் இருக்குது, ஜெனட்டிக்ஸ் இப்போ பெரிய கொஞ்சம் வித்தியாசம். பட் வி டோன்ட் கோ இன் டு தோஸ் டீடைல்ஸ். ஆனால் இந்த 6க்குள்ளே எல்லாத்தையுமே அடக்கிடலாம். கீழே இருக்கிற 3ஐயுமே இதுக்குள்ளே அடக்கிடலாம். எலக்ட்ரோ கிளினிக்கல் சிண்ட்ரோம்ஸ் கேள்விப்பட்டிருக்கீங்களா? யாராவது கேள்விப்பட்டதே இல்லை. போஸ்ட் கிராஜுவேஷனாக கேள்விப்பட்டிருப்பீங்க. இது கேள்விப்பட்டிருக்கீங்களாம்மா, சைல்டுஹுட் ஆப்சன்ஸ் சீஷர். நீங்கள் இப்போ எல்லோரும் இருக்கீங்கள்ல, ஒரு ட்ரான்ஸில் இருக்கீங்கள்ல, அதுதான் என்ன நடக்குதுன்னு தெரிஞ்ச மாதிரியே இருக்கும், ஆனால் கண்ணை திறந்துக்கிட்டே கிளாஸில் தூங்குவாங்க, அவங்க தான் இவங்க. சைல்டுஹுட் ஆப்சன்ஸ் சீஷர், இது எல்லாத்துக்கும் வீடியோ இருக்குது, எல்லாத்தையும் பார்த்துடலாம். ஜூனைல் ஆப்சன்ஸ் சீஷர் கொஞ்சம் பெரிய பிள்ளைங்களானா. ஜூனைல் மைக்லானிக் சீஷர் வந்தால் இது ஒரு இன்ட்ரெஸ்டிங்கான திங். நம்ம ஊரில் அடல்ட் நியூராலஜிஸ்ட் நிறைய பீடியாட்ரிக்கை ட்ரீட் பண்ணுவாங்க. கேட்டால் அவங்களுக்கு எல்லாம் தெரியும்னு சொல்லுவாங்க. பீடியாட்ரிக் நியூராலஜி எப்படி டிஃபர் ஆகும் அப்படின்னா, நிறைய பீடியாட்ரிக் நியூராலஜியில் எபிலெப்சியில் யூ டோன்ட் நீட் டு ட்ரீட், தேர் ஆல் செல்ஃப் லிமிட்டிங். அடல்ட்டில் அப்படி கிடையாது. காமன் கண்டிஷன், இதுக்கு சிண்ட்ரோம் பேர் சொன்னால் அவங்களுக்கு தெரியலாம், ரொலாண்டிக் சீஷர் சொல்லுவாங்க. அதோட பேர் வந்து பெக்ஸ்ன்னு இருந்தது, பிசெட்ஸ்ன்னு இருந்துச்சு. இப்போ ரீசெண்டாக செலக்ட்ஸ், செல்ஃப் லிமிட்டிங் எபிலெப்சி ஆஃப் சென்ட்ரோ டெம்பரல் ஸ்பைக்ஸ். ட்ரீட் பண்ணணும்னு அவசியம் கிடையாது. சிவியர் மைக்லானிக் எபிலெப்சி ஆஃப் இன்ஃபென்சி, உங்களுக்கு வேண்டாதவனுக்கு சாபம் கொடுக்கணும்னு நினச்சிங்கன்னா இந்த எபிலெப்சி வந்துடும் அப்படின்னு சொன்னால் ட்ரீட் பண்ண முடியாது. லெனாக்ஸ் ஜெஸ்டர்ஸ் இஸ் அனதர் டிஃபிகல்ட் எபிலெப்சி. லேண்ட் ஆஃப் கிளஃப்னர், அதை எப்படி கண்டுபிடிக்கிறது அப்படின்னா, சீஷர் இருக்கும் ஆனால் ஸ்பீச் ரிக்ரெஸ் ஆகிட்டே வரும். வெஸ்ட் சிண்ட்ரோம், நம்ம டாக்டர் ஹேண்ட் ரைட்டிங் மாதிரி இருக்கும் அவங்க. இஇஜி, ஹிப்செரித்மியா, இல்லைன்னா யார் டாக்டர் ப்ரிஸ்கிரிப்ஷனையாவது பாருங்கள். குமரன் எழுத்தெல்லாம் நல்லா தான் இருக்குது. ஒய் வி பாதர் அபவுட் திஸ் எலக்ட்ரோகிளினிக்கல் சிண்ட்ரோம், இது தெரிஞ்சால் தான் நம்ம பேஷண்ட்டை பேச முடியும். இது இப்படி இருக்குது, அதனால் இப்படி தான் இருக்கும். இல்லை இப்போ நமக்கு பினைன் மைக்லானிக் எபிலெப்சி ஆஃப் இன்ஃபென்சி இருக்குன்னா, அவன் லேசாக ஏதாவது சார் இன்னொரு டாக்டரை பார்க்கலாம்னா உடனே உங்கள் காம்படிட்டருக்கு லெட்டர் எழுதி கொடு. இதெல்லாம் உங்களுக்கு டயக்னோசிஸ் தெரிஞ்சால் மட்டும்தான் பண்ண முடியும். ஸோ ஃப்யூச்சராக என்ன இன்வெஸ்டிகேட் பண்ணலாம், என்ன ட்ரீட் பண்ணலாம், ப்ரொக்னோசிஸ் எப்படி இருக்கும், சீக்கிரம் செத்து போயிடுவானா, இல்லை ரொம்ப நாள் இருப்பானா, இல்லை இருந்து நம்மளை கொல்லுவானா, இது எல்லாம் இது தெரிஞ்சால் தான் பண்ண முடியும். இந்த பேஷண்ட்டை நம்ம ஹோல்டு பண்ணுறதா, இல்லைன்னா கலத்தி விடுறதா, இல்லை ஹையர் சென்டர் ரெஃபர் பண்ணுறதா, இது எல்லாமே இதில் தான் இருக்குது. ஆன் டாப் ஆஃப் இட் என்னை மாதிரி கொட்டிக்காரனுக்கு ரிசர்ச்சுக்கும் இது யூஸ் ஆகும். இஇஜி நம்ம ஊரில் எல்லாத்துக்கும் இஇஜி. நீங்கள் எங்கே போனீங்கனாலும் ஃபாலோ அப் வரும்போதெல்லாம் இஇஜி எடுப்பாங்க. அதில் என்ன பார்ப்பாங்கன்னு எனக்கு இன்றைக்கி வரைக்கும் தெரியாது. எனக்கு இன்றைக்கி வரைக்கும் இசிஜி ஒழுங்காக பார்க்கவும் தெரியாது, பார்க்க தெரிய வேண்டிய அவசியமும் கிடையாது. ஆனால் யூ கேன் நாட் எக்ஸ்க்ளூட் ஆர் இன்க்ளூட் epilepsy by doing an EEG, but you can do electroclinical syndrome. அதுக்கு கிளாசிக் பேட்டர்ன் இருக்குது, அது எந்த இடியட் பார்த்தாலும் சொல்லிடலாம். இமேஜிங் தயவுசெய்து நீங்களாவது பெரியவளாகி ஏதாவது பண்ணும்போது இமேஜிங் எடுக்கணும்னு நினச்சா எம்ஆர்ஐ எடுங்க. எல்லோரும் சிடி எடுக்கிறாங்க. ப்ளீடு கால்சிஃபிகேஷன் மட்டும்தான் தெரியும். ஆன்டிஎபிலெப்டிக் இப்படி கிளாசிஃபை ஞாபகம் வச்சுக்கோங்க. ஆனால் இது எதுவுமே தேவையில்லை. ப்ராட் ஸ்பெக்ட்ரம், நேரோ ஸ்பெக்ட்ரம், டார்கெட்டட், ஆனால் கான்ட்ராண்டிகேஷன் தெரியணும். கடைசி பாயிண்ட். இதை மட்டும் ஞாபகம் வச்சுக்கிட்டா போதுங்க. மைக்லானிக் எபிலெப்சிக்கு தயவு செய்து கார்பமிசிபினை கொடுத்து கொன்றாதீங்க. எபிலெப்சி வில் கெட் வர்ஸ். இந்த ஃபேன்சி ரைட்டு, இந்த ஒரு ஸ்லைடு தெரிஞ்சால் நீங்கள் எபிலெப்சி ட்ரீட் பண்ணிடலாம். ரொம்ப கிளியராக இருக்குல்ல சார்? எதையுமே நீங்கள் ஃபோட்டோ எடுக்க வேண்டாம் சார், எல்லாமே நைஸ் கைட்லைனில் இருக்குது சார். இந்த பக்கம் இருக்கிறதெல்லாம் சீஷர் டைப்பு பேருங்க. ஜென்ரலைஸ் டானிக் கிளானிக் சீஷர், ஆப்சன்ஸ் சீஷர், ஃபோக்கல் ஆப்சன்ஸ் ப்ளஸ் ஆர் மைனஸ் ஜென்ரலைசேஷன், மைக்லானிக், டானிக், போட்டாச்சு. அந்த பக்கம் ஃபஸ்ட் லைன் ஆஃப் ட்ரக், செகண்ட் லைன் ஆஃப் ட்ரக், அதுக்கப்புறம் ஃபஸ்ட். ஸோ இது கொடுத்து கேட்கலன்னா அதை சேருங்க, அதையும் கொடுத்து சேரலன்னா அதை சேருங்க, அதையும் கொடுத்து சேரலாம் அதில் சேருங்க. ஆனால் இது ரெண்டாவதுல சேரலன்னா அது எவன்ட்டையுமே சேராது. ரொம்ப கஷ்டம். உண்மையிலேயே அப்படி தான். பீடியாட்ரிக் நியூராலஜியில் 100% எடுத்தீங்க அப்படின்னா 33% உங்களுக்கே தெரியும், இன்னொரு 33% எனக்கு தெரியும், இன்னொரு 33% யாருக்குமே தெரியாது. அதுதான் பீடியாட்ரிக் நியூராலஜி. ஸோ இது இப்படி இவ்வளோ ட்ரக்ஸ் எஸ்விஏ, சோடியம் ஆல்புரைட், ஈத்தோசெக்சிமைட், லிவாட்ரிசிட்டம், லாமோட்ரிஜின், ஸ்டீராய்ட்ஸ், வைகபாட்ரின், டோபிரமைட், கீட்டோஜெனிக் டயட், ஜோனிசிமைட், லாக்கோசமைட், பிரிவாசிட்டம், பெராம்பனால், இதெல்லாம் இருக்குது. இதெல்லாம் ஃபஸ்ட் ஜென்ரேஷனில் இந்த எல்லா ஜென்ரேஷனும் ரொம்ப கஷ்டப்பட்டு ஃபோட்டோ எடுக்க. இந்த ஹோல் பாயிண்ட்டே அதுதான். இப்போ எல்லாத்துலேயும் சிவப்பில் என்ன கலர் இருக்குன்னு பாருங்கள், சிவப்பில் என்ன லெட்டர் இருக்குன்னு பாருங்கள். லிவாட்ரிசிட்டம். எந்த எபிலெப்சியாக இருந்தாலும் தயவு செய்து லிவாட்ரிசிட்டம் கொடுங்க, நீங்கள் சேஃப். யாருமே தப்பு சொல்ல முடியாது. கேட்கலன்னா தெரிஞ்சவன்ட்ட அனுப்பி விட்ருங்க, இல்லைன்னா டோஸை கூட்டி பாருங்கள். பீடியாட்ரிக் எபிலெப்சி சிம்பிளிஃபை ஆகிடுச்சா? இவ்வளோ தான் பீடியாட்ரிக் எபிலெப்சி. இதுக்கு மேலே அங்கே ஒன்றுமே கிடையாது. வெட்டி இழுத்தா லிவாட்ரிசிட்டம் போட்டுருங்க, வேலை முடிஞ்சுது. இப்போ கேசஸ் பார்ப்போம். இது ஃபோக்கல், சும்மா ஃபோக்கலாக ஜென்ரலைஸ் தான் மட்டும் சொல்லுங்கள். ஃபோக்கல். ஆனால் வந்திருக்கிறது நியூபார்னில் எப்படி சீஷர் வந்தாலும் யூ ஹேவ் டு டேக் இட் அஸ் அ ஜென்ரலைஸ்ட் ஒன். அதுக்காக தான் அந்த ஸ்லைடு, வேறு ஒன்றுமே கிடையாது. இது இது ஏன் வந்திருக்குன்னு ஒரு அண்டர் கிராஜுவேட் சொன்னால் நான் ஒரு 100 ரூபா தரேன். என்கிட்ட கையில் காசு இல்லை, ஏன்னா கிளாஸ்மேட்டு ததைஸ் வச்சுருப்பான். யாராவது சொல்லுங்கப்பா, இந்த பிள்ளைக்கு ஏன் ஃபிட்ஸ் வந்திருக்குன்னு அதில் இருக்குது, செவத்தில் எழுதி ஒட்டியிருக்கு. எதனால் சார்? இன்ஃபியூஷனா சார்? புள்ள குண்டாக இருக்குது, ஃபிட்ஸ் அடிச்சுக்கிட்டு இருக்கு. என்ன லாமோட்ரிஜினா? எதனால்? அவர் சுகருக்கு வந்துட்டார். கரெக்டாக சொல்லிட்டீங்க. பல கிளூ கொடுத்ததுனால உங்களுக்கு 100 ரூபா கிடையாது. இதே எங்கள் வார்டுக்கு வந்த இதில் எனக்கு இது முடிஞ்சப்பறம் நீங்கள் ஜென்ரலைஸ் தான் சொல்லணும். இந்த ஸ்லைடில் ஒரு தப்பு இருக்குது, அது என்னன்னு சொல்லணும். இது எல்லாமே எங்கள் ஹாஸ்பிட்டலில் வந்த பேஷண்ட்ஸ் தான், என்னோடய பேஷண்ட்ஸ் தான். எனக்கு ரைட்ஸ் இருக்குது, ஆனால் யாரும் தயவுசெய்து வீடியோவோ ஃபோட்டோவோ எடுத்துடாதீங்க, அதுக்கு ரைட்ஸ் இல்லை. ஜென்ரலைஸா ஃபோக்கலா? ஸோ ஜென்ரலைஸ். இந்த ஸ்லைடில் என்ன தப்பு இருக்குது? ஆக்சிஜன் வைக்கல, சூப்பர், ஒப்பேறிடுவீங்க. இது முதல் கேள்வி, எபிலெப்சியா இல்லையா, சீஷரா இல்லையா? சீஷர் இல்லைன்னா வேறு என்னது மேடம்? ஓரோஃபேஷியல் இது எதில் வரும்? நீங்கள் ரொம்ப படித்தவங்க, மெடல் வாங்கினவங்க எதில் வரும்? ஓரோஃபேஷியல்னு சொல்கிறாங்க. கடந்த 10-15 வருஷமாகவே இருக்குது. இப்போ தான் நம்ம ஊரில் புதுசாக சொல்கிறாங்க. ஆட்டோ இம்யூன் என்கெஃபலைட்டிஸ்னு ஒரு கண்டிஷன் இருக்குது. ஏர்லியராக ட்ரீட் பண்ணால் நல்லாயிருவாங்க, இல்லைன்னா ரொம்ப சீக்கிரம் போயிடுவாங்க. இது ஒரு இன்ட்ரெஸ்டிங்கான வீடியோ. அந்த குழந்தைய பாருங்கள், பார்த்துட்டே இருங்க. என்னோட கன்சல்டேஷன் ரூமில் அந்த குழந்தைக்கு ரொம்ப நாளாக அது வந்துக்கிட்டே இருக்குது. ஃபீவர், தலைவலி தலைவலின்னு 2 வருஷமாக சொல்லிக்கிட்டே இருக்கலாம். இந்த கையை எப்படியே பண்ணிக்கிட்டே இருப்பாலாம், தலையை சொரிஞ்சிட்டே இருப்பாலாம் 2 வருஷமாக. திஸ் இஸ் ஃபோக்கல் எபிலெப்சி. இந்த குழந்தைக்கு எல்லாமே நல்லா தான் இருக்குது, ஆனால் தலையை சொரியிறா, அப்நார்மல் ஏதோ பண்ணிக்கிட்டு இருக்கான்னு மந்திரிச்சிட்டு வீட்டில் உட்காந்துருக்காங்க. இவளுக்கு கடைசியில் ஷி ஹேட் ரேஸ் முசன்ஸ் என்கெஃபலைட்டிஸ் ஆகி நடுவில் கொலசெக்டமி பண்ணி வச்சுருக்கோம். இப்போ பார்த்தது என்னது, முதல்ல பார்த்த வீடியோ பார்த்தீங்கல்ல, ஒரு குழந்தை முதல்ல படுத்து தூங்கிட்டு இருந்துச்சு இல்லையா? ஸோ அதுவும் இதுவும் சிமிலராக இருக்கா? இன்னொரு குழந்தை பண்ணிவிட்டு அதுக்கப்புறம் யானிங் பண்ணிச்சு இல்லை, ஏன்னா இந்த குழந்தை வெல் அவேக்காக இருக்குது ஆனால் பண்ணிக்கிட்டு இருக்கு. ஸோ திஸ் இஸ் கால்டு மயோக்ளானிக் எபிலெப்சி. ஹேவ் சடன் ஜெர்க்ஸ் ஆஃப் மசில், மயோக்ளானிக் எபிலெப்சி. இது சின்ன 2 மாதத்து குழந்தை. திஸ் குட் பி சிவியர் மயோக்ளானிக் எபிலெப்சி ஆஃப் இன்ஃபென்சி. இட் வில் பி வெரி வெரி டிஃபிகல்ட் டு ட்ரீட். ஹையர் சென்டருக்கு ரெஃபர் பண்ணிடுறது நல்லது. ஏன்னா நம்ம தலையில் உட்காந்துட்டு நம்ம தலையை தின்னுக்கிட்டு இருப்பாங்க, வேலை பார்க்க முடியாது. இப்போ உங்களுக்கு தெரியும் கேட்குதா? இவங்க டப்பு டப்புன்னு எடுத்தே சொல்லிக்கிட்டே இருக்காங்க. சலாம் அட்டாக் அங்கே இருந்து 4வது ஆள் சலாம் அட்டாக்னா என்னன்னு சொல்லுங்கள். கேட்டதுக்கு ஒரு காரணம் இருக்குது. நீங்கள் தான் உட்காந்துருக்காங்க உங்களே மாதிரி, அவங்களும் சொல்லலாம். ஏன் அதை சலாமட்டா கேள்விப்பட்டிருக்கீங்களாம்மா? நீங்கள் சலாம் எப்படி சொல்லுவீங்க? ஸோ உடம்பெல்லாம் குறுக்கி சொல்லுவீங்க. ஸோ அதர்வைஸ் இட்ஸ் கால்ட் இன்ஃபென்டைல் ஸ்பாசம். இது ரொம்ப சட்டிலாக தான் இருக்குது, ஆனால் வந்தால் கடக்கடன்னு வந்துக்கிட்டே இருக்கும். இதுவுமே ட்ரீட் பண்ணுறதுக்கு டிஃபிகல்ட்டாக தான் இருக்கும். இது எபிலெப்சியா இல்லையா? இதுவும் ஓராஃபேஷியல் தான் மேடம் சொன்ன மாதிரி. இதுவும் ஆட்டோமியூன் என்கெஃபலைட்டிஸ் தான், டிஃப்ரெண்ட் ஃபார்மேட். ஆப்சன்ட் சீஷர் எத்தனை பேருக்கு தெரியும்? கை தூக்குங்க பார்ப்போம். சார் நீங்கள் சும்மா இருங்க சார். ஆப்சன்ட் சீஷர் யாராவது பார்த்துருக்கீங்களாம்மா? பின்னாடி இருக்கிற ஸ்டூடெண்ட்ஸ் யாராவது பார்த்துருக்கீங்களா? அதை இன்டியூஸ் பண்ணலாம் கிளினிக்கில். இனஃப் டைம் ஸ்பெண்ட் பண்ணிங்கன்னா அதை எப்படி பண்ணணுங்கிறதுல தான் கேட்ச் இருக்குது. ஸோ அந்த பையனை வந்து பேப்பரை ஊதி ஃப்ளோட் பண்ண வைக்கணும். அவனை ஹைப்பர் வென்டிலேட் பண்ணிங்கன்னா அந்த சீஷர் வரும். இப்போ வரும் பாருங்கள். நீங்கள் சும்மா ஊதுன்னு அவன் 2 தடவை ஊதிட்டு விட்டுருவான். ஸோ யூ ஹேவ் டு ஆஸ்க் ஹிம் டு கீப் அ பேப்பர் அஃப்ளோட். ஒரு நிமிஷம் ஃபுல்லாக ஹைப்பர் வென்டிலேட் பண்ணால் வரும். எவ்ரி ஆப்சன்ஸ் கேன் பி ரீப்ரொடியூஸ்ட். இஇஜி எடுக்கும்போது இதை பண்ணி எடுத்தால் அந்த ஸ்பைக் வேவ் பேட்டர்ன் கிடைக்கும். ஆனால் யாரும் பண்ண மாட்டாங்க, ஏன்னா வெளியே 50 பேஷண்ட் உட்காந்துருப்பான். வந்துருச்சா? ஸோ ஸ்டாரிங் அப்படியே இருப்பாங்க. ஒரு 10 செகண்ட் 15 செகண்ட் மேபி மேக்ஸ் ஒரு 25 செகண்ட்ஸ் இருப்பாங்க. அதுக்கப்புறம் விட்டதுலேருந்து பண்ண ஆரம்பிச்சிருவாங்க. So yes, come back now. இவன் என்னன்னு பாருங்க. இவன் ஒரு இன்ட்ரெஸ்டிங்கான கேரக்டர். இதுவும் என்னோட கிளினிக் ரூம். என்னம்மா? டூரெட்ஸ். ஏன் டூரெட்ஸுக்கு ஒரே ஒரு ஃபீச்சர் ரூபா கொடுத்துட்றேன். ஓக்கல் டிக்ஸ் இருக்கணும். ஓக்கல் இருந்தால் தான் டுரெட் பேர் வரும். இல்லைன்னா இன்னொரு பேர் என்னது அதுக்கு? டிக்ஸ். நீங்கள் இப்போ தாடியை தடவிட்டு இருக்கீங்களா, அதுவும் டிக்ஸ். அதே மாதிரி அவர் தோள்பட்டையை குலுக்கிக்கிட்டு இருக்கார். ரைட்டா? இல்லை நிறைய பேருக்கு இருக்கும். சிலவங்க இப்போ பேசி கண்ணாடி இப்படி பண்ணுவாங்க. சிலவங்க உட்காந்துருக்கும்போது காலை மட்டும் ஆட்டிக்கிட்டு இருப்பாங்க. சிலவங்க மண்டையை சுரிஞ்சிக்குவாங்க. சிலவங்க கண்ணாடி எடுத்துடும். இது எல்லாமே டிக்ஸ் தான். டிக்ஸ் எப்போ நம்ம ஷோல்டருக்கு மேலே வருதோ வெளியே தெரியும், கீழே இருந்தால் தெரியாது. நீங்கள் உங்கள் காலை கையை சுரிஞ்சிட்டு இருந்தீங்கன்னா ஒன்றும் தெரியாது. தலையை சுரிஞ்சிங்கன்னா இட் பிகம்ஸ் எ டிக். சரி, இவனுக்கு நான் டிக்ஸ்ன்னு சொல்லி அனுப்பியாச்சு. அப்புறம் சுற்றி டிக்ஸ் இல்லைன்னு சொல்லி அவன் பள்ளிக்கூடத்துக்கும் போல ஒன்றும் செய்யலை. 2 வருஷம் கழிச்சு வந்திருக்கான். எப்படி இருக்கான்னு பாருங்கள். டிக்ஸ் எப்படி எவால்வ் ஆயிருக்குன்னு பாருங்கள். அவன் வீட்டில் எல்லா ப்ளே ஸ்டேஷன்லேருந்து எல்லாம் வாங்கியாச்சு. அவ்வளோ வாங்கி வீட்டில் உட்காந்து விளையாண்டுக்கிட்டு இருக்கான். எனக்கு உடம்பு சரியில்லைன்னு சொல்லிட்டு. he has gone worse. அவன் பாஸ்டரே போயிட்டு வெறும் டிக்ஸ் அவனுக்கு. ஸோ சில்ட்ரன் கேன் மில்க் அவுட் ஆஃப் யூ. வீடியோ எடுக்க ஆரம்பித்த அப்புறம் குறைஞ்சிருச்சு. இது நான் நிறைய தடவை காட்டியிருக்கேன், தூத்துக்குடியிலே ஒரு தடவை காட்டியிருக்கேன். சாப்பாடு ரொம்ப ஆகிட்டு நினைக்கிறேன், தூக்கம் வந்துட்டு சார். இந்த முடிஞ்சிருச்சு. இதுதான் இது என்னது? சீசர் இல்லையா? அவ்வளோதான், சீசர் தான். அப்படி சொல்லி தான் அந்த பிள்ளைக்கு சோடியம் ஆல்பரேட்டு எல்லாம் போட்டு அனுப்பியிருந்தாங்க. In this age, it's very normal, happy child, and when you make her excite by showing some toys, different mannerism. Take a message. முடிஞ்சதே. Diagnosis epilepsy இல்லையா? முடிஞ்சிருச்சு. எபிலெப்சியா இருந்துச்சுன்னா லெவாட்ரசிட்டம். கார்பமிசிப்னு எங்கே கொடுக்கக்கூடாதுன்னு புரிஞ்சு வச்சுக்கோங்க. எபிலெப்சி is so simple. This is simplified by this great pediatrician. நீங்கள் இவரை பார்த்துருக்கீங்களா? யாராவது பெரியவங்களுக்கு தெரிஞ்சிருக்கும். He is called Dr. முகமது தம்பி. He is the first pediatrician. He is an American board. அவரை மாதிரி ஒரு எபிலெப்சி யாராலையுமே சொல்லிக் கொடுக்க முடியாது. It's a tribute to him. Thank you.
Thank you, sir, for such an...
அந்த ட்ரக் ஆஃப் சாய்ஸ் யாருக்காவது இன்ட்ரெஸ்ட் இருந்துச்சுன்னா நைஸ் கைட்லைன்ஸ்னு சும்மா கூகுளில் போட்டிங்க இல்லை ChatGPTயில் போட்டிங்கன்னா வந்துடும். என்னோட வேலை முடிஞ்சது. தேங்க்யூ சார்.
Over to chairpersons.
Thank you, sir. It was a very concise and up to the point.
Thank you, madam.
Very helpful for us to understand on pediatric epilepsies. We always have few diagnostic dilemmas and how to proceed with children in certain conditions. Like infantile spasm is epilepsies to treat sometimes. We have children who have typical features of infantile spasm and not responding to levetiracetam, but the EEG doesn't show typical hypsrhythmia features. Typical EEG findings also. So in such case, how to proceed with this?
As I said initially, epilepsy is mainly diagnosed clinically. So if you have infantile spasm, it is infantile spasm. You may have subtle incomplete spasms, like your flexor, you may have extensor as well. The EEG or the finding you are trying to find out is a hypsarrhythmia and the EEG. That is to have an electroclinical diagnosis of West syndrome. It doesn't mean that the child doesn't have spasm. Is a type of seizure. It can happen on its own. It doesn't need to be a part of West syndrome. The treatment help. If it is very difficult, ACTH is the drug of choice.
So can we try with steroids or we should directly get into the...
For ACTH, for the infantile spasm, you have to be aggressive with treatment initially. You don't waste time on... When the disease sets in, it is very difficult to eradicate. So if you hit it hard at the beginning with ACTH and then you follow it up with steroid, you have a better resolution.
Okay, sir. Thank you, sir.
Sir, if a child is already taking levetiracetam and now it presents with the breakthrough seizure, sir, now how we should treat, sir? Either we have to load again levetiracetam or any other?
If the child is already on levetiracetam, you don't need to load it with levetiracetam. You can use good old phenobarbital or phenytoin, or you can use even sodium alpurate. If they're having a breakthrough seizure, you need to go back to the history to see whether the child is having what type of seizure. Compliance is the main thing, and what dose they are giving. Suboptimal dose. So dose is 40 to 60 milligram per kg per day. Most often they will be around 20 to 30.
The child is already on tablet phenytoin, sir. Now it presents with status.
Tablet phenytoin.
Yes, sir.
Yeah.
Now we should load phenytoin as loading dose or
Gardinal. Phenobarbital.
loading. We can give a loading or a half loading, sir.
You can give loading. Yeah.
Loading itself.
Why you are worried about loading, half loading?
Phenytoin, can we give phenytoin, sir?
Already if the child is on phenytoin, the pharmacokinetics is first order kinetics. Once it reaches the threshold, it will be there. Even if we give more and more, it will be flat. It is not a second order kinetics.
So we have to change.
So you have to change the.
Sir, one question. How to stop AEDs?
If the child is completely seizure free for 2 years, reduce it over a period of 6 weeks to 2 months, like 20% down. We need having it's a very difficult epilepsy, or if it is symptomatic epilepsy, if there is underlying background, then leave it for 3 years. If it is a juvenile myoclonic or juvenile absence, it is a lifelong treatment.
Okay, sir. Thank you. Any more questions from audience?
கஷ்டமானதை கேட்டுறாதீங்க. Absolutely not. Only thing is levetiracetam bit safer for girl children. That is the only reason we use levetiracetam. Otherwise, carbamazepine is good enough. It can control almost all type of epilepsy at the right dose.
Sir, if a child is due to levetiracetam, but seizure is controlling, is there any other choice?
We can switch into something else, sodium alpurate or lamotrigine, depending on the type of seizure. We have the choice of first line, second line. Usually levetiracetam very rarely produce behavioral issues. It does, but it's very rare.
Sir, in
compared
adults,
to sodium alpurate.
Okay, in adults they are using other drugs like Biracetam, newer drugs compared to.
It's a fancy thing, they will use it, you don't need to.
Thank you, sir.
Okay, with this we conclude this
session. Now I request Dr. of Thoothukudi Medical College to honor our speaker, senior pediatric neurologist Dr. Nandakumar sir with a memento. I request our chief Dr. Babita ma'am to join in hands. I request Dr. Nandakumar sir to honor our chairperson, Dr. Babita ma'am with a memento. I request our chief Dr. Babita ma'am to honor senior neurologist Dr. Kannan sir with a memento. Thank you, sir and ma'am. Moving on to the next session. I hope all the UG guys out here got a dopamine shot from this pediatric epilepsy topic. Next is a topic from a great orator of our Thoothukudi Medical College. It's about decaying daily skin disorders. From speaker Dr. J. Tades sir, HOD Department of Dermatology. This topic is a useful topic for all the undergraduate students. Our Tades sir always used to say that the best tool the dermatologist used to have is their eyes. Eyes is the best tool through which a dermatologist can reach heights. A living example for such a quote is our HOD sir. So hope this session is the final and will be the CME. I request our speaker Dr. Tades sir for this session. Will be Dr. Elango sir, retired HOD Department of Medicine, Dr. Pediatrics. Dr. Muthuraman sir, Senior Pediatrician, to the dais.
Good afternoon, one and all, and good afternoon, sir. Happy to see so many persons in the last session. And dermatology, it is the ever-needed topic, whichever specialty you are practicing. And skin lesions are the external markers of internal health, and we'll be able to get a lot of clues for our diagnosis just by visualizing the skin lesions. And I was eagerly waiting for this topic, especially Dr. Tadayu sir, who is a well-known speaker, and I handed over the mic to him.
Thank you, madam. Thank you for the nice introduction. I don't know whether I'm good or bad, but dermatology actually is, nowadays it is becoming a better field, visual field. Okay. So decoding daily dermatosis. So we see a lot of skin diseases, and most of the time it is getting confused. What is this fungus? Whatever it is always confusing. So I'll try to make it a bit clear. Okay. So what is the main thing here is that children may not always have the words to express their discomfort. Okay, they will not be able to tell. But it will be complicated by the history of the parents and grandparents. Poochi kadichichu sir, sopa mathi potan sir, pudu chetta potan sir. No, you will not be able to decode anything. But the skin often tells you the story. So silently listen to the skin while the patient gives the history. So I contradict with Nandakumar that history tells everything. For me, it doesn't tell anything. Only my eyes tell, and only the skin teaches me everything. And listen to what the skin speaks. That will tell you the diagnosis. So first we'll see about the neonatal rashes. So neonatal rashes, most of the time they are harmless, and they are toxic by appearance and toxic to the parents but not to the physician. So not to the child also, right? So likewise we have some neonatal rashes, transient neonatal pustular melanosis, miliaria, like that. One by one we will see. So erythema toxicum neonatorum. So this usually happens by second day or third day of birth, and it subsides within 3 to 4 weeks. So usually you see some or pustules, but the skin is angry looking. You can see the severe erythema in this child, but the child will be asymptomatic. It will not be disturbed, it will feed properly, it will be active. So it gives the appearance of a flea-bitten appearance, or a papule surrounded by sea of erythema. So this classically this appearance, but child will not be toxic. And the classical thing to differentiate it from other dermatosis is that palms and soles are usually spared in this condition. And usually it resolves within 2 to 3 weeks, and no need for any treatment, just requires reassurance. And to apply any plant-based medication. Immediately, they will do. So that should not be done for these patients. And second is transient neonatal pustular melanosis. This happens 1 or 2 weeks later, and you can see small pustular lesions in the skin. It will be discrete, and it will be haphazardly distributed here. Be typically involved in such patients, and it will be of pustules. The skin will be not inflamed. It will be very normal looking, and it will rupture, it will crust, and it will heal with the post-inflammatory hyperpigmentation. This also resolves with neonatal pustular melanosis. No need for any treatment for these conditions. And next is milia. So milia is nothing but a retention keratin cyst. The hair follicles, everything is immature to produce milia. This is not miliaria. Miliaria is verkuru. This is milia. This is also very transient. Usually it will subside within 3 to 4 months. No need for any treatment, no need to panic also. Then neonatal acne. So this typically, the distribution will be in the malar area of the face. And typically, there won't be any comedones. So comedones are classical thing in acne. In neonatal acne, it will be absent. In infantile acne, comedones will be present. If acne is present in infants, you have to think in terms of a hyperandrogenic syndrome, right? So this is because of the maternal hormones circulating in the child will produce. It will last for up to 3 months. Here again, it will subside of its own without any post-inflammatory changes or scar, unless and otherwise you don't disturb. So these are the conditions which you should not treat. You should just reassure the patient. Patient satisfy agave matanga. Idha ointment bodu, syrup bodu. So your oral treatment will not work here. But apply anything, it will subside spontaneously, right? And next is miliaria. So this miliaria is a sweat retention syndrome, wherein it occurs because of the sweat gland or sweat duct obstruction at various levels. So this commonly seen in infants, especially in incubator, when there is high humidity. So that causes miliaria, fever, and overbundling and tight garments also will produce miliaria. This also doesn't require any treatment. The child will be happy. It will not be symptomatic. It will subside within 3 to 4 weeks of its own. And seborrheic dermatitis, this is otherwise called as cradle cap. So here again, it is due to early colonization of the disease infection. This again doesn't warrant any treatment. If it is highly symptomatic, you can go for an antifungal, preferably azole group, clotrimazole, ketoconazole, luliconazole, like that. You can give topically, you can give for 2 to 3 weeks, it will subside. But that too is not required, because children's skin are more prone for absorbing drugs, and especially scalp skin has a lot of blood supply and it will get absorbed and it can cause toxicity. So this again, if left untreated, it will subside. So one thing is that you should not apply vegetable oil for this skin. எப்பவுமே ஸ்கின்ல ப்ராப்ளம் வந்தா தேங்காய் எண்ணெய் போடு அப்படிம்பாங்க. So don't apply தேங்காய் எண்ணெய் or any vegetable oil, because vegetable oil contains a lot of lipid material. These lipids are the substrate for Pityrosporum species. It will get aggravated. So don't apply coconut oil for scalp, especially in infants. So actually this also doesn't require any action, otherwise it is symptomatic. So all these conditions are normal in a child and it will subside spontaneously without any treatment. So what are the red flags when such sort of lesions develop? How to differentiate from serious illness? The bleeding into the skin, it is a serious disease. Okay. And vesiculobullous eruptions. So vesiculobullous eruptions in infants, anybody can tell what are the conditions? So it can be seen in congenital syphilis or a child born to a SLE parents. These are the two conditions will produce bullous eruptions in a child. So that has to be given a lot of importance. And if it is associated with systemic symptoms, especially poor feeding, lethargy, poor activity, and fever, that importance. And persistent or worsening of the lesions or aggravation of the lesions beyond the expected time of healing, that also you should give importance. This is also important. So these are the red flags. If these are absent, you can just manage this case by your words only. And we can how to decode. So first we'll see what are the red rashes. So red rashes is reddening of the skin. It can be due to increased perfusion. That you call it as erythema. So how to differentiate? You press it with the slide. So the pressing of with the slide is called the diascopy. Periya scope la ondum kediyadhu. So only the glass slide you call it as a diascope. You press it, it will blanch. It is erythema. If it doesn't blanch, it is purpura. So this is because of increased perfusion. That is because of extravasation of blood into the skin. So that's how you have to differentiate. And in children, erythema. So this is angiomatous nevi. This will subside spontaneously. Usually within 1.5 years it will subside. And that is a port wine stain. So port wine stain will not subside and it will be associated with serious internal complications, especially cerebral and liver. Like that you can have angiomatous malformations you can have. And purpura, so red rash, bleeding into the skin, we have two types of purpura. One is non-palpable, you feel it. If it is not elevated, you will not be able to feel it. So that is due to thrombocytopenia or bleeding disorders or coagulation factor deficiency like that. So that is non-palpable. If it is palpable, it is due to vasculitis. So this is how we have to differentiate. So non-palpable purpura, you have to look for bleeding disorders, and palpable purpura, you have to look in for vasculitic causes. Okay. Then the hypopigmented macule. So hypopigmented macule, we have a lot of hypopigmented macules which we will decode. So first is tinea versicolor. What age tinea versicolor can happen? It can happen from infancy to adulthood. So no age is spared. Because in infancy there is excess seborrhea because of the maternal androgens, which are hormones which are circulating in the child's stream. So that is an for Petrosporum species, and it can produce tinea versicolor. How to identify this tinea versicolor? The macule will be very well defined. You can see as though the definition will be as though it is marked by a pencil. And when you just scale it, scrap it with a glass slide, you can see hair-like scales will be there. Okay, and it will be distributed in the seborrheic areas of midline of the trunk and chest. It will be there. So that's how you have to diagnose, and treatment is very simple. It's for 3 weeks. Don't go for any systemic antifungals, topical antifungals, especially azole group of antibacterials will be sufficient. So azole group we can give ketoconazole and luliconazole. They are highly effective against Petrosporum species. Nowadays ketoconazole is gradually showing less activity. Why? Because they have started using ketoconazole soap. So ketoconazole soap actually gives a suboptimal or a subpharmacological or a sub resistance. So ketoconazole is nowadays not highly effective in tinea versicolor. And this hypopigmented macule, you can see the definition is not clear. The macule is there. You can, if you trace the borders, you will not be able to identify. And when you scale it to the glass slide, you can tavidu mari varum. It will be easily coming out. Tavidu mari varum. Seriya? So this is a patient will tell, sir, mutham koduthu vandiruchu sir adima. Adupra poochi irukkan because of all these things. It is a normal condition, and it's said to be at the early stage of this will progress to typical atopic dermatitis. It doesn't most of the time. Required is just reassurance. If you want, you can go for, if it is erythematous and inflammatory, you can go for mild topical steroids. So in phase or desonide. So don't use any other topical steroids on the face. It will cause problems. And next is a very important hypopigmented patch is Hansen's disease. So this Hansen's disease, how will you diagnose? So by the border. The border will be very clearly defined, and border, it is elevated. Pigmented. When you see very closely, it will give a coppery hue. So this coppery hue will tell the diagnosis of Hansen's disease. Confirm it by testing hypoesthesia. Can you test hypoesthesia in a child? If you bring anything, not crying, so you cannot test. So feel it with the dorsum of your fingers. You feel the patch. If it is warm than the normal skin, there is a neurological deficit. This disease affects the peripheral nerves and the appendages. So thereby the appendages will be lost. Here the hair will be lost, sweat gland will be lost, and it will not be chill. It will be warm. That's how you have to identify the disease, and you have to treat accordingly. And you can look for nerve thickening. Most of the time it will not be present in children. And next hypopigmented patch is a hypopigmented nevus. So this is a large hypopigmented nevus. Most of the time it will be segmental. It will be present since birth. Okay. So this actually doesn't warrant any treatment. How to identify clinically without asking history? So patient so look the borders. It will be serrated. Any serrated lesion in the skin is always congenital. So that's the teaching. And when the hypopigmented patch looks like an ash leaf macule, so you can see the ash leaf, hypopigmented macule. in the trunk and it is horizontal. So this be a telltale story of Ashleaf macule, tuberous sclerosis. Marker for tuberous sclerosis. Actually, this also doesn't warrant any treatment, and you have to look for systemic problems. Then vitiligo. So how to differentiate from other hypopigmented patches? It is depigmented. Of skin, we have very few conditions, and the common and most common condition is vitiligo. Okay, so this it will be asymptomatic and it will be progressive in nature. This is segmental. Diagnose vitiligo. Then itchy eruptions. What are the itchy eruptions? How to decode itching? Urticaria. So the patient will come with hives, that is wheals. So the typical history will be ஊரல் இருக்கு தடிப்பா வருது கொஞ்ச நேரத்துல மறைஞ்சிருது. If the lesions are not subsiding within 24 hours, it is not urticaria. There is a vasculitis component. So urticaria should subside within 24 hours. This history is important. So how will you manage? Usual protocol treatment la you have to give சரியா, not indicated. You leave it, it will become all right. If it is highly symptomatic, you go for antihistamines. Antihistamines are the first line of treatment for urticaria. So how much antihistamine you give? You give the regular dose. If it is not responding, you double it, you can triple it. If it is not responding, after tripling the dosage, add one more antihistamine. Okay, that can be done. And mask much effect in urticaria. And next is papular urticaria. This has nothing to do with urticaria. This is an insect bite reaction, commonly mosquito bites. Okay, so how to differentiate? There will be excoriated papulovesicular eruptions in the exposed areas of the body. So just pull out the sleeves, you can see the skin will be normal. Above the trousers or skirts, it will be normal. It will be there in the exposed areas of the skin. So that typically the patient will be suffering from mosquito bites. That you have to advise and avoid mosquito bites, and treatment will be with topical steroids and antihistamines. And most of the cases of papular urticaria will subside within a period of, within 6 or 7 years it will subside, it will not be recurrent. And next itchy condition is scabies. So the typical lesion in scabies in an infant will be palms and soles. So most brought to the clinic with history of papular lesions. Most of the time the children will not be able to scratch. When the scratch response develops, itching, scratching, typical itch scratch cycle, minimum 3 months. So before that the child will not scratch. So the typical history you have to ask is whether itching is there in the family members. That means it is confirmed. And bit older children, you look for the web spaces. Typically genital involvement will be there. Any itchy eruption in the genitalia, male genitalia, is always scabies. And similarly in adolescent girls, typical lesions will be in the nipple and area. Eczematous eruption, which is bilateral in the nipple area, it is scabies. Look for scabies and other signs of scabies and ask for history, you will be correct. So what drug you have to give? So in infants it is you give sulfur ointment. It is a messy application. It is very difficult to apply. You cannot give ivermectin in children less than 3 years of age also. You can give permethrin. Permethrin is not supposed to be used less than 1 year of age. Effective and least toxic. So whole body application of permethrin will be sufficient. Single application will be sufficient. Okay. Clear the disease, and you can support with antihistamines and treat the family members or contact members also. So this is a itchy condition which is not common in our place, but it's not rare also. It can be seen, but like in Western countries or other countries, you will see a lot of conditions. Atopic dermatitis is very common. 1 in 5 child will be having an atopic dermatitis, but it's very less common in our place. So the child will be keeping on scratching. Sorry, this scratching actually will not be limited to the child as such. So if you put your hand, so that is because the itching is so intense that anything the child will scratch. So that is a very important thing. And infantile atopic dermatitis, most of the time the cheeks will be involved. In childhood atopic dermatitis, the lesions will be there in the extensor aspect of extremities, below the knees and both below the elbows it will be there. And later childhood or adulthood, the lesions will be there in the flexural areas, fossa, groins, and in the axilla also. The lesions will be there. So this is atopic dermatitis. Here again, treatment must give an anti-streptococcal antibacterial, because most of the time this is precipitated and perpetuated by staphylococcal antigens. So give an full course of anti-streptococcal antibiotic and then go for emollients or any moisturizers you can use. If it is not responding, you steroid. So don't use a potent topical steroid, go for a mild topical steroid, because when you are going to use the topical steroids for this patient, it has to be used for a very prolonged period of time. If you are going to give a potent steroid, it will cause atrophy and other complications of topical steroid. And most of the time this atopic dermatitis also will remit within a period of 6 or 7 years before attaining older childhood. The next itchy condition is dermatophytosis. So this is a it is a pandemic now. So we speak about COVID and other things, but this is a pandemic. It is a pandemic of recalcitrant dermatophytosis. It will be progressing. And the typical lesion will be a well circumscribed irregular macule, erythematous macule with scaling, and you can see some excoriated papulovesicular eruptions in the. This is the typical appearance of dermatophytosis. So how to manage? Thing is that you have to educate first. So don't share your dress, linen or beddings. That is a very important thing. Otherwise, and it will be resistant. Then you have to go for children, especially less than 6 years, no need for any oral antifungal. Go for topicals. Lot of topical antifungals are available. You can use that. So if it is resistant to topical antifungals, you can go for systemic therapy. For children systemic therapy, you can use fluconazole, you can use grisophylline. Don't use ketoconazole, okay, orally. And how long you should treat? The treatment should be 2 weeks beyond clinical cure. So previous teaching is that you give for 4 to 6 weeks, it will become all right. Now continue giving. If there is a response, keep continuing the antifungal till it subsides fully. Beyond clinical cure. Why this 2 weeks beyond clinical cure? When you give an antifungal, the fungus will go for a spore formation, and it will be hatching in another 1 or 2 weeks. Within 2 weeks it will finish hatching. So these organisms which are going to hatch again after healing will be solved by the antifungal. So treatment is 2 weeks beyond clinical cure. Then habitual. So this habitual. So usually most of the scalp and genitals. So these are the common. The patient kutturuvaanga. So thalaiya chorinjikitte irukanga, genitals chorinjitte irukanga. So you have to modify the habit and you have to educate the parents. That's what. So here this is an habitual itching. You can see a lichenified plaque in the neck. Okay. So it doesn't fit into any of the dermatosis. So we made the patient stand for some time and he started doing like this. So this is habituation. Because of the friction, it has caused lichenification. Behavioral modification, and for this you can go for since it is lichenified, you can go for a mid-potent steroid with salicylic acid. Asymptomatic eruptions. Most of the time asymptomatic eruptions are not so serious. Okay. So you can few enumerated lesions, viral warts. So how to identify a viral wart? It is a verrucous papule. Touch it. It will not spread by just touching. Rough verrucous hyperkeratotic papule, and the surface will be thrown into folds. That is, it will be giving an appearance of a cauliflower appearance. So if left untreated, it will resolve within 12 to 18 months. Spontaneous resolution. Active management of the electrocautery, cryocautery, and other lasers and what can produce a scar. So first try topical preparations and observe the patient and advise the patient not to scratch, it will resolve. And similarly, the next condition is molluscum contagiosum. So the typical lesion is an umbilicated papule. You can see the small dimple in the summit of the papule. So that's how you have to you can reissue the patient and go for topicals alone. This again resolves within 18 months. And if the lesions are there in the eyelids, you have to treat some or other because it can produce keratitis. So this is viral warts and molluscum contagiosum. And next is angiofibroma. So previously you used to call it as adenoma sebaceum, and this has nothing to do with the sebaceous gland or or a tumor. So this is just a blood vessel with the proliferation of fibrous tissue. So that's why you call it as angiofibroma. This is a part and parcel of tuberous sclerosis. So this usually occurs after 6 weeks. 6 years of birth. This can happen. So if such lesions are there, you have to look for other skin signs. Say for example, periangular macule, Sjogren patch, other thing, and the patient will be having epilepsy and learning disabilities. And next is phrenoderma. So phrenoderma is again an asymptomatic papillary lesion, spiny papillary lesions, especially over the bony prominences. Okay. So this is vitamin A and essential fatty acid deficiency. A dietary correction and therapeutic supplementation will be sufficient. So if it is left untreated, it can lead to other complications in the eye and GIT. So, and this condition is called lichen spinulosis. Whether it is clear, you are able to appreciate. You can see some spiny papillary lesions in the circumscribed area. You are able to appreciate. So most of the time the patients, children will be brought with such sort of lesions. Okay. So this is normal. No need to treat. It's called lichen spinulosis. As long as this papules are pointed, it is normal. If it is flat, if such a lesion is flat, it can be a marker for internal tuberculosis. We call it as lichen scrofulosum. So whenever such a child is brought, you look for the morphology of the lesion. If it is pointed, you reassure and send the patient. And if it is flat, dome-shaped or flat, it is lichen scrofulosum, that you have to investigate. So that is one another child with the extensive phrenoderma. Then the So hyperpigmented macules. So here I have a lot of hyperpigmented macules are there. So I have brought only 2 clinically important things. Eruption and other one is scapulae macule. So this is fixed drug eruption. So the patient will be presenting to you with the acute onset erythematous rash with central hyperpigmented and necrotic skin. So this is fixed drug eruption. Every time it will recur at the same site. So patient geta matra chaptiyama chapdala. So this will be the history. அதுக்கப்புறம் நீங்க கொஞ்சம் क्वेश्चन எக்ஸ்டெண்ட் பண்ணி இன்ஜெக்ஷன் போட்டியா சிரப் குடிச்சியா அப்படிலாம் கேட்கணும். So கேட்டதான் they will tell. Most of the time they will not be telling also. So this is fixed drug eruption. It is classical. Morphology is very classical. The common site of presentation will be the lips, genitals and in the face. And next is scapulae macule. This is again a congenital lesion. As I already told you, congenital lesions, the border will be serrated. You can see the serrations. So this serrated. So this is scapulae macules. If extensive expect neurofibromatosis. So this will have not in the childhood. Then vesicular eruption. So this is common and it is confusing also. The child newborn baby with the blistering of the pressure areas or frictional areas. So that is it's a mechanobullous disorder. When you traumatize the skin or when you offer friction to the skin, it will blister because there is absence of. In simplex, desmosomes are absent. In junctionalis, hemidesmosomes are absent. In dystrophica, type 7 collagen is absent. So this is will be present in the sites of trauma and pressure and friction areas. So you can see the blistering. And this requires genetic counseling and treatment is just symptomatic, prevention. So that is impetigo. So this is a very common condition in clinical practice. And how to identify? Short duration, typical lesions, erosions with purulent crust. Okay. If it is due to Staphylococcus. If it is confluent, it is due to Streptococcus. You can decide the antibacterials accordingly. Okay. And personal hygiene is very much important for this. Most of the time the patients or parents will not be bathing the child. தண்ணி பட்டா அதிகமாயிரும், தண்ணி படக்கூடாதுன்னு வச்சிட்டு இருப்பாங்க. So that you have to advise. That is must. And next is varicella. So most of the time varicella nowadays it is almost misdiagnosed or left undiagnosed. So how to diagnose this? So you can see a typical lesion. You see the lesion on the back. One lesion will be sufficient. Okay. So you can see a clear fluid. Erythema surrounding that. So that is called the rose petal. Nama skin ku rose petal la theriyadu. You can see the erythema alone. Okay. That is a typical lesion. Pearl-like lesion. Okay. Where is the finding theriyada? So this finding we have been observing, and it is not mentioned with the textbook, and most of the parties will be telling you this. You can see dimple or a puncture like thing in the center of the papule. That is called the muttu with the kuttu. So that is partish version. Easily you can diagnose. If you identify such a lesion, in molluscum contagiosum it will be solid lesion. Here it is a vesicular eruption, fluid filled. So that is the muttu with the kuttu. So that you can typically identify. And the lesion will be dome shaped or spherical. Okay. This is varicella. So you have to treat varicella within 2 days. Otherwise it will not be effective. Right. Mouth disease. It is transmitted fecal-orally by Coxsackie A16. Other virus, enterovirus 71. Right. So this enterovirus 71 will cause a serious disease. Coxsackie virus will be causing a less serious disease. So the typical lesion can differentiate these two things. Here it is spherical. There the lesion is oval and it is non-inflammatory. So that's how you have to identify. And typically hand, foot, mouth disease, though it is hand, foot and mouth, the typical lesions will be over the bony prominences, joints, and in the gluteal region. And palms and soles will be involved. Okay. So typically you can identify, and most of the time the patient will complain of 1 day fever and the fever will subside, and by 7 to 10 days these lesions also will be subsiding. Okay. So this is because of fecal-oral transmission. You have to ask the patient to boil the water and drink. So normal your bleachers, chlorine and other things, it will not kill this virus. Even it can pass through the filters also. And next is beetle dermatitis. So you can see the blistered beetle dermatitis. So this commonly is seen in people in villages where there is lot of weeds surrounding their thing. So this will be looking like as though it has been splashed with an acid. So this is called acid fly, or so it's a common disease or a pattern in our part of the city. Okay, most of them, what you have to do is wash with soap and water and go for topical steroid application, mid-potent topical steroid, and analgesic antihistamines will be sufficient, and after 3 to 4 days it will become alright. And that is another serious vesicular eruption. When a vesicular eruption involves the mucocutaneous junction, it is always serious, and most of the time it is due to drug eruption, Stevens-Johnson syndrome, right? Stevens-Johnson syndrome, and the patient has to be treated just to make vesicles. Next is generalized exfoliation. So generalized exfoliation, for pediatric purpose we have 3 conditions. Generalized exfoliation, you call it as erythroderma. A lot of diagnoses are there, but knowledge about these 3 conditions. So the first one is a flaky paint dermatitis. Okay, so you can see the lethargic child with the edema of the face, edema of the feet, and the peeling of the skin as though it is peeling off from a old painted wood. Okay, so it will be the boat ship ullam pathina idu theriyum, the paint urinja madiri theriyum. This is a typical thing. The child will be lethargic. Adha mukkiyam. Seriya, it will not suffer from any symptoms. Adi sorva ukandittirukum, and the typical lesion is this. So this is flaky paint dermatitis. This is due to deficiency of protein, right? So this is a painful condition. The child will be disturbed. Okay. So what you see is, you see the child is crying when you lift the child. Most of the time when you lift the child, the cry will stop. Whereas this condition, when you lift the child, it will cry. It will be comfortable on lying down. Why? Because of skin tenderness. When you touch, it will be tender. So that's why it is crying. So when you lift the child, it will start crying, and you will see a diffuse exfoliation of the skin. Skin tenderness will be there. When you just put your finger, and very mild pressure will be sufficient enough to peel the skin. That's called Nichols case sign. Okay. So this is because of staphylococcal scalded skin syndrome. So it is a more than antibiotic. What you need is hydration. Okay. What you need is hydration, right? And antibacterial is also required. And third one is acrodermatitis enteropathica. So acrodermatitis enteropathica, again it is an exfoliation of the skin. Generalized exfoliation will be there. How to diagnose is that around the eyes, around the anus. If periorificial exfoliation is there, it is due to zinc deficiency or zinc binding ligand deficiency, that is acrodermatitis enteropathica. Replacement is required. So this we can talk on. So I have made it bit simple. So petechial and purpuric rash, this is very serious. So most of the time it is caused by rickettsial. Okay. So next is erythema multiforme like. So usually it is due to, most of the time it is due to drug eruptions and herpes simplex virus infection. And urticaria, urticarial vasculitis are common manifestation of any viral infection. Okay. Any viral infection can produce urticaria and vasculitis. Most of the time the patient will be giving a history of fever and urticaria. So most of the time the rash also will subside when the fever subsides. And third one is maculopapular eruption. This is a very, very common eruption. So for a viral infection, if you give penicillin or penicillin-like drugs, it will produce a rash. So commonly with measles, the child will be sick. And normal, usual viral fever or any viral fever can produce a eruption like this. So this is maculopapular eruption. And the typical thing is that it will then body, then extremities, and it will subside. So typically it will match that. So alarming signals in dermatology which warrants you to do investigation. And so as I already told you, it is purpura and petechiae. Okay. And systemic symptoms, a skin lesion with systemic symptoms is always you have to investigate, and persistent rapidly evolving lesions, worsening of the rash on treatment, you have to investigate, and unresponsive to standard diagnosis or look for serious conditions. Okay. And skin tenderness and necrosis is one dangerous sign in dermatology. So you have to manage this patient. When the skin tenderness is there, the patient has to be given utmost importance, and you have to manage in an ICU. So to conclude, skin is not only a mirror to the child's health. So it also opens a window through which you can see the interior of the system, right? And identification, at least suspecting the disease in the treatment of skin diseases. So thank you for your kind attention. Thank you. And Department of Dermatology extends our heartfelt felicitation to Dr. Kumaran. Fulfilling, joyful, and healthy retired life ahead. Thank you, sir.
Thank you, sir. Over to the chairpersons.
Thank you so much, sir. It was a very interesting and mind-blowing performance. Your collections is very good, and you gave us so many clues to easily diagnose also, sir. And cases of children with dandruff, apart from coconut oil, what other oil can we?
Actually, madam. So we can go for light liquid paraffin. Most of the coconut oil which is available at present is only light liquid paraffin with coconut oil flavor. Okay. So cooking grade coconut oil is different. So that is cooking grade coconut oil is different. So that oil you should not apply. And most of the oils, scented oils, are light liquid paraffin, and that it can be used. Gingerly oil or other oils, vegetable oil, don't use it on your scalp.
Okay,
So
sir.
thing is that coconut oil is, though it is, it is not suitable for the, it contains a very good conditioner. Cocosin is a very good conditioner, but thing is that for the lipid material in the coconut oil, it is a very good oil for the hair. So if you want to apply coconut oil, apply for the hair, not for the scalp.
Okay. So one more question, sir. We prescriptions using drug combination creams. Is it harmful or?
Actually, I will call it as illegitimate.
Okay, sir.
Illegitimate. Don't combine any, with the antibacterial, antifungal, and the thing. It will. First thing is that the patient will not recover. 100% it will not recover. Go to a knowledgeable person, and he will identify the disease, and he will treat with one ointment. He will become all right. So you are going to lose your name. Okay. Then the patient will start using. So what will happen? On the chronic use of topical steroids will lead to a lot of complications, from skin atrophy to striae, which are not reversible. So that's why we don't prefer combinations. There are a few conditions where you can prefer combinations with topical steroids. Say for example, an eczematous condition with an infection. So where it is given under cover of a systemic antibacterial. Combination of a topical steroid with an antibacterial or antifungal is not advised.
Thank you, sir. Any other questions?
Sir, one tough question for you.
Yes, sir.
You shall openly answer. What brand of kids soap?
Yes, sir. Very, very nice question, sir. Actually, I can answer this in a very nice way. So, what is the best soap? It is said that the best soap is the soap the patient can afford. Okay. Kid soaps are not kid soaps. They are only adult soaps which are branded as kid soaps. And nowadays they call it as Zindettes. Zindettes are, they call it as, that is also a soap material with the pH which is very close to that of the skin. The skin pH is around 5.6. Okay. So any soap which will 5.6 or bit useful. A soap with a pH which is crossing 5.6 is alkaline to the skin. So skin will not tolerate alkali. But otherwise also, if an alkaline soap, he has been acclimatized to that soap forever. So no need to change that way. So no need to change that soap. So the best soap is that the patient, that's depending upon the affordability of the patient.
So brilliantly you avoided a brand.
Thank you, sir. That was a fantastic session, enlightening all the UGs. Speaker Dr. J. Tadayus sir to honor our Chief Department of Pediatrics, Dr. Kavita ma'am, with a memento. I request Dr. Tadayus sir to honor Dr. Muthuraman sir with a memento. Thank you, sir and ma'am. குழல் இனிது யாழ் இனிது என்பர் தம் மக்கள் மழலை சொல் கேளாதவர். The sweetest thing a man can hear in his entire life is a melting voice of a child. Child's voice is not just giving the words, it's giving the strength to entire family, in turn to the society also. So building a nation full of prosperity and happiness is mainly in hands of a pediatrician. will be such an enlightening session for all the practicing pediatricians. More than all, this will be a tombstone of celebration of our legendary pediatrician, our beloved Deputy Superintendent, Dr. Kumaran sir. On this great occasion, I request our Chief, Dr. Naresh sir, to give away the vote of thanks as a final ending.
So, occasion. So here we are celebrating the superannuation of our beloved Deputy Superintendent Kumaran sir. So this pediatric pearls, I think, has been well organized and reached what it was planned for. So I think our UGs should have been benefited much with this discussion. I thank our administrative department, our dean, our vice president, vice principal, the medical superintendent sir, to have this function as a grand success. I thank my HOD, Dr. Professor Arnathan sir, to making this event a much grand success. My assistants, my PGs who had worked hard to make this event as a very grand success. I thank all the UGs who are present here, the CRRIs and the final year MBBS students of Thoothukudi Medical College who had arrived who had come over here, and without them the entire program would have not reached its goal. I thank the hotel administration for the hall and the food they have provided. I thank the audiovisual aid people and the people who are supporting us for the YouTube and the sponsors for this program as a very grand success. I thank one and all. Thank you.
Thank you, sir. Thank you, Anandal. Thank you. Now we request faculties, Department of Pediatrics and postgraduates, Department of Pediatrics to stay back for a group photo. For all our delegates, you can have your tea and snacks out there.
வாழ்க்கையை பின்னோக்கி நகர்த்த முடியாது, ஆனால் அதை தடுக்கலாம். உலகிலேயே இந்தியாவில் தான் அதிக எண்ணிக்கையிலான டைபாய்டு நோயாளிகள் உள்ளனர். இந்த நோய் குழந்தைகளுக்கு மட்டுமல்ல, யாருக்கு வேண்டுமானாலும் வரலாம். மக்கள் மாசுபட்ட உணவை உண்ணும் போது அல்லது தண்ணீரை குடிக்கும் போது சால்மோனெல்லா டைஃபி பாக்டீரியாக்கள் எளிதில் பரவும். நீங்கள் நினைப்பீர்கள், அட காய்ச்சல் தானே, ஆனால் சிகிச்சை அளிக்கப்படாவிட்டால் அது மற்ற உறுப்புகளை சேதப்படுத்தும். நல்ல செய்தி என்னவென்றால், தடுப்பூசி போடுவதன் மூலம் டைபாய்டை தடுக்கலாம். அது நம்மையும் நம் அன்புக்குரியவர்களையும் நோயிலிருந்து பாதுகாப்பு. சுகாதார நெறிமுறைகளை கடைபிடிப்பதன் மூலமும் சுகாதாரமற்ற மேற்பரப்புகளை தொட்ட பிறகு கைகளை கழுவுவதாலும் மற்றும் நீங்கள் வெளிநாட்டு மற்றும் உள்நாட்டு பயணங்களுக்கு முன் டைபாய்டு வேக்சினேஷன் எடுத்துக்கொள்வதன் மூலமும் தடுக்கலாம். எனவே முன்கூட்டியே தடுப்பூசி போட உங்கள் மருத்துவரை அணுகவும். மறந்து விடாதீர்கள், இது ஒரு சாதாரண நோய் அல்ல. டைபாய்டை பற்றிய விழிப்புணர்வு மிகவும் அவசியம்.